Yes, ma'am. Let me start the recording.
This meeting is being recorded.
Okay. Hi, good afternoon, everybody. So today we'll be continuing with the further airway and mechanical ventilation parts of the respiratory system. So unfortunately, due to the paucity of time, we have a lot left. So I've tried to cut short a few topics which are not really theoretically important and more important from the practical point of view. Uh, so as much as as much as possible, I'll try to finish this off today. And if at all you feel you have some doubts in the respiratory system, airway ventilation, and you want some help with any specific part, you can put it up on the group. If possible, I might just upload small PDF notes for you to read in the exam. During the course, we'll go through waterfall concept also, yes, again, because I think somebody had a doubt yesterday on what exactly the waterfall phenomenon was, and we had really been in a rush on the other day while discussing the same. So we'll do that also today. So for today's topics, we'll first cover airway and then we'll go to some physiological parts of mechanical ventilation and some theoretical questions of mechanical ventilation. So coming to airway, it's a potential paper one question is the anatomy. So I've put up two diagrams over here. The first one is the airway anatomy of, the anatomy of a video laryngoscope, and the second one on the right is the anatomy of the larynx, which usually might be asked, trachea and larynx, which might be asked for as a part of tracheostomy or cricothyrotomy. So this you see on a daily basis. It won't be very difficult for you to recreate this diagram in the exam. You start with the base of the tongue, the epiglottis. You have the arytenoids, the airy epiglottic folds. You have your vocal cords, and through which you can see the tracheal rings on the either side of the base of the median glossoepiglottic fold over here are the vallecula. So this is your video laryngoscopy anatomy, and here comes the tracheal anatomy. So here you start with the hyoid bone. You have your thyrohyoid membrane, followed by your thyroid cartilage. Below that you will have a cricoid cartilage, and in between the two you have your cricothyroid membrane, and below that you have the trachea ultimately dividing into the right and left mean bronchus. So describing the tracheal anatomy. So what is it? It's a fibrocartilaginous tube that serves as a conduit between larynx and bronchi, allowing passage of air to and from the lungs. So you simply just draw this diagram over here. If you see, it has four layers. It's okay, starting from the innermost mucosa, submucosa, one cartilage which is C-shaped, and the adventitious layer. Here you draw the trachealis muscle connecting the two ends of this cartilage, and behind that you draw the esophagus. Okay, now while describing the answer, you describe each part of this diagram itself. So anterolaterally, what is it? It consists of these 16 to 20 tracheal cartilages. It's a hyaline cartilage. These cartilages are connected to each other by fibroelastic tissue. What do? They keep the trachea open during pressure changes that accompany ventilation. Then the next part you describe posteriorly. What is it? This is a fibromuscular wall. It is formed by the trachealis muscle. It makes the cartilages appear C-shaped. What does it do? It makes the trachea sufficiently flexible to allow expansion of this esophagus while swallowing. And then come the histological four layers. Mucosa, what type of mucosa it is? Pseudostratified ciliated columnar epithelium. The submucosa consists of connective tissues, glands, nerves, and vessels. It has a musculocartilage layer beyond that we've already seen, and adventitia. What are the functions of the trachea? Mainly is transportation of air. Second is humidification. It warms and moistens the air and protects the respiratory tract. Third is propels foreign particles. It's a ciliated mucosa. So what does it do? It propels foreign particles upwards towards the pharynx for expulsion, and the mucosa traps organisms before they enter the lungs. So this is the long and short of tracheal anatomy. What about the relations of the trachea? If you remember this one diagram, it will be easier for you to imagine what comes anteriorly, to the right, to the left, and posteriorly. So anteriorly, what all do you have? Ahead of the trachea, you have the arch of the aorta, the brachiocephalic trunk, and the left common carotid. Also, you have the sternohyoid muscle and the sternum. On the left side, if you see, the arch of the aorta continues on the left side of the trachea. Along with it, a part of the left common carotid and left subclavian artery comes. If you see posteriorly, it has the esophagus and the vertebral column. And on the right side, it has the right lung pleura, the right vagus, azygous vein, and the superior vena cava. So these are the relations. Nerve supply. It gets its sensory nerve supply from the vagus and recurrent laryngeal nerves. Blood supply, upper two-third is given by the inferior thyroid arteries, and the lower one-third is supplied by the bronchial arteries. And about the drainage? Lymphatic drainage is by pretracheal and paratracheal and deep cervical lymph nodes. So now what is tracheostomy? Tracheostomy question will be asked on indications, contraindications, and complications. So that's how I've put up the answer. So tracheostomy is basically creating a opening in the anterior wall of the trachea to facilitate airway access and ventilation. So tracheotomy is used when you directly connect the trachea with the skin of the neck, and basically it provides a opening through which a tracheostomy tube can be placed. So indications in the exam, you might remember random indications. Just classify indications into three parts. One is for obstruction of the upper airway, impaired clearance of secretions, and prolonged ventilator support. So then under this, what all you remember, you can write. Under obstruction of the airway, you have foreign bodies, neoplasms, trauma, burns, infections like croup epiglottitis, Ludwig's angina, deep neck space infections, laryngeal dysfunction like vocal cord paralysis, and surgeries that involve the base of the tongue, hypopharynx, rigid fixation of the mandible, or congenital anomalies. Next is impaired clearance of secretions. Why would the secretions be impaired? So here you start right from the central nervous system, spinal cord, neuromuscular, and then other chronic aspiration risks. So under central nervous system, you can write bleed, strokes, hypoxic brain injury, or bulbar dysfunction, advanced Parkinson's. Spinal cord injuries, the ones which cause high cervical lesions, impairing the diaphragmatic and intercostal muscle function. Neuromuscular, myasthenia, GBS, motor neuron disease, all of that can again impair the ability to clear secretions. And prolonged ventilator support. So under this, you have all the reasons why you need ventilation for long term, such as a chronic lung disease, like severe COPD, ARDS, pneumonias that don't improve, severe chest trauma, neuromuscular weakness requiring prolonged ventilator support, like GBS, severe critical illness. So long-term sepsis, multi-organ failure can cause uh, uh, critical illness neuropathy, which can lead to prolonged ventilation support, and failed extubation trials. So if you categorize it in, just remember these three categories, it will be easier for you to write the answer. Obstruction of airway, impaired clearance of secretions, and need for prolonged ventilator support. Okay. What are the contraindications? So contraindications, absolute only if there's a cellulitis in the anterior neck or uncorrectable bleeding diathesis, like INR more than 2, platelets less than 50. Along with that, if there's any absence of a cervical drug, that's a congenital anomaly. On relative contraindications are only hemodynamic instability, that is also a relative contraindications. But what we do in the ICU is percutaneous tracheostomy. So particularly, there are certain relative contraindications to doing a percutaneous tracheostomy. What are these? this which you assess on a daily basis. One is morbid obesity, short neck, or inability to identify and palpate the trachea. Vascular structures, if you have a high riding in innominate or thyroid internal mammary artery, gross distortion of the neck either due to hematoma, tumor, thyromegaly, or any scarring, severe tracheomalacia, inability to safely extend the neck, like there's a cervical fusion, cervical spine fracture, rheumatoid arthritis, and prior complex tracheal surgery. So, all of these are specific relative contraindications to doing a percutaneous tracheostomy. Now, coming to the types of tracheostomy, you have a surgical tracheostomy and a percutaneous tracheostomy. So, I have just put it out in simple points like what is the technique? In surgical, you do an open dissection through the skin, subcutaneous tissue, the strap muscles, expose the trachea, and then insert the tube under a direct vision. What do you do in percutaneous? You just take a needle puncture, put in a guide wire, serially dilate it, and place the tube. Visualization, of course, will be better in surgical tracheostomy. So you have a better control of the anatomy. In percutaneous, visualization is not great. So that is why it's usually advised to be performed with a bronchoscopy guidance to prevent injury to the posterior wall. Indications, now surgical tracheostomy is more preferred in children or patients with a difficult neck anatomy. But percutaneous tracheostomy is usually preferred in an ICU patients with a normal neck anatomy, stable condition requiring prolonged ventilation. The complications both have similar complications, but bleeding occurs more commonly in surgical tracheostomy, and posterior wall injury, creation of a false passage, pneumothorax, and emphysema occur more commonly with percutaneous tracheostomy. Cosmesis wise, percutaneous tracheostomy is better because it's a smaller scar and cosmetically more acceptable. Amongst the percutaneous tracheostomies, what are the techniques that we use? One is the I'm sorry, this should have been Ciaglia. This is auto-corrected. Ciaglia, where there is sequential dilatation. Blue Rhino, where there's a single-stepped curved dilator. Griggs is basically a forceps, which allows blunt dilation. PRDT is percutaneous, rotational, and dilational tracheostomy. Then there are other methods described in the books. One is known as Fantini, which is a translaryngeal approach for fragile tracheal structures, and balloon dilatation, where a balloon catheter is used for dilation when especially fragile tracheal structure. Lastly, ultrasound guided. The first 24 hours early in daytime or tube displacement. You can create a pneumothorax, pneumomediastinum, emphysema, tracheal injury. Amongst the complications that you see the next day or in the first week of doing the tracheostomy is one is persistent bleeding, tube obstruction, atelectasis, wound infection, or tracheitis. In later stages, you'll see tracheomalacia, tracheal stenosis, and tracheoesophageal fistula. And long-term changes are voice changes and cosmetic changes. So this is a question asked previously, tracheostomy care in the ICU. So you know what are the things that you do in the ICU on a daily basis to look after the tracheostomy, but it's difficult to organize this properly in your answer. I've put it under 6 points. First is tube and stoma. So what you do for the stoma, what you do for the tube. Next is what you do for the airway ventilation. Then monitoring safety parameters, communication and nutrition for the patient, and lastly, weaning and decannulation. So what do you do to ensure that the tube remains patent? Regular suctioning. You give humidification via an HFNC to prevent drying and crusting. Regular cleaning and replacement of the inner cannula if it is present. And you secure fixation to prevent any accidental decannulation. So all of this is done for maintaining the tube. For the stoma, what all you do? It has to be cleaned daily, the stoma site, with an aseptic technique, and a sterile gauze dressing should be kept, which should be dry to prevent any infection or skin breakdown. And regularly, you should inspect for any infection, bleeding, or granulation tissue at the stoma site. So for airway and ventilation, so you have to ensure adequate oxygenation and ventilation via SpO2 and ABG. Prevent aspiration by ensuring that the cuff is inflated and the head of bed is elevated. What are the monitoring and safety parameters we use is check the cuff apparatus. These safety measures should always be there at the bedside in order to guide you in case of an emergency. Communication and nutrition. So you have to help the patient speak with the help of speaking valves or writing aids, and assess swallowing if the patient is able to swallow before initiating oral feed and also evaluate for the risk of aspiration. And finally, you should always check daily for readiness for decannulation. Uh, you can downsize, deflate the cuff, and introduce speaking valve as steps towards decannulation. Now, the next thing that we'll see today is cricothyrotomy. So, cricothyrotomy is basically an emergency surgical airway approach in which the physician makes an incision in the cricothyroid membrane and passes a cannula or a tracheal tube into the trachea in order to oxygenate and ventilate the patient. So we saw the anatomy, right? You have a thyroid cartilage, cricoid cartilage, and in between those two, you have a small membrane called the cricothyroid membrane. And if you approach the airway by creating an incision over here, then that procedure is called cricothyrotomy. What are the indications? This is only done in an emergency in case of a failed airway, like a CICO, or cannot intubate, cannot oxygenate situation, or if there is an upper airway obstruction like anaphylaxis, angioedema, maxillofacial trauma, foreign body burns. What are the contraindications? Usually, it is avoided in children less than 12 years. Even if it has to be done, needle technique is preferred. Or if there is a traumatic disruption of the laryngeal or trachea below the cords. Okay. So there are three types of leucothyrotomy. One is the surgical, second is the needle, and third is the cannula or Seldinger's technique. So first is the surgical or the scalpel leucothyrotomy. In the surgical technique, what all you need? You need a scalpel, number 10 blade, a bougie, and a tube, usually cuffed 6 millimeter internal diameter tube. So what do you do? First, you identify the cricothyroid membrane by palpation, or also known as the laryngeal handshake. Once you palpate the membrane, you make a incision through the cricothyroid membrane and just turn the blade 90 degrees quarterly. Okay. So, try to imagine the steps as we walk through it. You've made a horizontal stab, then you turn the blade down with the sharp end facing caudally. Now, in this opening that you've created, you slide the bougie into the trachea and railroad a 6 mm cuff into the trachea. You can inflate and confirm position. If you're not able to palpate the cricothyroid membrane, then you make a vertical incision. You make an 8 to 10 centimeter vertical incision. Use blunt dissection to separate the tissues, identify and stabilize the larynx, and then you continue it the same way like we did for the palpable membrane. Just make a stab incision into the membrane, turn the blade through 90 degrees with the sharp end caudally, and slide the bougie inside, and on that bougie that they have shown, it's
This meeting is being
they have
recorded.
put a a 7.5 ET tube adapter. Okay. So again, you palpate and identify the cricothyroid membrane similarly. And then what you do is you look at point number 4. Puncture the skin with your dominant hand and just above the cricothyroid membrane. Then you direct the needle caudally at a 30 to 45-degree angle. Then you aspirate, confirm you're in the right place. You've seen bubbles. Now you advance the catheter inside and you can remove the needle. Now you attach the second setup that you have placed over there, right? You attach the second setup and you can connect this to a high pressure oxygen source. So the problem with doing a needle cricothyrotomy, it's a very small, you have a very small cannula inserted into the airway. You to ventilate through this cannula, you need a high jet ventilator system. So usually if you use a simple IV cannula, the problem is it will kink or get dislodged. So there are certain specific cannulae with the three for doing a cricothyrotomy, which is there in the first diagram on top. These are known as the Patil, the CRECATH, and the Ravusin cricothyrotomy uh, catheters. So now through this cannula you can, it's a small opening, so you can oxygenate, but ventilation and CO2 clearance is poor. So you need a high pressure oxygen also to drive the gas into the lungs, and there are special jet ventilator devices available which is connected to your wall mount O2 or a cylinder in order to oxygenate the patient. So the disadvantage of giving such high jet ventilation is it can cause barotrauma, pneumothorax, and subcutaneous emphysema. So if you don't have such jet ventilators, the diagram below shows a setup of how it can be created in the through easily available equipment in the ICU. So in this diagram, if you see, if the sorry, my pointer is not working. Okay, in the diagram below, if you try and see, there is a IV cannula connected at one end. It is connected to a three-way. This three-way is connected to an IV set tubing. The other end of the IV set tubing, where the drip chamber is, that they have cut off. And instead of that, they have put an ET tube connector from a 5 tube. Okay. So now this connector you connect to the O2 device, and this IV cannula is the one that is inside the airway. So, with the help of the three-way, you can put your thumb and occlude the opening over there and give it and enhance the pressure that is delivered into the airway. So this is one simple technique at the bedside that can be done in order to oxygenate the patient through a needle cricothyrotomy through simple bedside available equipment. I've just put this because practical point of view, you never know when and what might come up, and you need to know this. So the other problems with this is there is no suction capacity available. There's no cuff, so it's not a protected airway. So always remember, cricothyrotomy is either way is a temporary airway. It is maximum half an hour, 45 minutes. It just gives you time till you establish a proper definitive airway access. And the last technique to do a cricothyrotomy is using a ready-made cricothyrotomy set known as a cannula cricothyrotomy, or where you use a Seldinger's technique. So similarly, here you have punctured the cricothyroid membrane. After puncturing it, you insert a guide wire. Over the guide wire, you have a dilator and a cricothyrotomy tube through which you enter the trachea. Once you have entered, you remove the dilator and the guide wire in one go. Okay, so the three techniques, of which surgical, basically it's a faster technique. You get a cuffed tube, you have a definitive airway. But yeah, there will be more bleeding trauma. In a needle technique, it is very fast, but it's only good for children, where the size of the airway is less. But again, here the CO2 clearance is not that good and it will cause barotrauma. And the last is the Seldinger's technique, where you put, it's a more controlled and a safer insertion, but it needs a ready-made kit. Okay, and the procedure might not be as fast, especially in an emergency. So these are the three techniques, their drawbacks and main advantages in one chart. So what are the complications of cricothyrotomy? Hemorrhage, if you injure vessels, of course, you can cause injury to the esophageal or the posterior tracheal wall. Misplacement can lead to subcutaneous emphysema. Aspiration, if you don't have a proper cuff tube. And long term, it can cause subglottic stenosis and voice changes. Now coming to the next topic is the RSI or rapid sequence induction. So rapid sequence induction is basically a method of achieving rapid control of the airway while minimizing the risk of regurgitation and aspiration or gastric content. So basically, it is a defined steps given how to go about with intubation in case of a patient with a full stomach. So uh, if it I put a small table of the history of how exactly it came into practice, where initially Dr. Joseph Mendelssohn in 1946 established the lethal effects of aspirating gastric contents. 1951, there was the introduction of succinylcholine. 61, Dr. Brian A. Selick, he first described the Selick's maneuver to apply pressure on the cricoid cartilage to prevent aspiration. And all of these things were combined into a formal protocol called the RSI technique in 1970 by Dr. Edwin Stept and Dr. Peter Safa. So when do you do an RSI? It is mainly for emergency airway control in patients at risk of aspiration. That is a full stomach or trauma, GI bleed, uh, or any hypoxemic or respiratory failure that needs immediate intubation and inability to protect the airway, such as low GCS and seizures. So what are the steps of the classical RSI that were described? First was pre-oxygenation with 100% oxygen to maximize oxygen stores. Then rapid induction with a predetermined dose of a rapidly acting anesthetic agent, followed by administration of a rapidly acting muscle relaxant such as succinylcholine. After this, there was application of cricoid pressure, a period of apnea with no positive pressure ventilation. So this was the classical RSI, in which there was said you don't give positive pressure ventilation during cricoid pressure, and then it go perform the tracheal intubation with a cuff tube. And once you've established that the tube is in place, that's when you remove the cricoid pressure. So these were the steps of the classical RSI. Modified RSI, now there have been multiple papers suggesting various modifications, but there's no universally standard single modification. Okay, so some of these modifications include maximizing maximal optimization of oxygen stores by assisted ventilation before intubation or apneic oxygenation via nasal bronchs. Then second is, instead of just giving a rapid induction of anesthetic agent, they would there are some modifications suggest doing a stepwise titration followed by paralysis with a rapidly acting agent. Third is application of cricoid pressure. From being an absolute recommendation, it's come down to advisable. So if it obscures the view of the laryngoscopy, then it you can release the pressure. And the fourth modification that has been studied is implementation of a pre-planned strategy in the event of a failure to intubate, which we will see ahead in our difficult airway algorithms. Contraindications, there are not many contraindications, but if you are anticipating a difficult airway, like in case of facial trauma with severe anatomical disruption, in that case, you who may not tolerate apnea very well because of profound hypoxemia. So there are four things that you need to look after while preparing the patient for intubation. First is prepare the patient. Second is prepare the equipment. Third is prepare for difficulty. And fourth is prepare the team. So in prepare the patient, what all do we do? We use a pulse oximetry. What all do we know? What all monitoring do we need? We need a pulse oximeter, we need BP, capnography, ECG. Ensure a proper position of the patient. In case of obese patients, they need ramping. In case of head injury, 30-degree head up. And in case of C-spine injury, they'll need a neck immobilization. Ensure a good IV access with fluid running and adequate pre-oxygenation. So all of this you have to do to your patient. What all equipment you need a proper O2 supply, airway, all the airway equipment that you need, face mask, airway adjuncts such as oropharyngeal, nasopharyngeal airways, self-inflating bag, laryngoscopes, appropriate sized ET tubes, bougie, stillet, suction, and whatever tape and tie you need to fix the tube. And drugs, whatever RSI drugs, vasopressors, and prolonged infusion for maintaining sedation paralysis. All of that should be ready. The third is to anticipate difficulty. So you need, what all do you need for anticipated difficulty? A video laryngoscope, an LMA, cricothyrotomy kit, difficult airway trolley, oxygenation plan in the event of failed intubation. And fourth and the last thing is to prepare team. That is, you confirm the roles before starting as to who is going to be the intubator, who will deliver the drugs, who will give the cricoid pressure, and who will do the inline stabilization wherever necessary. And always have a senior person accessible while doing such a procedure. So these four things, if you just remember the heads, you will be able to fill in what you do for the patient, what all equipment you need, difficulty anticipation, and team rules. So these four things are need to be assessed. So positioning, this so your sniffing position where there is flexion at the lower cervical level and extension at the atlanto-occipital joint, they recommend a 9 to 10 centimeter height headrest to achieve this. Your neck should be open and your external auditory meatus, suprasternal notch should be horizontal, and the glabular chin plane should be horizontal. So these are all the prerequisites for the sniffing position. Ramping, what you do is you multiple pulse if an achieve the auditory meatus and the sternal notch in a same plane. C-spine in holds the head such a between the mastoid process and the occiput. So so that the head is held in one neutral position, and you should resist any change or during manipulation while doing the laryngoscopy. Commonly used drugs, these their side effects, these you'll be able to write. Propofol need. Muscle relaxants, the ones recommended are only succinylcholine and rocuronium, and pharmacological adjuncts such as fentanyl, alafentanil, and these sure you will be able to write. Now, pre-oxygenation. About pre-oxygenation, replace the nitrogen that is forming the majority of the FRC with oxygen. And the main goal is to extend the safe apnea time. Okay. So, safe apnea time is the duration of time until a critical arterial desaturation below 88 to 90% occurs after cessation of breathing or giving the muscle relaxant. Healthy patient, safe apnea time is up to 8 minutes. But if you do not pre-oxygenate, it would be only 1 minute. So, at least three minutes of tidal breathing or 8 vital capacity breaths in 1 minute should be performed with an inspired oxygen concentration of 100%. Cricoid pressure. So the rationale of giving a cricoid pressure is to occlude the esophagus in between the cricoid and the vertebral body of C5, C6 so that there is no reflux aspiration of the gastric contents. So it is said that you start with a 10 Newton force, and then once the consciousness is lost, you increase the force to 30 Newtons. There's no way of knowing how much is 10 and how much is 30. And you keep the pressure maintained till the position of the tube is confirmed. But if at all there is any difficulty in laryngoscopy or if vomiting occurs, the cricoid pressure should be reduced or released. So a lot of controversies around the Selix maneuver that you the application of cricoid pressure displaced the esophagus laterally in 90% of the subjects. So instead of occluding, it actually displaced it. It worsened your Cormac-Lehan grade view during laryngoscopy, and there was no difference in the incidence of aspirations. Plus, reduced lower esophageal sphincter tone. It reduced the LES tone, so therefore it actually increased the risk of reflux, and the median intubation time was longer. So in most situations, it is not harmful, but and may be beneficial. It is specifically contraindicated in C-spine injury, anterior neck trauma, active vomiting, and if there is inadequate view of the cords in laryngoscopy. So what are the limitations of RSS? There is no ability to test mask ventilation since you are not doing any positive pressure ventilation. Later on, in a CICO condition, if you don't know whether your bag masking is adequate or not, risk of failed intubation, you have given the paralytic agent, so spontaneous breathing is lost. So if intubation fails, you need rescue operations. Hemodynamic instability may occur in critically ill patients. Aspiration risk is not fully eliminated. It has limited applicability in some patients, such as those who have profound hypoxemia or severe metabolic acidosis. They will not be able to tolerate even a brief apnea. uh, and drug related limitations, what all each drug has its own side effects, which is another limitation of the RSI, and it's not suitable for children. Now from RSI we move to difficult airway. So there are two definitions of difficult airway, one given by the American Society of Anesthesiologists, sorry, uh, which defines difficult airway as a situation that physiologist has difficulty with either face mask ventilation or tracheal intubation or both. So where it's specific in the American Society definition, it specifically mentions that it should be a trained anesthesiologist who's having difficulty with bag mask, tracheal intubation, or both. And in the Canadian Society, instead of anesthesiologist, they use the term experienced airway manager. And apart from face mask and tracheal intubation, if you're not able to put in a supraglottic airway or establish a emergency front of neck airway, that is when they define it as a difficult airway. So if any of these fail, not all, if any of these fail, then it is called a difficult airway. So the assessment. Now the assessment for a difficult airway is different in the ICU as compared to the OT. Over here, the recommended method is to use the Markocha score. So the Markocha score has been test validated for airway assessment in the ICU. So in the ICU, what is different is that there are other physiological problems apart from just simple airway anatomy problems that can make us airway establishment difficult. One is that, and second, also there are other operator related factors which also should be given due consideration, which have been included in this score for anticipating difficult airway. So what are the scores? M is for Malampatti grade 3 or 4. After M is A. Now A is apnea aware, okay? Obstructive sleep apnea. C is cervical spine limited mobility. O is mouth opening of less than 3 centimeter. Again, C is coma, and H is hypoxemia, also agitation less than 80%. And the last score is A, that is non-anesthesiologist. So it considers both pathology related problems and operator related problems while anticipating or assessing for a difficult airway. So total score is 12. It ranges from 0 being easy and 12 being very difficult. Anything less than more than 7 is a difficult airway as per the Markocha score. So just remember, I think the most confusing part is the second A. The second A is obstructive sleep apnea. That is the only part that confuses us. Otherwise, the mnemonic is very clear. So what are the drawbacks of the Markocha score? It has not been validated for video laryngoscopy and the sensitivity is only 73%. So I've just put in the other methods of airway assessment. One is your Malam Patti score, class 1 to 4. In class 1, where everything is visible from your uvula, fauces, soft palate, and pillars. In class 2, your pillars are not going to be visible. Class 3, only base of the uvula and soft palate is visible. And class 4, only the hard palate is visible. The Cormack-Lehan grading is also been mentioned over here for your laryngoscopic view. Grade A gives you a full view of the glottis. Grade Grade 1, sorry, grade 2 is A and B. A is part of the cords visible. B is only arytenoids or posterior origin of the cords visible. Grade 3 is only the epiglottis is visible, and grade 4 is no glottic structures are visible. Another method of assessment is your Lehmann airway assessment. In that you have L is for look externally for any facial trauma, large incisors, beard, mustache, large tongue. E is the evaluate the 3-3-2 rule. Your incisor distance of 3 finger breadths, hyomental distance of 3 finger breadths, and thyroid to mouth distance of 2 finger breadths. M is Malampati greater than equal to 3. O is obstruction, any condition like epiglottitis, peritonsillar obstruction, peritonsillar abscess, or trauma. And N is neck mobility. So now difficult airway management guideline, the classically explained difficult intubation guideline given by the Difficult Airway Society is your plan A, B, C, and D. Now, the problem with this is that it is not been it has been given mainly for your OR setup. Okay, so there is another guideline given by the IDA, which is specifically for tracheal intubation in ICU. So it does not explain difficult airway as A, B, C, D only. It also includes step 1, 2, 3, 4, 5. It so we'll go through that more in detail. So your step 1 is pre-oxygenation and induction of anesthesia. So what all is included over here is 2 persons are needed, of which one should be experienced. For optimizing pre-oxygenation, they recommend one of the two, either using an NIV or an HFNC. So remember, your RSI usually does not uh, just tell you to use positive pressure ventilation, or where you have NIV use or HFNC is to be used for pre-oxygenation. Second thing, induction, they recommend using either etomidate or ketamine with succinylcholine, and if it is contraindicated with rocuronium. They do recommend use of cricoid pressure and IPP, intermittent positive pressure ventilation, is to be used. Uh, so they say that using a gentle positive pressure ventilation might actually improve your oxygenation and help improve your apnea time without actually risking much of aspiration. So all of these are included in the algorithm for difficult airway management in ICU. Your step 2 is your laryngoscopy and tracheal intubation. So this is just like what is given in your DAS guidelines. So before that, what they say is, when you're doing your face mask ventilation, if it is successful, you go ahead and do laryngoscopy. If it is not successful, you do only a single attempt at laryngoscopy, provided your saturation is maintained above 95. So over here, you can use, they advise while doing laryngoscopy to continue nasal oxygen using oxygen flow at 15 liters per minute. Okay, so they recommend giving an apneic oxygen or using HFNC. Then you can use either direct or video laryngoscope, and maximum 2 attempts are supposed to be used. The DAS guideline uh, says 4 attempts. Okay, over here it is 2 attempts. And between each attempt, you will have to change something. Either you have to improve on the position of the patient, either you change the scope blade, or you use a bougie stillet, or you do an external manipulation, or you release the cricoid pressure. So you don't do the same thing again. You do something that is probably obscuring your view and helps you get it better at the second attempt. And throughout both the attempts, you're supposed to maintain the depth of anesthesia. Okay. So this is your step two of your intubation protocol over here. Second is step three now. So now if you have failed, then you go ahead and put in a supraglottic airway device. During this, so you continue with your apneic oxygenation and you preferably use a second generation supraglottic airway device. Remove the cricoid pressure during insertion of a supraglottic airway device if you haven't already. And even for this, they give you only two attempts provided the saturation is above 95. And between each attempt, ensure mask ventilation and maintain the depth of anesthesia. If you fail at putting a supraglottic airway device also, then the next step is to do a rescue face mask ventilation. Again, here you continue the apneic oxygenation using O2 or HFNC. And then eh, while doing the bag mask, you have to ensure a good neuromuscular blockade. And even if this, and then you give a, if this also fails, then you do an emergency cricothyrotomy. We have already discussed cricothyrotomy in detail, so I'm not going to it go into it again. So your step one is your pre-oxygenation and induction. The plan A of your DAS comes in step two, that is laryngoscopy and induction. Plan B comes in step three, that is supraglottic airway device. Plan C of rescue mask, face mask ventilation comes in step four. And plan D is your step five, that is emergency cricothyrotomy. So what is this is a specifically asked question. So this is something we already discussed, but since it's an answer in itself, I've just put one slide. What is CICV? It is a most dangerous form of airway difficulty where you cannot visualize the trachea for intubation and cannot effectively ventilate the patient's lungs with a face mask. So basically, when you are here at step four is when it is called, when you failed at step four, it is a CICV condition. So what do? Do not continue to try and intubate the patient first. You will cause more swelling, bleeding, and increase the risk of complications. Second, administer 100% oxygenation and give a jaw thrust to help lift the base of the tongue from the pharyngeal wall. Use airway adjuncts like oropharyngeal or nasopharyngeal airway. Use two hands to hold the mask and an assistant to squeeze the bag, and which may make a significant difference. By using two hands, you can pull the mandible ahead in the anterior direction and release the cricoid pressure on the second difficult airway. The patient's physiology and physiologically difficult airway. Basically, patients' own compromised reserves have caused a condition in which the risk of complications of intubation are high. So, what are the risk factors? One is the patient's pathophysiology. So, these are the points that you should mention as the uh, risk factors for doing for a PDA. One most important is hypoxemia, cardiovascular instability. So already desaturated patient or a patient with a low blood pressure. Others are right ventricular dysfunction, raised ICP, obesity, pregnancy. And other human factors are your airway operator experience. So how do you approach a physiologically difficult airway? So step one is team and equipment preparation. So this is the same thing what we have seen in the chart where a table of four columns, right? Prepare the patient, prepare the equipment, prepare for a difficult situation, and prepare the team with defined roles. So the same thing comes over here to have a proper checklist. Team over here, they recommend three healthcare providers for a physiologically difficult airway, and training. You should include simulation-based training for preparedness. Step two is patient preparation. Patient preparation first is assessment and counseling. So assessment we saw, sorry, this is not Monacha, this is Marco score, sorry. And counsel the patients about the possibility of a difficult airway if feasible. Hemodynamic monitoring, we have already seen you need a continuous ECG, BP, NIBP, SpO2. Optimize your hemodynamics with fluids, vasopressor dips should be connected. They also recommend doing a peri-procedure focus to assess the cardiovascular status. Step 3 is intubation. Now, for intubation, what they have suggested is a modified RSI approach. What modification they have suggested is titrated administration of rapidly acting sedative hypnotics and neuromuscular blockade with or without gentle mask ventilation. Again, so mask ventilation is not a recommendation in the classical RSI. Here, what they have said is modified version. And cricoid pressure should, if applied, remove it immediately if your visualization is impaired. So initially, cricoid pressure was a recommendation. Now it's just mellowed down to a suggestion, or you can do it, but if at all there's any difficulty, you can release it. The medicines that in physiologically difficult airway, they specifically recommend ketamine or etomidate. And they also said that ketamine is safe in raised ICP. And for neuromuscular blockade, we've seen succinyl or rocuronium. And tracheal intubation. For a physiologically difficult airway, the recommendation is to use a video laryngoscope itself. And everybody should be trained in it, and it should be routinely employed as a first attempt. It has proven to be superior to a direct laryngoscopy in difficult airway management. And electively use a stillet or bougie routinely with whatever you're using, either video or direct laryngoscopy. So this is one recommendation which is different in the physiologically difficult airway algorithm. Step 4, post-intubation care. So here, this is, you have to confirmation of the tube. They recommend it at least wait for 7 breaths on the EtCO2 to confirm the tube position. Auscultation, X-ray, bronchoscopy to establish the depth of the tube and ensure hemodynamic stability. The next is you look at your ventilation and hemodynamics. Lung protective ventilator strategies are recommended, and use dynamic strategies to assess fluid responsiveness if your pulse rate or blood pressure is unstable. And if the patient continues to be hypotensive, they recommend putting an invasive arterial line and an invasive central line. Okay. And continue whatever infusion of sedative hypnotic as per your clinical requirement. So a few things that are specifically mentioned in the physiologically difficult airway is to use the Makocha or the HIP score for assessment. Then to have modified RSI, and the drugs they have recommended specifically ketamine, etomidate, and even safe use of ketamine in raised ICP cases. And using video laryngoscope is what is specifically different that has been mentioned in the physiologically difficult airway path algorithm. The next is in mechanical ventilation, one of the physiology questions that is asked is lung volumes and capacities. So I've put a simple graph that gives you all the lung volumes and capacities in one place. So now you look at this. First we'll do volumes, then we'll do capacities. Volumes, you start from your baseline to around 1.5 liters almost. This is your residual volume. So what is your residual volume? It is the amount of air in the lung that remains even after a forceful expiration. Then comes your expiratory reserve volume. This is another 1500 ml. So this comes to 3 liters. Okay. Expiratory reserve volume is the amount of air that can be expired after a quiet respiration, end of a quiet respiration. So this is your expiratory reserve volume. So from this 3 liter starts your tidal volume of 500. So what is your tidal volume? It is the amount of air inspired or expired during quiet breathing or rest breathing. And above this comes your inspiratory reserve volume up to 6 liters, which is the amount of air that can be forcefully inspired above a quiet breathing. Okay. So these 4 form your volumes. Start with your residual volume 1.5 liters, expiratory reserve volume another 1.5 liters, 500 ml of tidal volume, and 2.5 liters of your inspiratory reserve volume. Coming to your capacities. So the first capacity is your functional residual capacity. Functional residual capacity is the sum of your residual volume and your expiratory reserve volume. That is, your inspiratory capacity comes next. That is your sum of your inspiratory reserve volume and your tidal volume. Vital capacity is the amount of air that can be maximally inspired and expired. That is the sum of your inspiratory reserve volume, tidal volume, and expiratory reserve volume. And finally comes your total lung capacity. The formal definitions of each I've put on this in this one slide to just go through before the exam. Now, next we come to some important ventilator terminologies or concepts. The first that we will be dealing with is the driving pressure. So, what is driving pressure? Driving pressure is the distending pressure above the PEEP required to generate a tidal volume during mechanical ventilation. So basically, how much pressure you need to apply on the lung in order to distend it with a particular tidal volume is called your driving pressure. Okay. So it represents both the pressure required to counter the elastic resistance of the chest wall and the lung. Okay, so this pressure includes the pressure needed to counter the elastic resistance of the entire respiratory system. It includes the chest wall also and the lung also. So, what is the formula? Delta P, that is your driving pressure, is tidal volume upon compliance. For a ventilated patient who is on passive breathing without any spontaneous effort, it is your P plat or your plateau pressure minus your PEEP. Okay, so what are the target values? What it is said that in patients with ARDS, you aim to keep it below 14 to 15 centimeter of water to minimize lung injury. Higher values indicate a increased risk of villi. So what are the strategies to decrease the driving pressure? One is increasing PEEP. So if you see the formula, it is uh, P plat minus PEEP, right? So if your PEEP is increased, your delta P should at least mathematically be reduced, or you limit the tidal volume. What is the utility of delta P or this driving pressure? First utility we describe in ARDS patients. So in this, the most widely studied is by Amato et al. This in this paper, they have mentioned that of all the parameters that you see on the ventilator, be it RR, tidal volume, or P plat, driving pressure was the only pressure parameter that stratified the risk of villi and was associated with a survival benefit. But you don't have a formal trial that has used a driving pressure driven strategy versus a low volume driven strategy to prove this. But in his study, in his paper, he has said that of all the parameters that you see, your driving pressure best stratifies risk of villi and is also associated with a survival benefit. The other benefit of driving pressure we have seen yesterday, it helps in adjusting or deciding how much PEEP you have to give. Other uses of driving pressure in we've seen in non-ARDS uses are optimizing the ventilator settings intraoperatively to reduce post-op morbidity. This specifically has been seen in thoracic surgeries and CP bypass surgeries, where they have seen that in thoracic surgeries, for every 1 centimeter water increase in driving pressure, morbidity post-operatively increased by 3.4%. And similarly, even in CP bypass surgery, it has proven to have lesser post-op pulmonary complications. Okay, so this is the importance of driving pressure. So each of these pressures, now, even in my previous slides, you would have seen whatever concept I discuss, I put it in specific points so that's easy to revise. Mainly definition, what is the formula for it, what are the normal values or the target values for it, and what is its clinical utility. So if you try and read it like this, or even if you are blanked out during an exam, just put these 4 points, and under these 4 points, whatever you remember, you can just enumerate. So the next pressure that we'll study is something known as the transpulmonary pressure. Now, first to understand transpulmonary pressure, you understand what is intrapulmonary or your intraalveolar pressure and intrapleural pressure. Okay. So, the 760 is your atmospheric pressure. So, what happens during inspiration? Your intrapleural pressure is already negative. You know, it is around -4, right? So, when in during inspiration, it becomes further more negative, say around -6. So, this causes your air to move in from the atmosphere, right? So your intrapleural pressure drops and your intrapulmonary pressure also drops. The difference between these two is known as your transpulmonary pressure. Okay. Uh, so coming to the definition, the difference between the alveolar pressure and the pleural pressure is called transpulmonary pressure. So this is also the distending pressure, like we saw in driving pressure. No, driving pressure we said was the distending pressure required to inflate the lung. So this is also the net distending pressure applied to the lung in either by the inspiratory muscles or positive pressure ventilation. But the difference between driving pressure and transpulmonary pressure is that transpulmonary pressure is subtracting your pleural pressure. So all the chest wall component is now out. So the transpulmonary pressure is sometimes known as the true distending pressure. That is, it is the actual pressure applied across the lung to distend it. So if you are, say, applying an X number of pressure across a lung and majority of that pressure is going in counteracting the compliance of the chest wall, then hardly anything is being delivered to the alveoli, correct? But the transpulmonary pressure separates this. It separates the chest wall compliance from the lung compliance. So it is given by the formula alveolar pressure minus pleural pressure. Okay. This you measure is at one at end inspiratory. At end inspiratory or alveolar is your peak inspiratory pressure minus esophageal pressure. Why esophageal pressure is considered surrogate for it. The second pressure pressure is flat minus your esophageal pressure, and a third during is your esophageal. Okay, so esophageal surrogate pressure hence it is being used. So PL, or your transpulmonary pressure, is the pressure delivered to the lung independently from the effects of the wall and the abdomen. So the target values are, for your tidal transpulmonary pressure, you should keep it less than 25 centimeter of water and zero. So I've given you a small example in order to understand the role of transpulmonary pressure. Okay. See, here you have your alveolus. Say you have a peep plat of, you already have a of 30 and a peep of 16. Now this is, uh, you have two patients. Here you have patient A, you have patient P. Same peep plat, same peep. You are seeing this on the ventilator. Now, if you have the pleural pressure of patient A is 5 and the pleural pressure of patient B is 2. Okay. So then what will be your transpulmonary pressure? Over here, it will be P plat, which is 30, minus 5, which is 25. And over here, it will be your P plat 30 minus your pleural pressure of 12, that is 18. Okay, so right now we just saw your target transpulmonary pressure in tidal or your inspiratory transpulmonary pressure should be less than equal to 25 and expiration is above 0. So your target is 25. So for patient A, your target is, already achieved. Well, you already crossed your upper limit, sorry. But for patient B, you still have scope. Okay, it's 18. You have to keep your upper limit is 25. So you still have scope to increase your PEEP. All right. So here, that's how your transpulmonary pressure helps you guide setting PEEP by separating the chest wall compliance from the lung compliance. This is one example. S- Take another example over here of two patients, X and Y. Both again have the same PEEP plat of 30. Already you have maxed out. Both have the same PEEP of 12. Suppose you have an esophageal catheter that says your pleural pressure and expiratory pleural pressure over here is 5, and over here it is 14. Okay. So over here, what would be your transpulmonary pressure? We are talking about end expiratory. Na? End expiratory transpulmonary pressure is PEEP minus pleural pressure. Here it will be 7. Similarly, here it is negative. Okay. So though you applied the same PEEP to both these patients, one of them is having a negative transpulmonary pressure. That means alveoli are collapsing at the end of expiration. So over here, your end expiratory TPP target is to keep it above 0. This one has gone below 0. So you can further try and increase your PEEP and see the effects. Okay. So this is the role of transpulmonary pressure. How do you measure it? You've taken it. Esophageal pressure is a surrogate for it. It is measured via an esophageal catheter, which is air-filled, thin latex walled balloon inserted nasally or orally. Clinical uses we just saw: assessing the lung recruitability, setting the optimal PEEP, setting tidal volume or inspiratory pressure, and assessment of patient ventilator asynchrony. So since you have an esophageal catheter, you can identify certain types of asynchronies like auto trigger and ineffective trigger, because you can see the trigger of the diaphragm also with this esophageal catheter. Those pressure changes will be reflected over here. So you will be able to see that whether the trigger is generating a breath or not generating a breath. So this will help you identify these two types of patient ventilator asynchronies. So this is the uses of transpulmonary pressure. Next comes mechanical power, a topic that has been very much in the news of late. So it refers to the total work performed by the ventilator to inflate the respiratory system within 1 minute. So initially, how we used to focus on each individual setting, how the tidal volume affects the patient, RR effects, P plat effects, driving pressure, PEEP, all of them have individual interaction, right? But recent research in ventilator-induced lung injury has made it clear that they don't function individually. And the cumulative energy delivered to the respiratory system over time is what is a critical factor in determining lung injury. So what is the physiology behind it? So it is basically how much energy you are transferring to the lungs. So this each breath that you deliver, it delivers energy to overcome one the elastic forces and the other is the resistive forces. So mechanical power basically quantifies this energy load over time and measures it in joules per minute. Basically, the work done by the ventilator to inflate the lungs repeatedly. So it has two parts. One is the elastic component and the other is the resistive component. Elastic component is the work done to stretch the lungs and the chest wall, and the resistive component is the energy need to overcome the airway resistance. So if you're giving a high mechanical power, it can cause overstretching, volutrauma, or shear stretching, atelectotrauma, especially in ARDS patients when the power is low, when the compliance is low. So now the formula for mechanical power in different papers and different authors have given differently. We stick to the one with given by Gattinoni. So even for the for different modes, the power is mechanical power formula is different. The for volume control given by Gattinoni, it is 0.098 into RR into tidal volume into P peak minus half of delta P, where 0.098 is a conversion factor to convert centimeter of water per liter to joules. Delta P is your driving pressure, P plat minus PEEP. P peak is your peak inspiratory pressure, VT tidal volume, and RR respiratory rate. So what you need to understand is each of these components don't have equal effects. 2 times increase in tidal volume increases the power by 4 times. But a 2-time increase in the respiratory rate will increase the power by only 1.4 times. And a 2-time increase in PEEP will increase the power by 2 times. So the target range, it is ideally it should be between 17 to 20 joules per minute to reduce the risk of villi. What are the clinical implications? It has been studied extensively by Gattinoni et al., and they have demonstrated a relationship between mechanical power and villi. As much as the mechanical, even a slight increase in the mechanical power causes a significant increase in mortality. So again, just like your driving pressure, even mechanical power is said to have a mortality difference in ARDS. Uh, Effects on gas exchange and hemodynamics. So higher mechanical power means you're delivering more tidal volume, better oxygenation. But if your mechanical power is excessive, it will cause over distension, VQ mismatch, increased dead space. Similarly, if your what are its effects on hemodynamics? Higher mechanical power simply means higher intrathoracic pressures, reduced venous return, and increased afterload, causing a decrease in cardiac output. Now, mechanical power can predict weaning failure also. If it is the mechanical power during an SBT is high, it is associated with an increased risk of weaning failure, and a lower mechanical power predicts weaning success. Also, it has an implication in NIV. It is a less explored implication, but it has a study in COVID ARDS patients has shown that you can calculate the mechanical power for a patient on NIV, and this calculation in the first 24 hours actually could predict your need for intubation and mortality. And just simple measures like proning these patients reduced the mechanical power by 35% and significantly improved clinical outcomes. So, while describing the clinical implications, one is mechanical power is determines the risk of villi and determines the risk of mortality. Second, it has an effect on gas exchange and hemodynamics. Third, it can be used to predict weaning failure. And fourth, it can be used to predict the efficacy of NIV also. Now, the next concept that we're going to see is stress index. Basically, stress index is something that has been derived from the pressure time curve during a constant flow ventilation. That means when you have a volume control, your flows are constant. In such a case, if you look at the pressure time curve, you will get something known as the stress index. It basically shows how much tidal volume and airway pressures are distributed in the lung, whether you're causing recruitment or whether you're causing over distension. Now, if you see the formula for it, it is very complex. We don't use this formula. Some of the ventilators can calculate the stress index. It is airway pressure at one time t is given by A. A is basically your elastance into your time from the start of inspiration raised to your stress index plus B, which is your baseline P. So what we usually do is just visually look at the graph. Which graph? We look at the pressure time graph. This is of a volume control mode or in that, looking at this graph visually, we determine what is the stress index. So if your the ideal path is to keep is that this should be linear. It should be straight. This terminal part. So if this is straight, this is your stress index is nearly 1. But if this is little convex, your stress index in such a case is less than 1. Less than 1 means you have a lot of collapsible alveoli, and that is why this part, the stress index is less than 1. That means you still have some scope to increase your PEEP and uh, get more recruitment done. And if this part is concave like this, that means your stress index is more than 1, which means you are over distending the alveoli. So this is again one small concept. Now coming to some modes of ventilation. Now I am not going to the details of the modes, but one question that has been asked previously is what is closed loop ventilation? So uh, to understand that, you need to understand the concept of open loop ventilation and closed loop ventilation. Now, what does it say? It says that uh, in an in a normally what we do in the ICU is this. What we do is you have a patient, you have a ventilator and you have a clinician. Okay. So clinician assesses whatever the patient's condition is. Based on that, he sets the ventilator, and exactly that is delivered to the patient. So here, this is an open loop because it is your clinician is within the loop. Okay. But in a closed loop ventilation, what happens is your clinician is outside the loop. Your ventilator assesses your patient's dynamics, and on its own, the ventilator will readjust based on whatever the patient's needs are. So over here, the controller or your clinician is out of the loop. So this is known as a closed loop ventilation. When a clinician is into the loop, it is known as an open loop ventilation. Okay. Setting. So these are certain decides how much pressure is needed to deliver this is exceeded, it will automatically uh, cut off the pressure delivered by the ventilator and deliver a lesser tidal volume. So this is one of an examples of the closed loop ventilation. Basically, it protects the lung from high pressures. Other newer, more defined um, modes of closed loop ventilation include ASV or adaptive support ventilation, PAV plus, that is proportional assist ventilation, NAVA or neurally adjusted ventilator assist, where your diaphragm trigger, the amount of trigger generated by the patient is detected by the ventilator, and only the breath that is delivered is in proportion to the amount of that trigger. And Smart Care or Neo Ganesh, which is a AI installed closed loop ventilator. So what are the advantages? One is obviously there's better patient ventilator synchrony. The ventilator is automatically adjusting as per the patient needs. Second is there's reduced workload for the clinicians. There's reduced workload for the clinicians because you don't have to frequently go and check and readjust the ventilator. Enhanced safety, there's better gas exchanged because the targets are achieved by adapting to the lung compliance, and faster weaning. So the transition to a spontaneous breath by dynamically balancing the support is faster. The next question asked is inverse ratio ventilation. So inverse ratio ventilation is a new mode of one of the advanced modes of ventilator in which the inspiratory time is intentionally prolonged so that the IE ratio is more than 1 is to 1 instead of the normal 1 is to 3. 1 is to 2 or 1 is to 3. So there are two examples of this mode. One is your APRV or the airway pressure release ventilation, in which your IE ratios can go up to 2 is to 1, 3 is to 1, 4 is to 1, and your expiration time, of course, is very short. This is given by your Drager ventilator. This is just for your own knowledge. And the second is by a bi-level ventilator. A bi-level mode gives you an IE ratio of only 1 is to 1. So the as compared to APRV, the expiratory time is relatively more. So this mode is given by your Puritan Bennett ventilators. So it's basically the same concept, but it's just that different brands of ventilator are called it differently. So how do you define any mode of ventilator? You define it as the control and the cycle. So this is what it's a pressure controlled mode and time cycle mode. But at the same time, it is allowing spontaneous breathing with or without pressure support in both phases of the ventilator cycle. So I'll explain this statement to you. So basically, the ventilator has its own inspiration expiration cycle. So the ventilator has one cycle where the pressure is going to be high, and one small time when the pressure is going to be low and again high. So basically, this will be 4 is to, say, 3 is to 1 or 4 is to 1. Over and above this, the patient is allowed to take his own breath whenever he triggers. Okay. And this breath can be, you set the sensitivity and pressure support for this breath. It can be in any phase of the ventilator. It can be either in the high phase or it can be in the low phase. So this is what is the concept of inverse ratio ventilation. So by improving your I ratio, now you've prolonged your inspiration to so long, you ensure better recruitment. Okay. So I'll explain you a simple concept in order to understand this. This APRV, bilevel, and even HFOV is something called as shear stress. Okay, what is shear stress? Is at So whenever you are rapidly giving a high pressure to open the alveoli, then this alveoli shuts, then it opens, then it shuts. So this repeated opening and closing is what is causing a shearing stress in them, which is what causes atelect trauma, which is one of the mechanisms of villi. Okay, so these newer modes, they attempt to decrease this villi and at the same time improve your alveolar recruitment by prolonging your inspiration in APRV and bilevel. Okay, so that is what is the fundamental concept behind this mode. So what are the settings in these modes? You have a P high. P high is the time, like I showed you in the diagram, right? You have this, you have a P high, you have a P low, and at the same time you have a T high and you have a T low. Okay, the time that is to be at this point and the time that is going to be at the low point. So P high is usually it is basically, if you're switching from a pressure control, the inspiratory pressure that you were giving is equivalent to your P high. You should avoid exceeding from more than 30 centimeter of water. So giving a high high P high will ensure a high transpulmonary pressure and will promote lung recruitment. Your P low is equivalent to your PEEP. The difference between P high and P low determines the tidal volume. Frequency, so you have a T high and a T low. So your T high has to be more. You want a ratio of almost 4 is to 1, right? So this is 3 to 6 seconds, and the time spent with low pressure is only 0.5 to zero point 0.8 seconds. So this is the T low is the most important settings in ARV. The This is the duration required to 1 second. To get your the amount of time required to achieve 75% of the peak expiratory flow rate is the time that you should keep as your T low. So this, for an example setting, is 4.5 seconds as a T high and only 0.5 seconds as a T low. So you get a I ratio as high as 9 is to 1. Then you set the inspiratory rise time, you set the sensitivity for spontaneous breaths, and you set the pressure support that can be applied at both P high and P low phases for the patient to take us to basically give an assistance to the spontaneous breath taken by the patient. FiO2 you adjust according to your oxygenation targets. So usually you would theoretically want to believe that actually by giving such high pressures, and on top of that, if you're giving spontaneous breathing, you would expect that the lung injury would increase. But what has been seen in studies, it has proven to be beneficial, because mainly because of recruitment. Plus, I explained you the concept of shear stresses. So the shear stress is reduced. There's more homogeneous distribution of the transpulmonary forces and redistribution of perfusion to the uh, uh, atelectatic or fixed areas. Advantages: prioritize uh, prioritizes alveolar recruitment, so better aeration, lesser shear stress, lower RR. Paralysis and deep sedation is not required. In fact, you're encouraging spontaneous breathing over here. So because of that, there will be better clearance of secretions. Disadvantages, one is barotrauma, but this is only theoretical. It's not seen consistently in studies. Patients will need a lot of fluid here because of your positive intrathoracic pressures. This is opposed to the restricted fluid strategy in ARDS. There's very limited experience with this mode. Tidal volume generated may not be lung protective. It increases the RV afterload because of the positive pressure in the thorax. So the RV afterload will be high. But because you have caused better recruitment, your VQ mismatch is less and pulmonary vasoconstriction is reduced. The release breath. So if you're keeping the lung open for 4 to 5 seconds, in that half second also where you're caused a release breath, you can cause de-recruitment in that phase. And sorry, this last point was supposed to not be there. Yeah. So the evidence for APRV, what is the evidence for APRV? It was given by a paper by Zhu et al. In which they studied the difference between APRV versus your normal ARDSNet low volume ventilation in around 138 patients. Okay, in this, it was a single center study. In this, what they saw that there was a significant benefit in mortality. There was a significant benefit in ventilator free days, in successful extubation, and even reduced tracheostomy. So, because of this evidence, it has been one of the recommendations of rescue strategies in ARDS. The next comes your HFOV, or the high frequency oscillatory ventilation. So to understand HFOV, you think of it as a vibrating CPAP machine. Okay, if you look at this diagram over here, okay, so you have your ET tube over here. You have the inspiratory limb coming from your ventilator, expiratory limb over here. Now this for HFOV, basically you have this piston. This piston is driving this diaphragm, okay? And inside this, you have a continuous flow of fresh humidified gas. So now this diaphragm here is going to oscillate at a very high frequency, 3 to 15 hertz, okay? 3 to 15 hertz means 1 hertz is 60 cycles. So if 3 hertz means 180 times, it's going to oscillate in 1 minute. And that means it's like making a patient breathe at a rate of 180 breaths. Okay, but you're giving a very small tidal volume, that is only 1 to 4 ml per kg. The idea is to maintain a constant lung recruitment and prevent lung injury from over distension and loss of recruitment. So this is what was the concept based on which HFOV was established. So then if you're giving such a low tidal volume, how exactly is gas exchange occurring? So your tidal volume is less than your dead space. So there are certain mechanisms proposed by which gas exchange occurs. One is the pendulum phenomenon. This we have seen yesterday. The second is augmented diffusion. Just because of the oscillation, the random molecular motion increases, and this enhances diffusion within the alveoli. Then there is a concept of Taylor's dispersion, where oscillations cause the gas flow to become oscillatory in the airway, and this because of this, molecules in the center will move faster than the ones towards the wall, and this will cause more spread of gas. And cardiogenic mixing, that is, with every heartbeat, there is some mixing of air into the alveolar units. So these are some proposed mechanisms by which gas exchange occurs in an HFOV. So what are the settings we do? Bias flow. Bias flow, I told you, right? In this diagram, if you see, there is a fresh humidified gas flow. So this is your bias flow. Bias flow is set at 40 liters per minute. Sorry. Mean airway pressure. Mean airway pressure control. This is the pressure that you will set. Next you set is the power. Power is the diaphragm. It's set as a percentage. It is the diaphragm excursion. How much the diaphragm will move, that will determine your tidal volume. Next you set is your percentage inspiratory time, or the time that the piston will spend in the inspiratory phase. And the last thing you set is your frequency. Your mean pressure is basically the pressure with which your piston will move. To control oxygenation, what all you can do, you have your FiO2 and your mean pressure. So the higher pressure means more gas exchange. And to control your carbon dioxide, you again have your you have your power or delta P, the amount of excursion that is occurring in the HFOV frequency. You can increase the frequency to cause more CO2 washout. Percentage inspiratory time, again, you can decrease this in case carbon dioxide is a problem, and cuff leak. So that is one thing that you should understand. Here, the cuff is never completely inflated. Cuff leak is one of the ways of which CO2 washout occurs in HFOV. So what are the advantages? It decreases the ventilator-induced lung injury by reducing the shear stress. The parameters needed for oxygenation and parameters needed for CO2 clearance are independent. There's dissociation of those two, mobilization of secretions, and it can be used in children. Disadvantages, uh, again, at any point, it can cause de-recruitment. You need heavy sedation paralysis, requires active humidification. Giving high mean airway pressure means you can cause hemodynamic instability, and there's no mortality benefit. What is the evidence? There was an initial Cochrane meta-analysis which studied HFOV and showed that there was improved oxygenation at 24 hours and decreased mortality at 30 days. So this was a meta-analysis of many small studies. In 2013, two trials were released at the same time. One is the Oscar trial and one is the Oscillate trial. Oscar trial had around 795 patients. It showed there was no mortality benefit, and HFOV patients required more sedation and relaxants. But the Oscillate trial, it actually showed that the mortality increased with HFOV, and the trial was stopped early due to harm. So because of these two trials, it has fallen out of practice. Now, the next concept is weaning. Weaning, there is a question on not only weaning failure, what are the causes of weaning failure? There is also a question on the weaning indices like RSBI, and even how to assess readiness for weaning. What are the criteria to establish readiness for spontaneous breathing trials? So coming to the definition first, the definition actually given by ICC. It is basically a process of gradually decreasing the mechanical ventilator support and transferring the ventilation process to the patient. So ICC group 1, group 2 difficult weaning, group 3 prolonged weaning. The first, there's successful extubation or extubation after 1 act of SBT. Difficult weaning means it took 2 attempts of spontaneous breathing trial. 3 attempts at spontaneous breathing trial, more than 3 attempts.
This meeting is being recorded.
Simple, 2 to 3 attempts. Difficult, more than 3 attempts. Prolonged. Simple, 2 to 7 days. Difficult, more than 7 days. Prolonged. Okay, so remember here, they say the patient should be extubated. Huh? After 7 days, if the patient is extubated, say this was difficult weaning. So these were the gross problems that the definition of ultimately weaned. And you trial is not the same universally. Okay, so some it was, they said initial assessment, they used terms that initial assessment, SBT was not clearly defined. And a lot of patients, especially with type 2 respiratory failure, you might just extubate even without an SBT. So all of these patients were not really included in this definition. So that is why there came another definition by Wind, weaning according to the new definition. This was proposed in 2016. So the Wind definition defined weaning as the any kind of separation attempt without accounting for the previous reduction in ventilator support. So basically it defined weaning in two categories. One is for intubated patients, one is for tracheostomized patients. Sorry. In them, it The definition includes two components. First is the separation attempt, and the second is the successful weaning or separation. So, separation attempt means uh, you give a spontaneous breathing trial or direct extubation, or extubation without a SBT is defined as a separation attempt in intubated patients. Successful weaning means extubation without death or reintubation within the next 7 days, whether NIV post extubation was used or not, or ICU discharge without mechanical ventilation within 7 days. Whichever comes first is called successful weaning. That means the after you patient got extubated within the next 7 days, there was no reintubation, or the patient was discharged, or the patient survived, is what is called as successful weaning. For a tracheostomized patient, 24 hours or more with spontaneous ventilation through the tracheostomy without any mechanical ventilator was defined as a separation attempt. And when was this separation attempt successful? It was successful when the patient remained on spontaneous breathing without a mechanical ventilator for 7 consecutive days, or he was discharged on spontaneous breathing, whichever came first. So, this is how wind more specifically defined uh, SBT, मतलब separation attempt and successful weaning. So, now weaning, according to wind, it was now they put it in four categories. So you had three categories given by ICC. They gave us another category called as group 0, where no weaning or no separation attempt was made. Group 1 was separation. First separation attempt resulted in termination of weaning in 1 day. Termination of weaning could be either successful weaning or death. Okay, that was known as a short weaning. Difficult weaning is first separation attempt required more than 1 day but less than 7 days. This we've already seen. 2 to 7 days is difficult weaning, and prolonged weaning is more than 7 days. But here they gave category A and B. That means if even after 7 days the patient did not get extubated, it was 3B. But if the patient got extubated, it was 3A. Okay. So this was properly defined in the wind classification. This is the newer uh, definition of weaning and difficult weaning. So this is the one you should know. Just for ease, I've put the comparison of both the ICC definitions and the wind definition in one table. Criteria to assess readiness for spontaneous breathing trial and weaning. There are four categories of criteria that you should define. First is your clinical criteria. That means there should be resolution of the acute phase of the disease. There should be an adequate cough. There should be absence of excessive secretions, cardiovascular hemodynamic stability, and adequate mentation. So these are the first primary things or the clinical things that you need to assess for seeing readiness of SBT. Second is the ventilation criteria, whether the patient is ventilating properly seen by an SBT of either 20 to 30 minutes. Your PaCO2 should be less than 50, pH should be normal, vital capacity should be more than 10 ml per kg, tidal volume should be more than 5 ml per kg, RR, spontaneous RR should be less than 35. Your F by VT or your rapid shallow breathing index should be less than 100, and your minute ventilation should be less than 10. So basically, your tidal volume and RRS or minute ventilation. So these are all your ventilatory criteria to say the patient is ready to be weaned. What are the oxygenation criteria? Your PaO2 should be more than 60 on an FiO2 of less than 40 and P less than 8. Saturation should be more than 90. PF ratio should be more than 150. Shunt fraction should be less than 20%, and your alveolar arterial gradient on 100% FiO2 should be less than 350. And there are certain pulmonary reserve measurements, which are your vital capacity more than 10 ml per kg, maximum inspiratory pressure more than minus 25 centimeter of water, static compliance more than 30 ml per centimeter of water, dynamic compliance more than 25 ml per centimeter of water. Airway resistance should be stable and improving. Your dead space ventilation, VD by VT, should be less than 60% when the patient is intubated. P 0.1 should be between 1.5 to 3.5. Crop index should be more than 6. So these four are the criteria to assess readiness for short spontaneous breathing trial and weaning: clinical, ventilatory, oxygenation, and your pulmonary reserve measurements. So in the weaning process, what all do you do? You first, there should be resolution of the respiratory failure, assess the readiness to wean, give an SBT, extubate, reintubation, or discharge. So, SBT is specifically defined as the evaluation of a patient's readiness for weaning from mechanical ventilation or extubation and the ability to breathe spontaneously. What are the strategies used for giving a spontaneous breathing trial? One is TPs with supplemental O2, CPAP recommended to overcome the endotracheal tube resistance, or a low level pressure support of around 5 to 8 on minimal ventilator settings. And the last is your ATC or automated tube compensation. How long should the spontaneous breathing trial be given? At least for 30 minutes, but not longer than 120 minutes. Now, some of the weaning indices have been asked as a question itself. Amongst them, you have an RSBI. So, what is RSBI? RSBI is basically, it is used to evaluate the prediction of successful liberation from the mechanical ventilator. It is described by Young and Tobin. Again, sorry, this is a autocorrect. It's Young and Tobin. It was also known as the Young-Tobin index. It is basically the ratio of to RR in per minute to tidal volume in liters. Okay, remember tidal volume is in liters in RSBI. So interpretation, normal value is, it should, if it is less than 105, it indicates successful weaning. If it is more than 105, that means your RR is much more to the tidal volume. It will highly predictive of weaning failure. So what are the factors that affect RSBI? One is the mode of ventilation. Okay, some studies have found that the RSBI is higher in TPs compared to CPAP or pressure support. Patient's himself condition, your RSBI may come high, but there may be some other problem, like patient would have sepsis, fever, anxiety, position is not good, or restrictive lung disease, or narrow endotracheal tube. In COPD patients, RSBI cannot reliably predict the successful outcome, because COPD has one biggest problem of ineffective ventilator trigger. In cardiac patients, RSBI should not be used as a sole predictor of weaning success. You should consider the mode of weaning. Why? Because a TPs versus a CPAP pressure support type of SBT will make a difference in your uh, intrathoracic pressures. Okay, intrathoracic pressures being positive is actually a support to the lungs, support to the heart. And when a patient who has a underlying heart disease might actually get decompensated when you remove that positive intrathoracic pressure and you put the patient on TPs, and that might cause uh, weaning failure. So you should consider what mode of weaning you are using in cardiac patients, and TPs is usually avoided in such patients. Neurosurgical patients, it's a good predictor. Burns, you have to use other things like cuff leak and see the AT secretions. For prolonged mechanical ventilation, you should, single RSBI does not accurately predict successful weaning, and a trend has greater prognostic value. So there are certain modifications. One is the serial RSBI and one is the RSBI rate. Serial RSBI is, you during the course of SBT, you see starting the RSBI might be stable. It might deteriorate later due to poor respiratory muscle endurance. So this is then two other index. Okay, F into peak inspiratory pressure minus PEEP upon maximal inspiratory pressure into PaO2 upon 40. Normal value is less than 9. And new crop index, that is your compliance rate, oxygenation, and pressure. So the formula is given in the name only. Compliance is your dynamic compliance, rate is your Oxygenation is P small aO2 upon capital AO2. That is your alveolar and arterial oxygenation. And pressure is your maximum inspiratory pressure. Normal value is more than 13 breath ml per breath per minute is a predictor of an successful weaning. Now, physiology of weaning failure. So this is another question. What are the causes of weaning failure? How will you assess and how will you treat? So this can be given by a simple mnemonic A, B, C, D, E. A is for airway breathing, B is brain dysfunction, C is cardiac dysfunction, D is diaphragm dysfunction, and E is endocrine and metabolic causes. So coming to first is your airway and breathing. Airway, first is what are the causes that can lead to weaning failure over here? One is an obstructive cause, second is a compliance cause, and third is a muscle fatigue. How will you assess this? This you can, if you know this, you can write these, right? Obstruction, what you'll do, physical examination, whether there's stridor, wheezing, crackles, you'll see the ABG, you'll see an X-ray to see if there's any one of the causes causing a reduced compliance. Also, you will see the flow time and pressure time graphics to understand whether the airway resistance is increased or there's an intrinsic PEEP. For respiratory muscle fatigue, there is an index which has been mentioned, which is called as the tension time index, which is given by PDI upon PDI max. PDI is the mean trans diaphragmatic pressure during inspiration, and DI max is the maximum trans diaphragmatic pressure, which assesses the strength of the diaphragm, into TI, that's the inspiratory time, upon T tot, that's the total cycle time. And if this tension time index is more than 0.15 to 0.18, there is a risk of diaphragmatic fatigue and weaning failure. How do you treat it? You find it. Depending on what you get over here. You clear the secretions, do a suction, give a bronchodilator, give a corticosteroid for airway edema. Treat the underlying lung pathology. If there's pneumonia, give antibiotics. If there's edema, give diuretics. Optimize the ventilator settings to improve the gas exchange, and NIV as a bridge if required. So this is your airway and breathing. Next comes your B. B is brain dysfunction. So what are the causes of brain dysfunction causing weaning failure in the ICU? Most common is an altered mental status due to delirium. Next is central respiratory drive depression because of maybe opioid overdose, encephalopathy, and neuromuscular disorders affecting respiratory control. So amongst how will you assess? You can assess by seeing the GCS neurological exam, drug levels of opioids, EEG or CT MRI. And how will you treat? First of all, reverse the sedations. Either you stop it or use reversal agents. Treat the delirium, whatever is causing it, either an infection, electrolyte imbalance, hypoxia. Consider antipsychotics. Support the neuromuscular disorder if that is a cause, and optimize your ventilator support till your central drive improves. C is your cardiac causes. Cardiac causes can be either due to heart failure, any ischemia, or arrhythmias. How will you diagnose them? ECG will give you an idea of any ischemia and arrhythmias. Echo. So they say that if your E by E prime was more than 12.5 at the beginning and it increases to 14.5 during an SPT, it will predict weaning failure due to a cardiac cause. And lung ultrasound, if there were less than 6 B lines or lung ultrasound before SPT and it increased to more than 6, again, this will be a marker of a cardiac failure causing failed spontaneous breathing trial. And BNP, anti-pro-BNP, they say that 12% increase during SBT will predict weaning failure due to a cardiac cause. If there's ischemia, you can check your troponins. Hemodynamic monitoring, if you have a PA cath which says that the wedge pressure is increased during SBT, again, it would suggest that the cardiac is the cause of weaning failure. Another thing is SCVO2. So it is said that if there is a drop in SCVO2, if it would predict it could be cardiac. But if there is no drop in SCVO2 during weaning, during a spontaneous breathing trial, then this weaning failure is unlikely to be cardiac related. So how will you treat any cardiac dysfunction? Obviously, for heart failure, you'll give diuretics or for fluid overload, vasodilators for preload and afterload reduction. If there's ischemia, treat it with if there is arrhythmias, then you give specific treatment for those antiarrhythmics. And at all, if needed, you might give some inotropic support and gradual weaning to reduce the cardiac stress. D is your diaphragmatic weakness. So, diaphragmatic weakness most commonly will be critical illness or ventilator induced diaphragm uh, dysfunction. How do you assess it? You have some airway occlusion pressures that is your P01 and your maximum inspiratory pressure. You can do a diaphragmatic ultrasound or an EMG. How do you treat it? You cannot give any specific treatment. Physical therapy is one, nutritional support, gradual weaning, and tracheostomy can be considered. And finally, all your electrolytes and endocrine causes. Amongst your electrolytes, you have hypokalemia, hypophosphatemia, hypomagnesemia, thyroid, adrenal dysfunction, or severe anemia. To diagnose them, you will check specific levels in the blood, and to treat it, you will supplement those hormones or electrolytes or blood for anemia. So these are the long and short of all your weaning indices. So I'm going to stop here. I've covered maximum of the exam questions in respiratory system, mechanical ventilation. Yesterday, somebody had a doubt on waterfall phenomenon. So I'll just try and do that again for you. I hope I can explain it. Okay, so now this is something. What is waterfall phenomenon? Waterfall phenomenon is something that explains the role of external peak in overcoming the workload in a patient of COPD. Okay, so what is happening in a COPD patient? They have a high intrinsic PEEP because of a hyperinflated lung. So whenever the muscle has to generate a breath, they have to work against this intrinsic PEEP in order to trigger the ventilator. So this increased workload causes ineffective triggers. Okay. So in order to offset this, it is said that if you apply an external peak, this workload is decreased. The easiest way that I have understood this is in one of Dr. Divatia's lectures where he says that, so suppose you can imagine if you have to climb a very big step, okay? So you have to climb a very big step. The lung has to basically, in analogy, the lung has to do so much work to uh, climb this step, okay? That is your intrinsic PEEP, okay? That is the amount of work that the lung has to do. To ease it out, if you put a stool, you can just climb the step easily, right? If you take a smaller stool, so your external PEEP that you're applying is like that small stool that helps your lung overcome this intrinsic PEEP. So how have they applied this analogy to the waterfall now? So you have a pressure over here in the alveolus. You some narrowing or some airflow limitation in a COPD patient. This is your critical pressure, and beyond that, you have an airway which has an airway pressure. Okay. So what they have compared to this they have compared this to a waterfall. They say that this height of the waterfall is your airway alveolar pressure, and the downstream flow is your airway pressure. Okay. This critical pressure is what this slope is. All right. So they say if you add an extrinsic peak, you can if you improve this, the extrinsic peak basically improves the height of this and makes this flow easier. All right, that is what is the concept of waterfall. But if you increase this beyond a certain height, you will make the flow from year to year more difficult. That is why the extrinsic PEEP that you apply should be less than the intrinsic PEEP, or like in the slides that I showed you, around 80% of the intrinsic PEEP. Okay. So this is what is your waterfall analogy. Okay, I'm going to stop over here at this point. And if anybody has anything, any doubts, or you feel like some things are unclear, either you can, due to paucity of time, I'll have to log off now, but you can put it on the group. I'll try and help you as much as possible. Okay. Navneet is the next speaker there. Dr. Amrita is there.
Yes, I'm here.
Yeah, hi.
By Dr. Jasmine. As usual, she has explained the concepts really well, and I hope you have maximum benefits with these sort of discussions. So we'll continue with our cardiology lecture, which we had done yesterday. Okay. The next topic that I was supposed to talk on was rheumatic heart disease and mitral stenosis. I'm audible, I hope. Hello.
Yes, Dr. Amrita, you're audible.
Okay. All right. So rheumatic heart disease and mitral stenosis. Just a second. Yeah. Mitral stenosis is the narrowing of the mitral valve orifice, leading to obstructed blood flow from the left atrium to the left ventricle during diastole. It is more so present in the developing countries, and the women are more affected compared to men. Onset is usually in the third and the fourth decade of life. So, the stenosis will be there of the mitral valve where there is narrowing and blocking of the blood flow coming into the left ventricle. Etiology. The rheumatic heart disease is the first etiology. It is a preventable sequelae of the acute rheumatic fever. Post group A streptococcus pharyngitis, and mitral stenosis is the most common lesion here, progressing to LV inflow obstruction with pulmonary vascular consequence. Other causes include calcific disease, for example, mitral annular calcification, prosthetic valve dysfunction, systemic inflammatory disorders, radiation valvulitis, endocarditis with large vegetations, congenital causes, and carcinoid. So, what is the pathophysiology in case of a rheumatic heart disease for the mitral stenosis? It is the untreated or undertreated group A streptococcal pharyngitis. Okay, and it occurs as a result of an exaggerated immune response to specific bacterial epitopes in the susceptible host. The inflammatory process in the valve leaflets is thought to be initiated by cross reactivity between the streptococcal antigen and the valve tissue. So essentially, this thing is called as molecular mimicry. Okay, where the M protein epitopes resemble the cardiac tissue, and it leads to the pancreatitis, recurrent episodes, valvulitis, and fibrosis towards the end. Valve deformation can happen, leading to thickening of the leaflet, commissural fusion, caudal shortening, which causes the fish mouth orifice and calcification of the leaflet cusps. So, in case of mitral stenosis, exactly what happens? There is pressure in the left atrium. Because of the stenosis, the flow into the ventricle is not happening properly, and there is a pressure. The volume increases in the left atrium, resulting in increase in the pressure, because of which there is a backflow, and there is increase in the progressive pressures in the pulmonary vasculature. A further back pressure leads to the right ventricular pressure overload, right ventricular dilation, leading to these problems. And for the left ventricle, whenever there is a left ventricular pressure overload, LA dilation happens, it can lead to all these problems. So, what will the patient present with? Patient can present with, initially, he will be asymptomatic, but later on can develop symptoms of heart failure, progressive exertional dyspnea. Atrial fibrillation symptoms might also be present. Okay, and a patient can come with what is called as Ortner's syndrome, where there is compression of the left recurrent laryngeal nerve. They can present with cough as well as dysphagia. Any cause of increased cardiac output can further lead to worsening of this condition because of reduce in the diastole. So, what kind of murmur the patient presents with? They present with a low pitched mid diastolic rumbling murmur along with presystolic accentuation, opening snap, okay, after S2, which is heard best at the apex, and the murmur increases with squatting and hand grip. It decreases with decreased blood flow across the valve. Opening snap becomes closer to S2 as the stenosis becomes more severe, and the opening snap might be absent if the valve is heavily calcified. Apart from that, patient also present with the facies of the mitral facies, central cyanosis with developing of pulmonary hypertension, low volume irregular pulse, pulmonary regurgitation with Graham Steele murmur, which is present during inspiration, and all the signs of heart failure patient can present with. Diagnosis. The ECG features comprises of P mitral, which is the left atrial enlargement, which is the classic ECG manifestation. Apart from that, they can also present with features of atrial fibrillation and sometimes pulmonary hypertension. Chest X-ray comprises of straightening of the left heart border, prominence of the upper lobe veins, pulmonary artery enlargement, curly B lines, which is relevant of interstitial edema, presence of McCallum's patch, which is the the large LA, which is visible as a double shadow, and LA calcification. Right heart catheterization, there will be presence of giant A waves whenever we do a right heart catheterization, and the PAC tracings will be like this. Echocardiography. Now, there is a huge chart of echocardiography definition and the anatomy and hemodynamics given. So it has been cut short, and we have to remember only three things basically. So the mild stenosis, mild mitral stenosis, is when the mitral valve area is more than 1.5 centimeters square, but the mean gradient is less than 5 millimeter of mercury. It is mild. Uh, it is moderate when the valve area is 1 to 1.5 centimeters square with a mean gradient of 5 to 10 millimeter mercury. And it is severe, which can be divided into asymptomatic and symptomatic. So severe is when it is less than 1 centimeter square with a mean gradient of more than 10 millimeter of mercury. And there is also something called as critical mitral stenosis, where the valve area is less than 0.5 centimeter square. So, how do we manage mitral stenosis? Any underlying pathology which aggravates the condition has to be treated. Secondary prevention is important, like penicillin G. Okay, all the things which presentations of heart failure, any cardiogenic pulmonary edema, they have to be managed. Non-invasive ventilation, intubation needs to be done for the patient. So, atrial fibrillation is poorly tolerated in this patient, and emergent cardioversion might be required. Potential complications in such patients include death, stroke, cardiac perforation, severe mitral regurgitation requiring cardiothoracic surgery. Residual atrial septal defect may also require closure. Anticoagulation is indicated in cases where there is persistent AF along with mitral stenosis, prior embolic event, or presence of a left atrial thrombus along with mitral stenosis. Here, warfarin is preferred over the direct oral anticoagulant, as is depicted in the Invictus study, where it was found to decrease stroke and death in such patients. Drugs in beta blockers, calcium channel blockers might be required in such cases, and to manage pulmonary congestion. DDs include left atrial myxoma, endocarditis, mitral valve prolapse, severe AR, tricuspid stenosis. Where will we do percutaneous mitral balloon valvotomy or commissurotomy? So it will be done in the following cases: where there is severe MS, favorable valve morphology, absence of left atrial thrombus, or moderate to severe MR, and patients coming with one of the following symptoms: where there is severe symptomatic MS, asymptomatic MS, but a mitral valve area of less than 1 centimeter square, new onset of atrial fibrillation, or suboptimal valve anatomy. That means the patient is not yet a candidate for surgery. And mitral valve replacement in other cases are done. Here, anticoagulation is required for 3 to 6 months for bioprosthetic valve and lifelong for the mechanical valve. So goals: avoid tachycardia is required. Afterload in hypotension, patient will require agents, but it should not cause too much of tachycardia. Okay. Atrial fibrillation rate control will be needed. And if need be, patient needs to go for an urgent cardioversion. High PEEP can worsen the RV effect, as we have discussed yesterday. Okay, so use the lowest effective PEEP. Intubation induction if needed. Blunt the sympathetic surge. Avoid drugs like ketamine, which can cause tachycardia. If required, use more hemodynamically stable agents like etomidate. Pregnancy, avoid tachycardia and volume overload, and go for mitral valvotomy and commissurotomy, as we have discussed in the previous slide. Okay, so these are the goals of the decompensated MS, and this is the most important slide which is needed for you in the ICU. So in the exam, this is the slide that one is looking for, and you need to produce. Coming to our next topic. So the next four topics that we have, it is related to post cardiac surgery care. Okay, these are very interesting topics, and most of the of the time we don't read up these topics. So better concentrate right now on the slides that we have. So evaluation and management of post-cardiac surgery shock. This will be the flow of my topic. Post-cardiotomy cardiogenic shock constitutes the most serious clinical expression of the post-heart surgery low cardiac output syndrome. It is defined by a decrease in the cardiac output that leads to hypoperfusion and hypotension. That is a cardiac index of less than 2 liter per minute per meter square, SBP of less than 90, pulmonary capillary wedge pressure of more than 16 to 18 millimeter of mercury, and oliguria. In-hospital mortality occurs following cardiac surgery in 2.6% of the cases. Now, pathophysiology includes local surgical damage, ischemic perfusion injury, which happens because of massive calcium entry to the cell with dysregulation of the cellular mechanisms, increase in the free radicals causing oxidative stress, and mitochondrial permeability dysfunction. So these are the mechanisms by which the ischemic reperfusion injury occurs. And last but not the least, we have the extracorporeal circulation, which itself can cause some amount of microvascular dysfunction. The imbalance between the damaging and the protective mechanisms cause postoperative myocardial stunning, and uh, it maximally causes the secondary cardiogenic shock. So how will you evaluate? History of the patient, quite similar to any kind of shock history. One needs to ask the prior history, anesthesia, past history, medical history, allergies, preoperative medication, any kind of symptoms. And if the patient has gone on the cardiopulmonary bypass, then one needs to ask regarding it, are aortic clamp time and problems and complications, if any, that has happened in the OT. Physical examination, look for signs of bleeding, abdominal examination, peripheral pulses, skin, urine output, all the things that are needed for shock. Basic hemodynamic management has to be done. Go for ECG, echocardiography, chest x-ray to look for further signs of what is the cause of shock. And extended hemodynamic assessment need be done in such cases. For example, pulmonary artery catheter might be an important tool, okay, along with further advanced kind of monitoring. For example, transpulmonary hemodilation, if present in your setup. So what could be the diagnostic approach in post-cardiotomy shock? What is the difficulty is that such patients can present with mixed shock, because there might be a primary cause of shock and there might be a secondary cause of shock. Therefore, available monitoring devices as much as possible with physical examination is needed to narrow down the diagnosis. For example, if the patient has come with a cardiogenic shock, peripheries will be cool, congested, there will be narrow pulse pressure, decreased in the capillary refill time. Hemodynamics need to be monitored and the echo has to be done. Bedside focus is one of the most important tools. We know the false protocol. We know how to identify different types of shock as we have studied yesterday. And uh, so systolic, diastolic, valvular dysfunction needs to be found, and whether patient has got a narrow pulse pressure. Vasodilatory shock, on examination, patient will be warm, dry with white pulse pressure. Okay, need to see the capillary refill time. For other hemodynamic mechanics like passive leg raise test, hmm, and patient will present with a white pulse pressure. Obstructive shock, okay, very similar to the cardiogenic shock, but look for other signs. For example, echocardiography, it is one of the most important tools to differentiate between these. There is loss of lung sliding in case of pneumothorax, okay, presence of a lung point. One can find out signs of pulmonary embolism. Any intracavitary obstruction is there. Any localized effusion is there. Last but not the least, we have the hemorrhagic shock, where it will be a narrow pulse pressure with underfilled left ventricle and hyperdynamic systolic function. So post-cardiotomy cardiogenic shock, it is found in 2.4% of the cases in case of an isolated CABG, 3.9% in aortic valve surgery, and 7% in case of a mitral valve surgery. It has a 20% mortality with risk factors like it is more common in case of older age group, female sex, preoperative renal failure, preoperative cardiogenic shock, and pre-existing left ventricular dysfunction. The management is very similar to any heart failure management. There is also something called a secondary cause of a post-cardiotomy cardiogenic shock, where ischemic injury is the most important contributor, and it results from graft-related factors, intraoperative ischemic reperfusion injury, any coronary artery injury, or any kind of other acute coronary lesion. And in such cases, atrial arrhythmias are common. Vasodilatory shock, the risk factors include how much is the duration of the cardiopulmonary bypass? Preoperative, whether any AC inhibitor has been used. So probably it might cause further hypotension of the patient. Vasopressor use. Alternative etiologies for these cases include if the patient already is in sepsis, has an adrenal insufficiency, uh, other comorbids like liver failure, pancreatitis, and such the population who are at very high risk of a postoperative sepsis are those who are undergoing surgery for infective endocarditis, or those who are undergoing an orthoptic heart transplant. Hypovolemic and hemorrhagic shock. So basically, bleeding in post cardiac surgery we will be discussing in detail in the next further topics. So I'll skip this part. Obstructive shock, we need to see the causes of the obstructive shock like cardiac tamponade, pulmonary embolism, any pneumothorax is present or not. How will you manage? So correct the mechanical problem first. If there is any bleeding, any tamponade, immediate whether any surgical correction is needed. Optimize preload. Start with a crystalloid infusion, okay? And colloid has been mentioned in the guidelines, but we usually go for crystalloids. Optimize the vascular tone and perfusion pressure. Most commonly used is noradrenaline, even for a cardiac case. Optimize myocardial contractility, just like in case of any failure case, dobutamine, milrinone needs to be used. Any kind of tachybrady arrhythmias needs to be managed accordingly, whether pacing is needed, whether electrolyte correction needs to be done, any kind of antiarrhythmics or electrical cardioversion needs to be seen. Optimize the oxygen delivery and treat the cause. For example, patient is in sepsis. Any surgical correction is needed. Management principles. Our next topic is management principle and diagnostic evaluation in a post cardiac surgery bleeding episode. So basically, per 12 hours, severe hours. The Bleeding Academic Research Consortium definition says 2 liters in the chest tube output within 24 hours of CABG. So these are two definitions which have been given. Any one of the definitions you can mention in the exam. And there are various risk scores like will bleed, has blood, and Papworth score, which helps in identifying the at-risk patients. And excessive bleeding in the cardiac surgery increases the risk for re-exploration. And prompt re-exploration for bleeding, it reduces the risk of adverse outcomes. So basically, one needs to be very prompt with the decision if re-exploration is needed. Causes of post-cardiac surgery, bleed. So there could be surgical causes, there could be medical causes. Surgical causes, if there is a poor hemostasis, any accidental injury, coronary artery graft and anastomotic failure. Uh, Medical causes of post-bypass hemorrhage includes hemodilution, hypothermia because of clotting factor dysfunction, preoperative platelet inhibitor therapy, inadequate reversal of heparin. So these are the causes, or you can divide them into patient-related variables, preoperative medications, and procedure-related variables. So how to minimize these operative blood loss? So how are we going to minimize? So when a patient has come from a surgery or is going into a surgery, what are the things we need to think of? We can divide it into preoperative, intraoperative, and postoperative measures. First of all, identify the at-risk bleeding patients. All right. Correct anemia if need be. So anemia is one of the risk factors for any kind of cardiac patient. It can further worsen failure as we have studied yesterday. All right. And then fibrinogen level testing, platelet function testing if the patient is on dual antiplatelets. So those are needed. Intraoperatively, one needs to maintain the homeostasis, minimize the hemodilution, individualize the heparin protamine titration in 1:1. Normothermia needs to be maintained, prevention of fibrinolysis, use of tranexamic acid, and use of a cell saver. Salvage pump blood via either hemofiltration or cell saver is needed. Post-operatively, point of care tests are needed. If the patient needs any kind of blood products, then one has to be proactive in giving of these blood products. Okay, appropriate blood product uh, has to be given, and one can use point of care testing. Even TEGs are available, ACT is available in the OTs, in all of cardiac OTs. So these needs to be used for point of care testing. This is a very important slide because I think it gives not only the importance of stopping the antiplatelets prior to coronary bypass surgery, but also for other surgeries, we can use this slide. So basically, if the patient uh, is on aspirin, emergency surgery, proceed for surgery. Urgent or elective surgery, also we continue the aspirin. And if it is a very high risk bleeding case and or patient is refusing transfusion, then there are guidelines to say that you can stop it at least 4 days preoperatively. But nowadays we do not stop, we continue with the aspirin. But if the patient is on dual antiplatelets, what do we do? Emergency surgery, just proceed with the surgery. For P2Y12 inhibitors, what is supposed to be done? For ticagrelol, stop it more than 3 days, clopidogrel more than 5 days, and prasugrel more than 7 days. Continue with the aspirin and consider bridging with cangrelor of the GP2B or GP2B 3A blockers in high risk thromboembolic cases. For elective surgery, also, we need to delay this or stop this before the surgery, but continue with the aspirin. So, for patients scheduled with the CABG, it is advisable to cease these at least 4 hours before the operation. So, for G2P3A blockers, it is advisable to be stopped at least 4 hours before the operation. So, that needs to be remembered. Continuing with the anticoagulation. Now, this is also very, very important slide that one needs to understand. So, when do we withhold the anticoagulation in such patients? So, suppose this is the day of surgery. For a low molecular weight heparin, one needs to stop 1 day prior. Okay. But after the surgery, it can be started after 24 hours if indicated. Okay. Coming to the DOACs needs to be stopped at least a minimum of 48 hours before the surgery. I'm telling minimum of 48 hours. And it can be restarted at least, a minimum of uh, 3 days after the surgery. And the low molecular weight heparin, and what I mean to say is that when we start unfractionated heparin and low molecular weight heparin 24 hours after surgery, then it can be bridged with the DOACs at least 3 days after the surgery. Okay. And in case the INR is more than 2 or the INR is more than 2.5, then the low molecular weight heparin needs to be stopped. And later on, you can start off with the vitamin K antagonist. So this is one of the most important slides. And vitamin K antagonist needs to be stopped 5 days prior to the surgery. So this is one of the most important slides. Please just keep this picture in your mind and produce it in the exams. Empiric dosing of heparin is given to achieve an ACT of more than 480 seconds, which is recommended in case of any OT. And heparin resistance needs to be which is defined as achieving an ACT of less than 400 seconds even after administration of 300 international unit per kg of heparin. This resistance may necessitate giving a higher heparin dose. All right. So patient might have a risk of having a higher residual heparin post-operatively, and maybe a higher risk of bleeding. So patient blood management, what is the target of hemoglobin? The target of hemoglobin it is a gray area. While the guidelines say the females, the target should be kept as less than 12. For the males, it should be kept less than 13. And IV supplementation has to be done. We have got various trials in acute myocardial infarction, in case of various cardiac surgery, which suggests that we can keep around 10 because there is no significant difference between keeping it at around 7 8 or around 10. So most of the trials based on most of the trials will keep around 10. Recommendation for the post operative management: in the post operative management, one has to have a low threshold for identification of the bleeding. Check for the tube drainage output. What is the tube drainage output? Any triggers for the re-intervention of bleeding is there, whether there is any hemodynamic instability. Prompt correction of the triads, the lethal triad needs to be done. Okay. And VT profile access, LMWH should be considered for the patient, but we need to have a low threshold even for bleeding after that. Detection of hit should be early. So if the patient has a high risk for bleeding, or you are thinking regarding bleeding, immediately get an X-ray done. Quantify the degree of the bleeding, hemodynamic status, coagulation studies, repeat the studies if need be, and obtain a TEE if you're concerned about a tamponade. So management, if there is a bleeding or a tamponade, manage accordingly. Check if your chest tubes are patent. Control the lethal triad. Control the hypertension, agitation. Normothermia needs to be maintained. Check the point of care testing. Give ionized calcium. Protamine is to be given 25 milligram IV for 2 doses if there is an elevated PTT, or infusion can be given over 6 hours. Then use PEEP with caution. Give off the blood products. So basically, protamine is given, platelet in case there is any dysfunction, fresh frozen plasma if the INR is more than 1.5, or you can also use a PCC. And for fibrinogen, low fibrinogen, one can go for a cryoprecipitate or a fibrinogen concentrate. Also, recombinant factor 7A has been used as an off-label use for a patient with uncontrollable coagulopathy, with a dose being 90 gram per kg, followed by a second dose after 2 hours. And the half-life is around 2.9 hours. So general guidelines for re-exploration is what? More than 400 ml per hour for 1 hour, more than 300 ml per hour for 2 to 3 hours, or more than 200 ml per hour for 4 hours. See this, if the bleed is more than this, okay, then re-exploration of the patient is required. And it is found that early exploration reduces the adverse outcomes by minimizing the use of multiple transfusion, averting hemodynamic instability and low cardiac output syndrome, which can lead to multi-organ failure. It also reduces the risk of tamponade and cardiac arrest events and lowers the risk of wound complications. So the multidisciplinary approach, this is the star slide that you have to remember. The prior admission, preoperatively, how are you going to manage? Intraoperatively, what is the minimal things you can do to decrease or minimize the postoperative bleed? However, if there is a bleed, what is the algorithm that one has to manage? So this is the guideline 2024 EACTS guideline on the management. So cardiac arrest following cardiac surgery. This is one of the questions that is anticipated. It will come in one of the coming years. Okay, CALS protocol. So please listen. What is the difference with the our normal algorithm for the cardiac arrest? So how is this post cardiac surgery cardiac arrest different from that of the normal the regular algorithm that we study? So first, it is always witnessed. The cardiac arrest occurs after 0.7 to 2.9% of the cardiac surgery cases. The survival chances in such cases is around 80%. Okay, it is rarely sudden. You will have some signs or symptoms 12 hours prior to, or just immediately after the OT. You will have some signs that needs to be recognized. Either the lactates are going to be high, the blood pressure will not be settled, there will be increased output, worsening oxygenation, or some rhythm abnormalities. There's usually no delay in the diagnosis because such patients are maximally monitored, and these patients are in the hospital. So early management is the key in such cases. And if the patient has arrested in front of you, obviously the patient management will be early. It is usually due to an early reversible cause. The most common causes are VF, cardiac tamponade, or any major bleeding. Reopening the chest is the final common pathway. Of the 4H and 4T, which are applicable in all the amenable cardiac arrest cases in a post cardiac surgery, okay, for other cases, you might go for shock. For other cases, you might, give the drugs. But in a post cardiac surgery, cardiac arrest, the one line that you have to remember is reopening the chest is the final common pathway. Okay. So, assignment of this goal is to provide the definitive treatment as early as possible. Whether you open the chest or you defibrillate, timely desternostomy is an important goal, as CPR is ineffective in such cases. Okay. So, manage the main management first. Even if you give CPR, Ideally such patients need to be opened up and call a surgical emergency. This is one of the cases where it is a surgical emergency, and get the surgeons in the OT ASAP. Okay, 6 roles which are assigned. So what are one person has to be there for the external cardiac massage, one person has to be there, that means for the CPR. Airway breathing needs to be managed, so one person needs to manage the defibrillation. There has to be a team leader like any other cardiac arrest protocol or ACLS protocol. Drugs and syringes, one person can manage, and there has to be an ICU coordinator. So this is another important role which is different from that of the other cardiac arrest cases, where the ICU coordinator has to run and call the OT and activate along with the surgeons as early as possible. So coming to the cardiac arrest protocol. So first is assess the rhythm. What is your rhythm? We have whether you have a ventricular fibrillation or a tachycardia. Okay, whether you have an asystole or a bradycardia or a pulseless electrical activity. So if we have a VF or a tachycardia, all right, go with 3 attempts of DC shock. This is another difference that you have from the previous the other ACLS protocol. 3 attempts of DC shock. Okay, for asystole and for the bradycardia, symptomatic bradycardia, go with the pacing as early as possible, and start basic life support. So before you start anything else, CPR, everything else, please make sure that if this is the protocol and the cardiac arrest is because of a post cardiotomy case, this is what has to be done. Start basic life support, go with the drugs. For a VF or tachycardia, the drug of choice is not giving adrenaline. You have to give an amiodarone 300 milligram via the central line. For an asystole or a bradycardia, give atropine 3 milligram or consider external pacing. And if paced, turn off the pacing to exclude any underlying VF. Okay, this also needs to be checked. And hello. Okay. Prepare for an
जो आप
emergency.
लाओगे सब खा सकते हो नहीं
Prepare for an
पढ़ना है कंसोलिडेशन
hello. Okay. Prepare for an emergency resternotomy. Kindly mute everyone. Prepare for an emergency resternotomy. Okay. Continue the CPR with a single DC shock every 2 minutes until the resternotomy happens. Continue CPR until the resternotomy. Continue CPR until the resternotomy. So what one has to remember, that resternotomy is the final common pathway for this kind of arrest. Okay. And manage the ventilation. Put on 100% oxygen, switch off the PEEP, bag and valve ventilation has to be done. Check if there is any pneumothorax or a hemothorax. If there is any tension pneumothorax suspected, immediately place the large bore cannula. Do not give adrenaline unless a senior doctor advises. Of pacing for more than a minute. Suppose things are not available, then go for a basic life support immediately. Okay, so defibrillation, this is a class 2A level B. Pulseless ventricular tachycardia, ventricular fibrillation, delay the external cardiac massage. Do not give a CPR unless it is more than a minute. Give shocks. Pacing is required as early as possible in case it is available. Resternotomy, inability to obtain a systolic blood pressure more than 60 millimeter of mercury on the arterial trace. Please go for an emergency resternotomy. Activate the OT. Infusions in established cardiac arrest, all the infusions need to be stopped. Okay, automated external defibrillator should not be used in cardiac surgical patients. If a manual defibrillator is available, and it should not, as I said, AED should not be available. It in fact causes more harm rather than benefit. Epicardial pacing for asystole or severe bradycardia, connect the epicardial pacing wires set to DDD mode at 80 to 100 beats per minute. That is a class 1 recommendation. For atropine, in other cases, it is not recommended. Asystole, extreme bradycardia, initially do not do atropine. Okay, there is no benefit. First do pacing. So pacing is what has to be done. Then later on go for other drugs. And emergency resternotomy, we have been mentioning it again and again. So the word that you need to remember is maintain if the blood pressure is less than 60 millimeter of mercury, then go for the emergency resternotomy within 5 minutes. Within 5 minutes. And even if resternotomy, if you have a center where ECMO is available, then go for a rapid initiation of ECMO, which is an alternative. Uh, which is an alternative. Okay, internal versus external cardiac massage. In fact, internal cardiac massage is said to be more productive than that of an external cardiac massage in such patients. Okay, and in fact, internal defibrillation can also be given directly to the heart. 20 joule shocks can be performed, and 5 joules in case of a patient with bypass. So the critical points are what? Call the code, notify the cardiothoracic surgeon, connect to the defibrillator, emergency pacing button, give stack shocks in case of VT and VF, aim for a systolic blood pressure of more than 60 millimeter of mercury. All right. If defibrillator is not available or pacing is not available more than a minute, then go for the CPR. IABP change to pressure trigger. Drugs amiodarone is given, but we do not give atropine, adrenaline in such cases. And emergency resternotomy to be done like arranged within 5 minutes, or alternative being ECMO. So this is the guideline that I have taken it from. I hope if this question comes, nobody is going to mess it up, because it has been very, the last slide is what you need to produce. Coming to the concept of defibrillation, this will be the flow of my talk. All right, there's a short history that one can go through if they are interested. So, defibrillation is a non synchronized delivery of a shock randomly during the cardiac cycle. Most of them are energy based, and the amount of energy that uh, that is given in the myocardium is dependent on the selected voltage and the transthoracic impedance, which varies in different patients. Okay, the application is giving the electrical current across the heart to convert the VF or the VT rhythm into the sinus rhythm. Now, there are two types. One is the impedance-based defibrillator. The other is the current-based defibrillation. The impedance base allows the selection of transthoracic current based upon the transthoracic impedance, and the current based is independent of transthoracic impedance and body weight and gives a fixed dose of current. Now, what is the principle? The principle is basically at cellular level, there is alteration in the transmembrane potential. The delivered current flows around through the myocardial cells and causes alteration in the transmembrane potential. And there are two mechanisms at the organ level. One is the critical mass hypothesis, and the other is the upper limit of the vulnerability hypothesis. Now, critical mass hypothesis is DC shock produces a current in density which depolarizes a critical mass of the myocardium, thereby leaving insufficient myocardium to maintain the re-entrant tachycardia and prevent the reinitiation. So basically, there will be one part of the myocardium which will be depolarized, another part of the myocardium which will be hyperpolarized, and in between there will be a small area of the myocardium which is the critical mass of the myocardium, which uh, where the current density is produced. So the critical point is formed on the boundary between the depolarized and the hyperpolarized region, and the hyperpolarization can de-excite the tissue that was depolarized just before the shock, thus restoring the excitability of the myocardial in that region. Okay, and the next one is the upper limit of vulnerability hypothesis. So basically what happens is, when you have any kind of uh, uh, these VF or the VT, so basically this happens between a threshold of the shock strength. We have a lowest threshold and it can extend up to a highest threshold of the shock strength. So to successfully defibrillate the patient, one needs to go above the shock strength, should be above the strength of whatever the VF or the upper limit of the VF strength is. Okay, I hope you are able to understand. So to successfully defibrillate, the shock strength must be greater than the largest shock that initiates the fibrillation. So this is called the upper limit, and this is the second hypothesis that uh, is the principle of the defibrillation. What could be the factors that affect the defibrillation? So basically, we have got the electrodes. It can be enteroposterior. Enterolateral. It can be enteroposterior, or it can be double sequential external defibrillation, where you have the enteroposterior and the enterolateral leads which are stacked together, and they give a continuous shocks from the two defibrillators. It is mainly used in case of refractory ventricular fibrillation, or in case of an even electrical storm. Pad size can affect the defibrillation. It decreases the resistance, increases the current flow, and causes less myocardial necrosis. ANSCO guidelines suggest more than 8 centimeter square size pads. Okay, optimal electrode size is also needed. Approximately, it is said to be around 12.8 centimeter. Handheld uh, paddle electrodes are more effective than the self-adhesive patch electrodes because the pressure applied will be uniform and it allows the electrode to be closer to the heart. Then monophasic versus biphasic. I think everyone knows this by now. Biphasic will defibrillate more effectively compared to and at lower energies compared to that of monophasic waves. Uh, Patient-related variables include transthoracic impedance. So if we have this around 70 to 80 ohms is normally present, and the effect is determined by multiple factors. For example, the energy level that one has used, electrode to skin interface, inter-electrode distance, electrode pressure, phase of the ventilation, and the blood conductive properties and the conductive properties of the tissues. For example, the composition of the gel itself can result in some kind of impedance and affect the defibrillation of the patient. Type of arrhythmia. Primary ventricular fibrillation will be easier to defibrillate compared to that of any kind of secondary VF, maybe secondary to any heart failure. Monomorphic VT needs a smaller current compared to that of a polymorphic VT and VF. Okay. Duration of the arrhythmia. If the duration of the arrhythmia has already been longer, then the effectiveness gets reduced. If it is a recent onset, then it is more effective compared to that of a late onset. Use of antiarrhythmics can also increase or decrease the defibrillation. Sodium channel blockers increases the energy required for defibrillation, while potassium channel blockers and catecholamines decrease the energy needed. CIED, or the cardiac implantable electronic device. Now, the position of the electrode pads should be such to avoid any contact with the skin overlying the CIED to maximize the efficacy and minimize the damage to the CIED. Circumstances in which the patients may be refractory to the defibrillation: extreme hypothermia, intoxication with volatile solvents, prolonged resuscitation or prolonged hands-off downtime, that is arrested but CPR has not started. Chronic amiodarone therapy, it increases the energy requirement in case of shock by about 60%. Phenytoin therapy, it may theoretically increase the resistance of the myocardium. Complications, the DC shocks are more effective and less damaging than the AC. Repeated shocks causes myocardial damage, electrocution of the members of the resuscitation team. That's the need for saying all clear. Biphasic causes less myocardial damage. It can cause burns, and implanted defibrillators or other metals, there might be some impact on these devices. So this is the star slide that one can go through. It has got everything from paddle size and position, the shock dose, sedation, anticoagulation mechanism. All right. In case of an AF, one needs to know when to give the anticoagulation. All right. Less than 48 hours, more than 48 hours. Uh, for cardioversion in the AF patient, there is a risk of thromboembolism. So you do not immediately shock the patient. Okay, you wait, give anticoagulant therapy, wait for 3 to 4 weeks, which decreases the embolism. So this is one important point that can be mentioned when you are talking about this. Okay. Coming to our next topic, which is complete heart block and pacemakers. Here I'll be essentially talking about pacemakers. So pacemakers are the electronic devices which stimulate the heart with electrical impulses to maintain and restore the functional heartbeat. And there are three types. Mainly, you have the permanent ones and the temporary ones. The temporary ones are mainly the portable ones, which can have a pulse generator with exteriorized electrodes for the temporary transvenous pacing, or you can have the battery powered cardioverters for the temporary pacing. Now, all the pacemakers consist of two components. One is a pulse generator and the other is the electrode or the leads, which can deliver the electrical impulse to the myocardium. It can be single chamber. Okay. So for example, we have one which is in the ventricle. So this is in the ventricle. Then we can have the dual chamber, which uses two leads to stimulate one the atrium and the other the ventricle. We can have a biventricular one, for example, the two leads, one is in each of the ventricles, and even leadless pacemakers are nowadays are available, and these biventricular pacemakers are the one which are the cardiac resynchronization therapy devices. Indications of temporary cardiac pacing. So we have sick sinus syndrome, heart blocks, drug refractory dysrhythmia, and the cardiovascular surgery. So cardiac sick sinus syndrome, if symptomatic sinus arrest or sinus pauses, suppression of the ventricular ectopy resulting from bradycardia, atrial fibrillation, brady syndrome, and symptomatic sinus bradycardia. So these are the indications. Heart block, type 1 and 2, usually these are not the class 1 indications. Okay, type 2 symptomatic secondary heart block is actually a class 1 indication, and acute bifascicular or a trifascicular block, complete AV block, or cardiac arrest is class 3 indication. So these are the indications.
This meeting is being
Can be
recorded.
non-atrium, ventricle, or dual modes. Then we have chamber sensed, non-atrium, ventricular, and dual, where the chamber sensing has happened and response to the sensing. So after the sensing takes place, the chamber sensing the sense chamber and the response to the sensed event. CE for sensed, and RSS response to the cardiac event. For example, we have DDD. So pacing to both the atrium and the ventricle is happening here. Sensing to both the atrium and the ventricle is happening here. It can either inhibit or trigger the pacing. So DDD. Similarly, we have the VVI. The most common modes are the VVI and the DDD. And most pacemakers will respond to a magnet exposure by becoming asynchronous. All right. So this is an important point that one needs to remember. The four basic concepts of pacemaker functioning are connection, output, capture, and sensitivity. So where the connection is happening, usually, so we have this. I believe everyone has seen a temporary pacemaker in their ICUs, and we have the buttons, the various buttons which manage the rate, the voltage, and the sensitivity. And it can be seen, whatever you are changing can be seen in the monitor of the temporary pacemaker. One also has the connections. So we have the atrial connector here, the ventricular connector here, and then we have the battery connector somewhere below. Okay, so these are the connections that are seen in case of a temporary pacemaker. Other terminologies include what is rate, the pacing rate in beats per minute. Usually it is set as a backup rate. The output of the pacemaker, it is the current which it produces as a brief pulse. To prevent loss of capture, the output is set 1 to 1.5 times higher than the identified pacing threshold. Sensitivity of the pacemaker electrode is the minimum voltage that is required to detect the P wave or the as a P wave or an R wave. And the normal settings is around zero point 0.4 to 10 millivolt for the atria and zero point 0.8 to 2 millivolt for the ventricles. What is a capture? It is the effective stimulation of the cardiac depolarization by the pacemaker. If the atrium is paced, then the spike will appear before the P wave. If the ventricle is paced, the spike will appear before the QRS complex. Capture threshold is what? It is the minimum amount of current which is required to initially depolarize the chamber. So capture and capture threshold. So what are the problems that one faces while using these pacemakers? Here we are talking mainly about temporary pacemakers because that is something that we commonly use in our ICU. So what are the problems that we face? We have the capture failure, and we have also the problem of detecting the intracardiac signals, which is the sensing problem that could be undersensing or oversensing. And sometimes the pacemaker itself can pseudo malfunction, which could be rate related, atrioventricular related, okay, or even the model related. So factors which influence the capture and the sensing, it could be fluid status changes, pericardial effusion, electrolytes, medications, battery failure, uh, low generator voltage or high pulse generator amperage. development of endothelial sheaths, any kind of dislodgement, disconnection, or the fracture. So these things will cause any kind of output failure as well. Capture failure. So the main problem, you can remember the capture failure as bed fast. What is bed fast? Battery failure, disconnection at any point, fracture of the wires and cables, settings which are inadequate, or any threshold change which can lead to a low output state. Okay. And for we have one of the examples here. For example, ideally after a pace, you have this spike, right? So after a spike, ideally we should have had, this is a ventricular pacing, and ideally after a spike we should, like dual chamber pacing, we have the atrium that is the pacer before the uh, uh, atrial rhythm, and then this is the ventricular. So before that, ideally the pacer should be there, but here there is a distance. So here there is a failure to capture this, and this is a failure to capture the ventricular spike. Okay. So the pacing threshold is the minimum energy that is required, which constantly triggers or depolarizes the pace chamber. This we have studied in the previous slide. And now we need to understand what is sensing. Okay. So under sensing occurs when the pacemaker fails to detect the spontaneous myocardial depolarization, and it which results in asynchronous pacing. So atrial and ventricular pacing spikes arise regardless of the P waves or the QRS complex. Ideally what happens, you have the spikes and which is followed by the wave, right? But suppose the spike is happening irrespective of the waves. So in this case, there is a ventricular undersensing. So the spike should ideally have been here, correct? And then we should have the ventricular this waveform, but it has happened after. So this is ventricular undersensing that is happening, and the main causes could be improper sensing threshold, any kind of insufficient signal, or fibrosis, fracture, or an electrolyte abnormality as well. Coming to oversensing. So oversensing, what happens is the pacemaker itself, it encounters some abnormal electrical signals, because of which it will not be able to give the proper pacer spikes, and thus the sensing will also not happen. So ventricular oversensing, example being here, what is happening here is, after the third sinus, ideally there should have been a pace, and then the sensing should have happened, right? So here the ventricle would have detected some electrical signals by the patient themselves, as a result of which the pacing spike is absent, and thus this is not followed by a waveform. So there is inappropriate inhibition of the pacing and an asystolic pause that has happened. So failure to capture, there is the pacemaker stimulation do not result in myocardial activation, and failure to pace, that is the pacemaker does not stimulate as expected. So how are we going to uh, do this pacemaker setup? Locate the generator, see if the battery is working or not. Each wire needs identify each wire which has to go in the atrium and which has to go in the ventricle. Epicardial ventricular wires exit on the left side of the chest. Atrial wires from the right side of the from the right side. Identify for the positive and the negative leads. Okay, attach the wires at the appropriate site. See, turn the pulse generator on, and whatever rate has to be set. Usually for a surgical patient, it is 90 to 110. For medical patient, 70 to 90. For a cardiac arrest patient or cardiac patient, 80 beats per minute. Okay. Then set the milliamperage. In non-urgent situations, 10 milliampere. In emergent situations, 15 to 20 milliampere. It is normally kept. And see for the sensitivity. Usually adult guidelines say start at 2 to 5 millivolt. Okay. If failure to sense occurs, then turn down the sensitivity. If the pacer is sensing beats which are not usually present, then turn the sensitivity up. So this is an important point that one needs to know to prevent undersensing and oversensing. All right, see for the patient responses and keep continuously securing the wires and all the connections. Complications, this CRT I'm not going to discuss. We have discussed the guidelines yesterday. Complications, implantation related and delayed. There could be hematoma, infection, pneumothorax, hemothorax. There could be fracture, dislodgement, pacemaker induced cardiomyopathy, thrombosis, pacemaker mediated tachycardia and all. So this is the star slide. If you go through this one slide, I think you will, whatever I have covered is present in this one slide. Okay. Coming to electrical storm, this is another very important small topic which might come. So what is an electrical storm? Basically, that you have 3 or more episodes of the ventricular fibrillation or ICD shocks which are happening within 24 hours and that need intervention. Generally, it is associated with poor outcomes. The triggers being, it could be drugs, it could be electrolyte abnormality, any kind of heart failure, ischemia, thyrotoxicosis, QT prolongation. These are the triggers for the electrical storm. Pathophysiologically, there is a neurohormonal balance with these predisposing condition. There is increase in the action potential depolarization, calcium overload leading to altered phosphorylation of the calcium handling proteins, and thus it can also lead to structural remodeling, re-entry leading to VF and defibrillation. Clinical presentation, they can span from relatively minor symptoms in hemodynamically stable patients like palpitations, syncope, or it can also lead to cardiac arrest. ECG changes you might not likely capture it on a standard 12 lead ECG, but it might require continuous monitoring with a surface ECG or continuous ambulatory telemetry or intracardiac electrograms as recorded by an ICD. All right. These are the percentages of the electrical problems where we find electrical storm, uh, and the maximum being in monomorphic VT. Diagnosis, as I said, your typical ECG might not give, and a telemetry monitoring or intracardiac electrocardiograms from a patient's ICD might be needed. Okay, differentials in a patient without the ICD, usually any kind of QRS complex cause might be a DD for this. And in patients with ICD, one needs to know that apart from the usual wide complex tachycardia, there could also be possible ICD malfunction. Treatment, hemodynamically unstable patient, go for the normal ACLS protocol for a VT or a VF or any kind of tachyarrhythmias. Okay, sorry. And for hemodynamically stable patient, you treat it with drug therapy, that is IV amiodarone is the drug of choice, which is one can also go for a beta oral propanolol. Oral propanolol is what is said, 40 mg every 6 hours for the first 48 hours. Okay, if there is a torsades point is happening, then magnesium 1 to 2 gram IV is given. And in a patient with ICD, go for an ICD interrogation and assessment of the programming. Coronary revascularization are needed in case of an MI case. Subsequent management may involve catheter ablation, maintenance of the antiarrhythmic therapies, and condition-specific therapies. For example, pacing might be needed, heart failure therapies, any kind of revascularization, correction of electrolytes, removal of any offending drugs, okay, and any inciting factor that needs to be removed should be removed. Refractory cases are managed by thoracic epidural anesthesia, IABP, or any temporary assist device. Stellate ganglion block has been said to be one of the temporizing measures, along with terminal sympathectomy via surgical cardiac sympathetic denervation or orthoptic heart transplant may also be needed in case of eligible non-responders. Renal artery denervation and stereotactic body radiation therapy have also been mentioned as potential management for refractory cases. So this is the one slide that you should know. More than 3 sustained VTVF in 24 hours, more than 3 ICD therapies in 24 hours, or recurrent VT within 5 minutes, the substrates, the triggers, the autonomic dysregulation, and the management while managing them chronically. So this is one chart, the star slide that we need to follow. Coming to our next topic, which is the long QT syndrome, another emerging cardiology topic, which had come actually last time as a long question. And we were wondering actually what to write. But at the end of the day, you can somehow gauge. But right now, just go through this slide very carefully. It is primarily diagnosed in a 12, you have to see the 12 lead ECG. Okay. And see for the normal QT interval, which is will starts with the beginning of the Q wave to the end of the T wave. So this is your QT interval. And a prolonged QT is said when the in case of more than 450 milliseconds in case of men and more than 470 in case of a female. And QT interval, one needs to understand how to what the formula is. We have the Bezet formula, we have the Fredericia formula. Bezet's formula is normally used, which is QT divided by the RR interval, and And then we have the risk factors for QT prolongation. What could be the risk factors? The cardiac factors, congenital long QT syndrome, history of prolongation, I'm sorry, bradycardia, ischemic heart disease, myocarditis, infarction, LVH. Medical conditions can include any kind of stress, starvation, hepatic or renal disease. In case of female, sex, medication related, and even metabolic, that is, dyselectrolytemia might also cause a QTC prolongation. Now, what is the pathophysiology of this prolonged QT? When we have the normal sodium potassium pump, there is depolarization which happens because of net influx of the sodium, and the repolarization which happens because of net efflux of the potassium ions. So, in the pathophysiology involves mainly this most of the time. I'm saying most of the time, not every time, but most of the time, it involves the potassium channels. Okay, there are drugs which block the potassium channels, producing a repolarizing current, which is termed as delayed rectifier current, and it results in a longer action potential, resulting in a delayed QT interval. Coming to the congenital causes of the long QT syndrome. So we have various causes. One needs to remember, this might be a busy slide, but what you need to remember is just this, okay? This and probably this, the protein and this. So the ECG morphology, you have the LQT1, long QT2 and long QT3. Long QT1 comes with a broad T wave. Long QT2, it comes with a bifid T wave. Okay, bifid T wave, and long QT3, it comes with a late T wave. Usually, what is the pathophysiology? The protein blocked here is, in case of type 1, the gene involved is KCNQ1, and the protein involved is it basically, the potassium channel is what is the current that is involved. In case of type 2, we have the the potassium channel again. But in case of type 3, it is very similar to the Brugada, the sodium, the high sodium channel is involved. Okay. And the trigger for the long QT1 is exertion, fright, and swimming. For the long QT2 is auditory, and the long QT3, even at sleep and rest, they can develop a long QT3 syndrome. Then QT1 is mainly long QT1 is in case of males. The other two are in case of females. And the onset of arrhythmias for one type is non-pause dependent. Pause dependent in case of type 2, and type 3 can happen even at lower rates. And beta blockers are essentially the treatment for all three of them. A sodium channel blocker may be required in case of type 3. Other causes of long QT syndromes are Romanov-Ward syndrome, Jelvin-Lenz-Nielsen syndrome, Anderson-Tawil syndrome, and Timothy syndrome. What are the medications which are associated? We can have antibiotics like erythromycin, clarithromycin, ampicillin, cotrimoxazole, antimalarials, antiarrhythmics, quinidine, disopramide, procainide, sotalol, amiodarone, bretylium. All these can cause. And other causes are amantadine, cyclosporin, hydroxyzin, methadone, nicardipine, tamoxifen. So there are a lot of drugs which are involved in case of a prolonged QT. And how do we diagnose, or how do we find out there is a probability of a long QT? So the probability score is called the Schwartz score, and the score of more than equal to 3.5 indicates a high probability. It involves the electrocardiographic findings, clinical history, and the family history of the patient. Clinical presentation. So first, get a proper medical family history with a 12 lead ECG, an exercise ECG, and an imaging of the patient. Go for other tests also, like electrolyte abnormalities, any kind of metabolic diseases or structural diseases which might be present in the patient. Manual confirmation of QTC and corrected QTC is required. Calculate the long QT risk score, that is the Schwartz score. All right. It could be less than equal to 1. It could be 1.5 to 3. If it is more than equal to 3, then the probability is quite high. And if the QTC is more than 500, then on repeated ECGs, then there is no need for further testing. That is a probability of a high, a long QT syndrome. Stop the medications after the weighing the risk and benefit analysis. ECG is needed. Follow up after 8 to 12 hours. Monitor the electrolytes of the patient. Okay, and consider for a cardiology referral. A QTC of greater than 500 is associated with a twofold or a threefold higher risk of a torcidus D pointus. All right. So what is the treatment like? The treatment, as we have said, any kind of QTC that presents, one needs to go for a beta blocker. If the patient has come in a cardiac arrest, ICDs might be needed. Okay. And then one might need even the left cardiac sympathetic denervation might be required in such cases. Additional pharmacological therapy of blockers of late sodium invert current, that is mexiletine, flecainide, and ranolazine might be needed. And a newer drug, which is called as lumacaftor, has also been implicated for this condition. So this is your star slide. We need to know the causes. First of all, what it is, what is the presentation, what are the genes involved, what are the acquired drugs involved, what is the pathophysiology, the diagnosis, and the risk factors with the management. So first line will always be beta blockers, and the high risk patients which are not responsive to the first line go for an ICD or a cardiac sympathetic denervation surgery. VA ECMO. So now we come to the range of what is called as VA ECMO, and this will be the flow of my slides. VA ECMO is a form of extracorporeal life support. It is a temporary support of patients with acute on chronic cardiac or circulatory failure. And it comprises of a drainage cannula. The circuit comprises of a drainage cannula that removes blood from the right atrium or the large central vein, and it is oxygenated and then reinfused into a major artery. So basically, VV has venous cannulation only. VA has got both the cannulations. VA is mainly for the pulmonary flow. It maintains the pulmonary blood flow. VA ECMO decreases the pulmonary arterial pressure. VV ECMO does not assist systemic circulation. VA ECMO cardiac support, it assists in the systemic circulation. VA ECMO, it is not used in case of right ventricular failure. VA is used. Perfusion rate requirement is quite high. Perfusion rate requirement is low. And lower PaO2 is achieved. A higher PaO2 is achieved. ECMO circuit connection is in series in case of VV ECMO, a very important point. And ECMO connection circuit is in parallel in case of a VA ECMO. There are fewer complications. I wouldn't say fewer, but what I'll say is there are certain VA ECMO specific complications which we'll be studying. So, this is the image that depicts the circuitry of the VA ECMO, where the blood is drained from the venous side, and then it passes through an oxygenator and a blender, and then the oxygenated blood is then carried and it is pumped back into a major artery. It can be of two types. The cannula can be of two types. One is a peripheral cannula, the other is a central cannula. The peripheral cannula drainage is from the right atrium or vena cava, and infusion is into any one of the peripheral vessels. But central cannula directly drains from the right atrium or the vena cava, and the direct infusion is into the ascending aorta. This is preferred post cardiotomy, as cannulas used for CPB can directly be transferred into the ECMO circuit. Indications: any indication for a refractory cardiogenic shock. Okay, it could be acute MI, decompensated heart failure, post cardiac transplant allograft surgery, any kind of arrhythmias, drug intoxication, myocarditis, peripartum cardiomyopathy, stress cardiomyopathy, cardiogenic shock following the resuscitated cardiac arrest. We have studied in the previous slide, post cardiotomy shock, any kind of bridge to transplant, sudden cardiac arrest. uh, well, ECPR is very common, acute decompensated pulmonary vascular disease, and there are other indications as well. Contraindications. Well, you will not find like contraindications to ECMO. However, uh, what is not favorable? Unrecoverable heart, when there is a disseminated malignancy, known severe brain injury, unwitnessed cardiac arrest, prolonged CPR, unrepaired aortic dissection, severe aortic regurgitation, okay, any compliance issues, any peripheral vascular disease. In those cases, it is a contraindication. Coming to the hemodynamic aspect. Now, the hemodynamic aspect, this is one of the schematic diagrams which show that you are pumping the venous blood. It goes into the oxygenator, it goes into the aorta. So what it does is it goes into the systemic circulation. So what it does is it increases the left ventricular outload and the afterload and the wall stress, and increases the left ventricular pressure. However, it also increases the mean arterial pressure and the end organ pressure. So perfusion is increased. The centrifugal pump delivers the retrograde flow into the aorta and the map and the oxygen delivery is improved. The preload decreases, the venous drainage reduces the RA and the LV filling, improving the systemic perfusion. The afterload increases, it raises the LV afterload. Sometimes the aortic valve might not open. This is one of the things that can lead to an LV distension or a pulmonary edema. At the end of the day, it is used to reduce the myocardial work and provide hemodynamic and respiratory support. And as I have said, it works in parallel, unlike that of the VV pump. Cannulation. So high flows portable cannulas are used. Peripheral cannulation is more common, and the cannula size is around 15 to 17 French of arterial cannula, which is used. It is inserted after an IV anticoagulation of 50 to 100 units per kg. Central cannula cannulation may be done for a severe peripheral vascular disease, but ideally we avoid. Initial settings and titration. So the pump speed is to achieve an extracorporeal blood flow of 3 to 4 liter per minute, and a sweep flow range of 1 to 10 liter per minute, with initial setting starting at a lower end of the range, and obviously 100% fraction of delivered oxygen of 1. Typically, it is not titrated during VA ECMO. We keep it around 1. Respiratory parameters: FiO2 of less than 0.7, PIP of less than 35. These are the respiratory parameters, thresholds that we need to maintain: PEEP of 15, respiratory rate of less than 10. Uh, the pre-membrane oxygen needs to be checked, and it has to be less than the critical threshold. If it is less than the critical threshold, watch for the hypoxemia, perfusion of the right arm if there is a peripheral cannulation. Monitoring has to be done for the cardiac output, pulsatility, ECMO flow, gas exchange, distal limb perfusion. Look for arrhythmias, any lack of pulsatility, and the low flow. Okay. Then blood flow and pressures. So flow 2.1 to 2.4 liter per minute per meter square. Initially avoid basically less than 2, because there could be a risk of clot. Pre-membrane pressures are maintained less than 300 millimeter of mercury. Replace the oxygenator if it is more than 150. And temperature, maintain normothermia. Get a daily basic examination workup like electrolytes, CBC, X-ray, and the KFT markers, along with plasma-free hemoglobin and D-dimers. Blood cultures can be done thrice a week. ACT targets around 140 to 160, with APTT targets of 45 to 55 seconds. Complications: like any other ECMO complication, we have got the neurologic complication. We could have seizures, intracranial bleeding because of so much of anticoagulation is going on. Hematologic, again, hemorrhage, hemolysis. Patient can come with a DIC. They can develop a HIT, retroperitoneal hematoma. Pulmonary, same hemorrhage, embolism, edema. Device related issues, cannula related, circuit related issues could be present. Cardiac arrhythmias can happen: cardiac perforation, tamponade, ventricular distension, thrombosis, infection, because at the cannula insertion site can happen, and renal acute kidney injury patient can also present with. So this is a general ECMO complication. So now we discuss with the VECMO specific complications. What are the VECMO specific complications? Mechanism being of LV distension is what? So as we have studied that from the right side, the blood flows, and then it blends with the oxygenator and comes to the aorta. So there is a persistent LV preload, okay, and a retrograde flow from the outflow cannula, which causes an increased afterload, right? So these
This meeting is
to
being recorded.
diagnose it, an ECG within 2 hours has to be obtained on the. And if the pulse pressure is less than 10 millimeter of mercury despite the inotropes, or there is a pulmonary edema on chest X-ray despite a high PEEP, then we think of an LV distension. Okay, so we decrease the flows, keep the patient on vasodilators, inotropes, diuretics, or dialysis might be included. needed for the patient. Apart from that, any LV unloading strategies, for example, IABP, any kind of a mechanical system, canal vent, LV surgical vent, the artery approaches that we have for the LV unloading strategies. So LV distension, go for a non-invasive approach or an invasive approach. Next, we have the differential hypoxia. This is the second VA specific complication, ECMO specific complication. So what here is no, all right, and the regular deoxygenated blood is flowing and goes into the blender, and then we have the oxygenated blood back. As the patient is having recovery of the cardiac function, so what is happening here? When we have the recovery of the water, the function of the heart, we have the heart as usual will start pumping. So the deoxygenated blood will go towards basically the left side of the heart, right? And then there is a red flow which is coming from ECMO, right, which is the oxygenated blood. So we have a mixing which is happening, which is called the watershed area, which happens in the arch of aorta, or it can also happen depending on which cardiac recovery is happening in the patient. So this mixing results in what is called as the north south or the Harlequin phenomena, where the patient will have a cerebral hypoxemia, but the blood flow in the other areas of the body will be okay. All right. So, diagnosis is usually the saturation and the PaO2 in the right upper extremity is lower than that of the lower extremities. And infrared spectroscopy can help reveal this regional oxygen saturation in the brain. Patient might have ventricular arrhythmias. The venous drainage oxygen saturation will be unusually high. All right. And there is increased pulsatility in the arterial tracing. So, what are the measures to reduce it? Decrease in the native or the impella, like the cardiac output needs to be uh, maintained and reduced, increase in the VA ECMO flow, ventilation optimization, and increase in the FiO2. The definitive or the long term measure would be to convert this VA ECMO into what is called as a VAV ECMO. Okay. Another cannula, a three-way cannula is added to the patient. Okay. So this is a VAV ECMO. Venous drainage cannula in the SVC, central cannulation, uh, getting a reconfiguration with grafted subclavian artery, all right, and conversion of the patient to a VV ECMO. So basically, the blood should not flow completely here. Once the recovery has happened, you gradually change to a VAV ECMO or a VV ECMO in such cases. Another VA ECMO specific complication is a distal limb ischemia. So, usually it happens when the patient is hemodynamically unstable or is on a high vasopressor state where there is a low flow state, or a larger cannula is used in case of younger patients, female gender, any thromboembolic events that has happened, when there are additional risk factors that are present, or patient has a perforation or rupture of the common femoral artery, all right, or there is a venous stasis, so or a distal artery compression. So in such cases, this particular entity happens, which is the limb ischemia. And how are we going to treat it? So basically, there is no distal perfusion that is happening. All right. So ideally, you use a smaller cannula to prevent this. Physical examination needs to be done to monitor the perfusion in the limbs. Okay. And the current standard is introduction of a distal perfusion cannula. So basically, we have this cannula, that is the cannula which is going into the artery. It is connected to a distal perfusion cannula, which can be connected to a the superficial uh, uh, the femoral artery, or sometimes even the profunda femoris artery. Okay, so this can be connected, and then go for monitoring of the limb perfusion with Doppler and near infrared spectroscopy. So bidirectional cannulas can also be used, and there are other novel cannulas which have been designed which can prevent this complication. But limb perfusion monitoring with duplex monitoring is very important in such cases. So VA ECMO cardiogenic shock, we basically, you see, how do we do the weaning? So weaning is done when the arterial pressure, pulse pressure is more than 10 millimeter of mercury. Patient is not having a pulmonary edema. The end end organ functions are maintaining. Okay. Then you wean the patient of vasoactive medications, evaluate for the ventricular function, evaluate for the end organ recovery like creatinine, LFTs, all these things. If the patient has a low dose support and the ejection fraction is more than 30%, the mean arterial pressure is more than 60 at a flow of 1 to 1.5 liter per minute, then you can gradually go for a weaning trial after seeing after seeing a therapeutic APTT and ACT levels. Clamp the ECMO circuit for 3 to 5 minutes and then go for a weaning trial. So weaning trial is successful if the cardiac index is more than 2.2, LVOT VTI is more than 0.15, a map of more than 60, and CVP of less than 18. All right. If it fails, then one has to go either for a transplant or try other devices that like the left ventricular assist device might be needed, or go for a bridge to palliation, basically go for a palliative care. So this is the end of my discussion on cardiac. I know there are a lot of topics which probably we might not have covered, but then this is the basic of whatever we could cover in cardiology. You can write down the topics and we will try to send you articles or recorded versions of our presentations. All right. So from the heart, now we switch to a completely different topic, which is statistics. Okay. We have to have a reality check on statistics. Unfortunately, I find it very boring, but then this has to be studied because in your first paper, at least 20% of the questions will come from statistics. So a couple of topics we will discuss here: the forest and the funnel plot. So this was one of the questions which had come last year. And what is a forest plot? Forest plot is a graphical tool that visualizes the result of multiple scientific studies on the same topic. The key components are point estimate, the estimated result for a single study. Usually it is shown as a square, and the size of the square will be proportional to the study's weight or the sample size. Larger studies will have larger squares, and narrower confidence interval. Confidence interval, it is depicted as a horizontal line through the square which depicts a range, and the true result of the study lies within that range. Overall pooled estimate, the combined result from all the studies, is depicted as a diamond below, and if the horizontal tips of the diamond cross the vertical line, then the result is not statistically significant. Line of no effect is a vertical line in between, which has no difference or impact. And last but not the least, the heterogeneity of the studies are depicted by I square. If I square is more than 50%, it means the studies are inconsistent due to the reason or other than chance. So when you have these type of questions in exam, just make sure you give examples. Okay. So forest plot, this is one of the examples of the forest plot. Even if you don't write all these things, make sure at least to make this, right? So we have the line of no effect, and where you have two types of, one is probably favoring the study and the other is not favoring the intervention or whatever. Okay. So there are two groups, and we on the first side we have the individual studies, the number of patients with treatment and control group, and depicting the number of patients with the outcome with the total number divided by the total number of patients in the treatment and the control group. So the squares, which is the square which is larger, will have larger studies and a reduced confidence interval. So when there is a decreased confidence interval, the study is more precise compared to that of a confidence interval which is huge, as you can see. So this is one of the if you take these, this and this, right? So this is a more precise study. The confidence interval is smaller here, while the confidence interval here is huge, but look at the effect of the study. The weightage of the study is quite small, right? So this is something which is depicted in this particular plot. And if the confidence interval is crossing beyond the line of null effect, right, then too much beyond the line, or if the weightage is crossing beyond the line of null effect, then the significance of the study comes down, right? And uh, the results or the interpretation of the entire study is given by the diamond, which is the diamond of the bunch. Okay, like we say, the diamond of the season. So we have the diamond of the bunch, which is given below, and this depicts the interpretation of all the studies. So in this particular example, you have it on this side, probably whether it is favoring or not favoring. So this is what it is favoring. This is what the diamond suggests. All right. And the scale of the statistic is displayed below, right? And the heterogeneity levels are depicted below this area where the individual studies are there. It is given by the chi-square or the I-square, and it depicts the heterogeneity of the study. Okay. And if it is more than 50%, as we have mentioned, then the studies are inconsistent. Interpretation, it helps to examine the individual studies. Statistical significance, we have mentioned it in detail. If the study's confidence interval crosses the line of no effect, then it is not statistically significant. Assess the pooled estimate, diamond at the bottom helps to assess the pooled estimate. It gives a visual assessment and variable results across the different studies, and it helps to identify the trends across the various studies. Okay. Coming to our next topic, which is the funnel plot. A funnel plot, it is a scatter plot that compares the precision and results of the individual studies. It is commonly used in meta-analysis to visually detect a publication bias. So the term funnel plot, basically it is in the form of a funnel. It refers to the fact that the precision of the estimated intervention effect increases with the size of the study. Okay, a small study effect estimates will typically scatter more widely at the bottom of the graph, with the spread narrowing among the larger studies that are more precise and closer to the true effect. The plot should ideally look like a pyramid or a symmetrical inverted funnel, as seen in this image. So how are you when this kind of answer comes? So you have to plot a graph, all right, and you have to plot the studies. So each study is represented as this dot, and like the line of null effect in the previous slide, we have the line of overall effect here as well. And then you have this two, the triangle, and this represents the 95% confidence interval. All right. And all the studies are within this 95% confidence interval. So the y-axis is represented by a measure of studied precision. For example, a standard error. And the more precise studies are towards the top of the funnel, right? And the less precise studies are towards the bottom of the funnel. The x-axis will represent the estimate size of the outcome. It can be given by odds ratio, okay, or by risk ratio. So these are given by odds ratio or by risk ratio, and it is plotted in the form of a logarithmic scale. Or you can also use sometimes continuous measures like mean difference or standardized mean difference can also be used to plot the x graph. So x, y, and you have this funnel. And we have to see, so basically it helps to uh, identify biases and heterogeneity in the study. So if 95% of the study is expected to lie within the diagonally dotted line, all right, and we have and the confidence so this is the 95% confidence interval. Implications. Example, we have these two images. One is an image A and the other is the image B. So here we have the standard error on the y-axis and the logs odds ratio on the logarithmic odds ratio on the x-axis. The line of no effect or the overall effect, and then the 95% confidence interval. What do we see here? We see here that the studies are multiply scattered in the different uh, directions of the study, right? So image A is like this, and image B depicts an asymmetrical funnel where all the studies are basically pushed to one side. Okay, so why is this happening? This is happening because probably there is a bias in the study. That's the reason why all the pointers are pointing towards the left. All right, and it gives a meta-analysis summary of the study. So here what is happening is the summary estimate will tend to overestimate the intervention effect. We know there is some bias as a result of which whatever the effect of the study or whatever the outcome of the study will probably overestimate whatever the intervention effect is. Okay. So the reasons for the asymmetry in a funnel plot could be there could be biases, publication, location bias, true heterogeneity. The size of the effect differs according to the study size. Okay, intensity of the intervention and differences in the underlying risk. There could be data irregularities, some fraud, artifact heterogeneity due to poor choice of the effect measure. Effect measure meaning you have to choose a proper effect measure. Okay, odds ratio, risk ratio, whatever, and it could be sometimes because of chance as well. So that cannot be helped. Okay. Next, we have the next topic, which is the number needed to treat and the number needed to harm. The number needed to treat actually had come during our FAT exam. All right. And actually, I couldn't write it properly. And I went back and read it after our FAT exam. So, number needed to treat exam. So, the exam formula, I think this is a general thing which I wanted to say in the previous slide as well. Whenever a statistics question comes, write in this format: define, give the formula, give an example, interpret, and what are the limitations, if any, you know. Okay. So, number needed to treat. Why does it matter in critical care? So, our RCTs often report the studies in terms of a relative risk, right? And but these are clinicians do not need a relative risk; they need an absolute patient-centered measures. So that's where the number needed to treat and the number needed to harm comes in. The number needed to treat is the number of persons who have taken the treatment, okay, for one person to benefit from the treatment. And number needed to harm is the number of person who has been exposed to the risk factor for one person to be harmed who would not have otherwise been harmed, right? So it is how many number of person you're giving the treatment to for one person to have the benefit, and how many number of person you're giving a risk factor or exposing them to a risk factor to have a harm to. So this is what number needed to treat and number needed to harm is. So number needed to treat is a reciprocal actually of the absolute risk reduction, while number needed to harm is the reciprocal of attributable risk or absolute risk increase. Okay. And it is more meaningful than the relative risk for assessing the efficacy of a treatment. So the relative risk is essentially a constant, it is constant regardless of whether the risk is there or not, but the NNT is likely to be higher in low risk group. Fine. So the importance, however, cannot be given just by one value. One needs to see the weight, the benefit and the harm of the trials, the studies. For example, the number needed to treat in the Proseva trial was 6. Okay, this is a number again. Somebody might ask you, what is the NNT of the Proseva trial? The NNT of the Proseva trial was actually 6. So what does it mean? It took 6 patients, okay, to find benefit in one patient with prone ventilation. So this is what it means. So the current concept that one needs to understand is the number needed to treat is 1 divided by absolute risk reduction. Number needed to harm is 1 divided by absolute risk increase. Okay. So the absolute risk increase, the absolute risk reduction is given by the controlled environment rate minus the experimental event rate. Absolute risk harm is given by experimental event rate minus the controlled event rate. And I'm sure by listening to this, you probably would not have understood a single word of it. So let's learn it with an example. Okay. So example, there is a new drug that has come for sepsis. All right. So we will be seeing the number needed to treat and the number needed to harm. Okay. So the new drug has come and it was found that in the control rate, the mortality of the drug was mortality was around 30%, but after giving the drug, the treatment rate, the mortality came down to 10%. Okay. So what is the absolute risk reduction in this patient? That is the controlled event rate minus the treatment event rate. Okay, that is what I said. The controlled event rate minus the experimental event rate. That is the risk reduction. All right. And that is 10%. So number needed to treat is given by 1 divided by the absolute risk reduction, which is 10 for this case. Now, adverse event. Adverse event, similarly, suppose this same drug causes renal injury and the renal injury is 2% for a control rate. But in case of treatment, it is 5%. That is high, correct? So the basically the renal injury is experimental rate minus the controlled event rate. So experimental, the 5% minus 2%, that is given by 3%. So the number needed to harm is around 1 divided by 0.03, which is 33, right? So 33 patients were studied to cause harm to one patient, and 10 patients were studied to to find the benefit of the drug in one patient. So the weightage of which is more? Interpretation is The low number needed to treat is a more effective treatment, and a high number needed to harm is a safer treatment. So we don't go by one number, we go by the net clinical benefit together. Okay. The pitfalls is they are time dependent. You do not know the interpretation or the adverse events or the protection benefit, whether it is for a year or 30 days or for 1 year, that you will not know. It cannot be homogeneous across all patients. It does not take into effect the patient risk factors. Okay, it does not take into account does not account for the severity of benefit versus harm. They will just give a number. You have to interpret yourself, and wide confidence interval in small trials is less reliable. So they will be if the trials themselves are small, then automatically these numbers won't matter. Okay, so I hope that you have understood the concept of number needed to treat and number needed to harm. Coming to our next topic, another very important topic, and you need to understand this concept very well, that is receiver operating characteristic curve and area under the curve. Okay, I will try to explain this conceptually so that in your own manner you can write in the exam. All right, this is what statistics is all about. So, the basic concept, how to draw the ROC curve, this might not be needed in exam, but you surely need to know what it is to even understand our basic statistics. The meaning of area under curve, methods for selecting the best cutoff value. Okay, we'll check this parametric and non-parametric ROC curves. We will not discuss this. It's not required. So, uh, the ROC curve aims to classify a patient's disease state as either positive or negative based on the test results. It helps to find the optimal cutoff value for the best diagnostic parameter. It is used to evaluate the overall diagnostic performance of the test and to compare the performance of two or more tests. So, this is basically a curve which has a lot of benefits, as we have discussed here, right? So, before we jump directly into the ROC curve, one needs to understand the basics of how the ROC curve is formed. And that starts with sensitivity, specificity, the false positive, and the false negative. Okay, so we go with the decision metrics. The decision metrics, you have the disease positive state, the disease negative state, then you have the predicted condition with positive and negative state, A, B, C, D, and you have the the formulas for the sensitivity is the number of true positives, specificity is the number of people who do not have the disease who are tested negative, false positives who do not have the disease but are incorrectly tested positive, false negative who have the disease but are incorrectly tested negative. Remember that you have a separate statistics table in your vivas, and all these questions might be asked. So these definitions are also important for you all. And the ideal test that we want to have is a sensitivity specificity which is equal to 1. Accuracy is given by A plus D, which is the all the truths divided by everything. So when a diagnostic test is performed, okay, so you have people without the disease, people with the disease, the false negative and the false positive. Suppose this is a graphical illustration and this is a cutoff, right? If I switch the cutoff from here to here, say, okay, from 60 to 55, this is my cutoff, say, then the number of false positives are going to increase and the number of false negatives are going to decrease. So how do you determine a cutoff in the patient? Okay, so it is uh, this is what is the basis of the ROC curve to determine what the cutoff is. The ROC curve, it is an analytical method which is represented as a graph. Okay, and it is a coordinated axis where you have the x-axis having 1 minus specificity, which is the false positive rate, and the x-axis with sensitivity. It is used to evaluate the binary diagnostic classification. Just you have to know whether there is a presence of a disease or an absence of a disease. The closer this curve is to the sensitivity area, suppose the curve is like this, okay, like this curve is better than this curve. All right, so the closer the curve is to the sensitivity, it is better, and it is closer to the sensitivity equal to 1. The most desirable property of the ROC analysis is that the accuracy indices derived from this technique, they are not distorted by fluctuations caused by an arbitrarily chosen decision criteria cutoff. All right. As we have discussed here, there is an arbitrary decision to take the cutoff as this or to take the cutoff as this. So the ROC curve helps to override that. And how does it override? So we have how the ROC curve is drawn. We have a decision matrix. Okay. So basically, we just choose a cutoff. Say 0.35 is the cutoff. We have the false, the true positive, the true negative, the false positive, and the false negative. And we plot it in our decision matrix. Okay. So this is how we calculate the sensitivity and we calculate the specificity or the false positive rate. All right. Uh, Suppose we plot the same thing with different cutoffs. All right. Here we have the cutoff as 0. If we have taken the cutoff as 0, all the patients are true positive. Well, all the patients are diseased basically, right? All the patients are diseased. So if we have taken this as the cutoff, all the patients are diseased. So 10 on 10 patients are have a false positive rate that is equal to 1. True positive rate, 20 on 20 patients are having a true positive rate that is 1 by 1. So your at the end of the day, your T is equal to 1. T is nothing, but you are determining the true positive rate and the false positive rate and the ratio of them. Okay. So if the cutoff is 0.35, then your false positive rate and your true positive rate changes. Likewise, if your cutoff, you keep increasing the cutoff, right? Your number of true positives will come down and your number of true negatives will increase. So basically, your sensitivity decreases and your specificity increases. Okay. So these numbers, the false positive rate and the true positive rate, they decrease as the threshold grows larger, right? So what we do is we plot each of these, whatever cutoffs we get. Okay, this is arbitrary. Whatever cutoffs we get, we plot them in a graph, and this is how the and we calculate the sensitivity and the specificity of the ROC curve. Okay, so
This meeting is being
model
recorded.
compared to that of anything which is lower down. So area under the curve, it is given by the ROC probability curve and it represents the degree or the measure of separability. It is widely used to measure the accuracy of the diagnostic tests or two binary classifiers. When the best one is the area under the curve less than equal to 9. Okay, 0.8 to 0.9, it is good. Ideally, it should be kept at least a minimum of 0.5, but at least a minimum of 0.7. So that is fair. Anything below 7.7 is not a good ROC curve. The interpretation will not be good. Okay. So we have what we have studied right now. If we recap, we have plotted the ROC curve. We have gotten the area under curve. But now the question remains. What is the question? The question was, how do we find a cutoff value? For example, I want to find the best anti-pro BNP cutoff. How do we get anti-pro BNP cutoff for the age of the patient or for a ACS patient? How are we going to find a cutoff? So we plot the ROC curve, all right, and then we determine how. So from the sensitivity point, you draw a perpendicular to the ROC curve. Whatever the point is available, that gives the best cutoff for that particular ROC curve. All right, the point on the this is the point where the sensitivity and the specificity is the maximum. So this states the best the best cutoff. Apart from that, there are other things. There are other parameters which are available to determine the cutoff value. You do not need to know, as long as you know this, that a perpendicular is drawn from the ROC curve, from the sensitivity point, the highest sensitivity point, to the ROC curve. This is the point of best cutoff. Okay, and there are other indices like Udin's index. Then you have the point on the curve with the maximum distance from this 45-degree line. Okay, these are also the other parameters. Only one of these, if you remember, that is good enough. Advantages, it is simple and graphical. It represents the accuracy over the entire range of test. It is independent of prevalence. The tests may be compared on the same scale and allows comparison of accuracy. The disadvantages are actual threshold. Decision thresholds are not displayed on the plot. And as the sample size decreases, the plot might not be the same. You might not get a straight plot. It might be all zigzag if the sample size is small. Calculation is cumbersome and friendly flexible software is not widely available. So these are the disadvantages of this curve. Coming to our next topic, which is the standard deviation and the standard error. So this was also one of the questions in the last exam. Okay, this was in fact, I remember the first question that has come in our first paper of the last exam. And the standard deviation and the standard error both measure variability. High values of either statistic indicate more dispersion. Standard error is not the same as standard deviation. Okay, so basically, standard deviation quantifies the variability of values in a data set. It assesses how far a data point falls from the mean. Okay. And standard error is what it quantifies the variability between samples drawn from the same population. How accurately a sample data represents the whole population. That is what a standard error depicts. So, example, for a standard deviation, so suppose we imagine there are a set of random 10 people and you are measuring the IQ of these 10 people. Okay. So when we are measuring the IQ, we get a mean, which is the red diamond here. All right. So what is the standard deviation? How much are the values of the individual test which are deviating from the mean? This is nothing but the standard deviation. Okay. Now, this is one of the tests for 10 people, right? Now we have multiple of these tests of say 10 people, 15 people, multiple of these tests, and we plot the mean of each of these tests uh, in a paper, right? So we get means of individual tests. Okay. So if we connect all those individual means together, then we can get what is called as the standard error. Okay. So this standard error, it depicts the variability. More specifically, it assesses the distance between each of the data point from the sample mean. Standard deviation can be interpreted by using a normal distribution curve, which is the bell-shaped curve, and in any normal distribution, data will not be symmetric. Data is symmetrical and is distributed in fixed intervals around the mean. In terms of standard deviation, if the graph, you have a high narrow peak graph and a small spread, that means the standard deviation is low. And if you have a flatter curve with a longer base and a broader peak, that means you have a higher standard deviation. Normally this is what you should know. Empirically, the rule, what it states, around 68% of your values, they fall within the first standard deviation. Within the second standard deviation, you have 95% of your values that fall, and within third standard deviation, you have your 99.7% of the values that which fall, which are the standard deviation of the mean. Coming to the standard error, as we have defined earlier, they are often referred to standard deviation, standard error of the mean, and it is a measure of precision of a sample statistic, typically the sample mean. Definition: the standard of standard error, the standard deviation of a sampling distribution. As we said, in a standard deviation, we are taking a single example, say 10 people, you go for a mean. But in a standard error, multiple of those means are taken and a sampling distribution is created. Okay. To estimate how much sample means would vary if we repeat the sampling process many times. So the formula is standard area. The standard error is equal to standard deviation divided by root over n. The SD is standard deviation of the sample and n is the sample size. As the sample size increases, the standard error decreases and the standard deviation remains constant regarding the sample size. So sample size is the standard deviation will remain the same, but the standard error changes. While standard deviation measures the spread of the individual data points, the standard error estimates how precisely the sample mean represents the population mean. So differences what we have, the standard deviation is within a data set. Standard error is across the samples or between the samples. The standard error, the standard deviation measures the data dispersion, while standard error will tell us about the mean precision. Okay, multiple means, and which is the most common finding, that is the mean precision it determines. And it assesses, the standard deviation assesses the distances between the data values and the sample mean, while standard error assesses the distances between the sample statistics and the population parameter, that is the accuracy of the study. And as the sample size increases, there is no change in the standard deviation, but standard error has a tendency to decrease. All right. Coming to our last topic, which is the parametric and the non-parametric test. So in parametric and non-parametric test, there are two broad families of tests to analyze the data. We have the parametric test, which assumes a normal distribution, and non-parametric, which is distribution free. That is, they are more flexible when assumptions fail. It doesn't follow the normal distribution curve. So think of them as parametric is ideal condition. You have the bell-shaped curve, you have all the data set within the distribution. Non-parametric is the real world, which is the messy data, and you have to go accordingly. So parametric tests. So parametric tests for a single sample, we have the t-test and the z-test. For two samples, we have for individual sample, we have the two groups, the t-test and the z-test. For paired sample, you are doing a paired t-test. For non-parametric test, for a single sample, you are doing chi-square, the cross-weld, the KS test, the runs test, the binomial test, and then you have the other tests like chi-square, Mann-Whitney test for a two-sample test. Okay, so what I want you to concentrate is on this. So if you know this, you will be able to write something about parametric and non-parametric tests. And this was also one of the questions in our last exam. So when there are two groups which are independent, normal, for a normal curve or the parametric tests, we usually go for independent t-test. For non-parametric, we go for a Mann-Whitney test. If there are two groups which are paired before versus after, say, you go for a normal distribution, we go for a paired t-test. And for a non-normal distribution, which is the non-parametric, we go for a Wilcoxon sign rank test. If there are more than two groups with independent measures, okay, we go for ANOVA test for the normal distribution curve, and we go for a Kroskal-Wallis test for a non-parametric test. For more than two groups, if there are repeated measures, you again go for repeated measured ANOVA test. For a non-parametric test, you go for Friedman test. And correlation studies, Pearson's correlation is used for a normal distribution curve. For non-parametric tests, you go for a Spearman's rank correlation. Coming to the t-test. T-test, as we have said, we need to know whether it is an independent test, whether it is a paired test or what. So example, we'll just take with the examples. So one sample t-test, it compares the mean of a sample to a no or a reference value. For example, what is the mean hemoglobin in the anemic patient, which is significantly different from the WHO cutoff of 12 gram per DL. You have a sample, you want to know what is the mean of the anemic patient or a group of anemic patient, mean hemoglobin in the anemic patient in that particular group, then we go for one sample t-test. Now, unpaired t-test, you are comparing two independent groups. For example, you want to know the systolic BP decrease or increase with a drug test A or a drug test B, right? You have two individual groups, two independent groups, and you want to test a particular parameter, which is an independent parameter for the two groups. Okay, then you go for an independent t-test. Coming to a paired t-test, it compares the mean in the same group before and after intervention. For example, you want to see an HbA1c levels in diabetics, okay, after a new insulin regimen. So before and after, you'll have to check. Then you go for a paired t-test. So I hope the examples are very clear, okay. And then we come to ANOVA test, which is the analysis of variance test. It is used to compare three or more groups. All right. So it compares, suppose a patient uh, is on three different types of diet. All right. One is on a fasting diet, one is on a keto diet, one is on a normal diet. And you want to know the mean cholesterol levels across the three groups. Then you use an ANOVA test. For one factor, you will use one way. For different types of diet with, say, you're adding a gender, then you use a two-way ANOVA test. And if the same group you're measuring multiple times, then you use a repeated measure ANOVA test. chi-square test, it tests the association between categorical variables. Okay, this is a non-parametric test, and you use it for categorical variables, whether smoking status is present or absent, and it is associated with a lung cancer, which is present or absent. Okay, so in fitness tests, blood groups also you can use it. Mann-Whitney test, it is an alternate to the independent t-test, as we have seen in the second slide. It is alternative to the independent t-test when the data are not normally distributed. Examples, it compares the independent groups on the ordinal or continuous data groups, but the data is skewed. For example, you are comparing the pain score 0 to 10 scale in patients on two analgesics. Okay, you give one analgesic and you're comparing, and you give another analgesic. So analgesics, basically pain, you might not have a number. You will have patient is having 0 to 10 score, but he will tell I have 0. It is a subjective number. So in these tests, you use the Mann-Whitney test. Okay. So this is the last slide that I do have uh, other tests for other tests as well, but I'm not going to do it because it's going to create a lot of clutter. Please concentrate on this. If you want to read, go back and read other tests as well. This is the last slide for me, and I hope Tapas sir has joined. All right. Uh,
Yeah.
Hello.
Hello. Yes, Dr. Amrita.
Hi, sir.
So I know how extensive you have taken the class and
I'm
the
really
level of.
sorry, sir, if I have exceeded
No,
that
no,
time.
no, no, no problem, no problem. It's all about sharing knowledge and preparing our candidate for their upcoming exam. So it's like better to be on the air side where we can do something extra for them. And you have quoted something from Pele. So that would be also one thing for our candidates to remember, that you have to be always in the first forward, and you should play your theory exam not in the back foot, rather in the first forward. So thank you, Dr. Amrita, for
Thank you
taking
so much,
the
sir.
so much of efforts. She has the day duties. She came from the hospital, and without wasting a single minute, she sat on the laptop and continuously talking about again something which is not so interesting, that is related to statistics. I would be very honest with you that this is the dedication and efforts by all our faculties today. Also, Dr. Jasmine has also taken so extensive and very thoroughly done class, and also the people, the faculties, because I am the last batsman, and I would be taking your the one of the most important, which I like the most, that is the nephro, and also some of the miscellaneous topics. But for last 2 weeks, we, not only our faculties but also our team, IT team, they are continuously on the laptop addressing some of the queries, handling the some of the troubleshootings, and they are ensuring that you all have a very, I would say, seamless experience of what is actually a good quality teaching is. So it started from Dr. Darshan, Dr. Niharika, Dr. Srihari, and it ended with, it is going to be ended. I am the last person between your finishing line and the current line. So again, I would not be taking so much of again extensive class, but yes, I would try to make it little bit interesting. So if you permit, you can not allow me to share, Dr.
Yes, yes, sir. I'll
Amrita.
stop sharing,
Yeah.
I think.
So, and then Dr. Priya has taken again to another level this week, Friday. And initially, we thought to take only 4 days and without informing. I am again, as I am the course director, I have the authority to discuss with you what happened. We have not informed to all of our registered candidates till the last date that we are going to extend beyond these 4 days, and we are adding again the Friday both weeks. So it's Friday, Saturday, Sunday, then Friday, Saturday, Sunday. And for me also, I just came from Hyderabad, attended one conference here in Ranchi. But again, it's about educating our people. So without further ado, I would be now starting. So just before that, I want to know how many people are with me. Can you just put a thumbs up, all of you, virtually? I know I cannot see you, and I don't want to also because you must have. Okay, very nice. Yeah, I need at least 20 thumbs up before I would start. Otherwise, kidney will be not in our brain, and you can see the kidney is happily. Yes. Still, some of the thumbs up I want to see before I will proceed, or else you can share with me in the chat box in the that how is the Joes. At least you should write very high, sir. Yes, I want, because otherwise I will not be getting so much motivated. Yeah, at least you should put yes, yes. Thank you very much. I know you all are charged up like our faculties. Whatever I can say for my faculties, it's like no less. They have taken the all difficulties to prepare these slides. You won't believe this much of effort is not so easy to like no put for each slide, each topic, each question, and they have lived up to at least our expectation. And I know, I believe that it would definitely help you in your upcoming exam. Okay, so my topic is something related to renal domain. But before that, I know, I believe that you all know me as a faculty. So I don't want you to face this type of situation in your upcoming exam. And for that reason, we kept this preparatory mock test 1 month before, because last time we have kept it around 15 days before. So people thought that this much of information you are disseminating just 2 weeks before is just like no showing the heaven, and you are like no throwing us to the like no hell. And we can see that heaven is not that far away, but you have not given us the chance to compete also. So that's the reason, the first picture, that I want to have the feeling that yes, there are like 30 days more, and you can quickly go through the videos, recorded video, because last time also we have not shared the recorded video. That was also one of the things which we have added this time. Despite all the logistic issues, we have ensured that yes, you should be going through multiple times the videos. Now the exam day, it should not be like Mr. Bean. You should be very thorough and like no, not checking that yes, this paper is right or wrong. And I don't want that people should feel, at least after the end of 6 days of extensive discussion, this type of thing, I don't even know what I don't know. Okay, so this is something what I always thought about, and that's why I start with that. Believe it or not, from nephro domain, can you imagine? CRRT was asked in the broad specialty DNB anesthesia theory question last time. So now you can expect from the nephrocritical care side in the DRNB exam, what would be the level of question? So if CRRT could be asked in the DNB anesthesia, so you can be asked about anything. So that is a bottom line. And with this background, I would be starting the first question. The last 5 years we have collected the questions, and I would be little bit now further would be faster to complete all my 264 slides. In next maybe I may reach 1 AM. Please pardon me. I have told you also beforehand, before starting this preparatory course, to have liquid, not hard drinks, but yes, definitely coffee, tea, or whatever, because 264 slides are there for me. Okay. So the question number one, early diagnosis and biomarkers in AKI. I want, if you have anything to share with me, please post in the chat box, because I don't expect that any other faculty would be with me, because they have already given their best effort, and I want them to take rest, and I will not be able to see the chat box. So you all can unmute yourself and interrupt me if you have some major doubt or you want to clarify something. Now, every question would be having something or other, the template. What would be you should be writing. Now, early diagnosis and biomarkers in AKI. So if this question is coming, so I am expected to write under certain headings. Now, these are the headings. Okay. Definition, importance, limitations of creatinine and urine output, concept of biomarkers, the types, again in the types, biomarker, It could be functional, damage, or stress biomarker. Then some of the key biomarkers, you can give the example. Clinical application of this biomarker, what is the evidence, what are the limitation of biomarkers, the future directions, and in conclusion, you can give a small 2-line paragraph. Now, coming to the definition and clinical importance, we all know acute kidney injury is like abrupt decline in the kidney function, and we normally get to know if your creatinine level is increasing and there is a decrease in the urine output. Definitely, if your patient is having AKI, it would be increasing the morbidity, mortality, and hospital cost as well as the healthcare expenditure. Early recognition allows prevention and intervention. We are not here to treat, rather the prevention is something which we want as an intensivist. Early diagnosis is critical. It improves the outcomes, guides our therapy, and prevents the progression. Traditional markers like creatinine and urine output are late and insensitive, so that is something which we need to address. Now, if we want to know about limitation of the conventional biomarkers, serum creatinine is widely used. They normally take some time to rise, almost like 1 to 2 days, and there are certain confounding factors like it influenced by the muscle mass, hydration, drugs. Then the second biomarker what we can take, that is urine output, is very non-specific, influenced by volume status of the patient, diuretics, and so many other variables. So definitely at this point of time, we need to have some novel biomarkers for earlier detection and risk stratification. Okay. Now, if we want to know what is actually biomarker, so definitely I think some or other class have been taken about biomarker, but if yes, we are getting a biomarker related question in the nephro part. So biomarker is a measurable indicator of biological or pathological process. Ideal biomarker should have certain characteristic. It should be early, sensitive, specific, reproducible. It can predict severity and outcome of our clinical disease or course. There are certain categories in the biomarker related to nephrocritical care or kidney. One is functional. Functional means it can detect the GFR, decrease in the GFR. Damage, something which can detect the tubular injury. Stress, that can predict susceptibility or risk. Now, this biomarker should be able to detect kidney injury before the creatinine rise. Otherwise, there is no point of going for some advanced biomarker. And it should be reflecting tubular stress, inflammation, and cell cycle arrest, because these are the things that first happen before we are getting the increase in the creatinine. Now, it should be also able to differentiate functional versus structural AKI. So these are something which we need to know, and if we want to keep it like as a pictorial view, so if you see here, there is AKI where the red box here, there is already damage, so biomarker is positive, and also there is loss of function. Now the two yellow box where the damage is not there, but the function has started declining. So it also would be manifesting as AKI. And also there would be another form of the subclinical AKI where your damage is positive or present in the form of biomarkers positive, but there is no loss of function. So here there is one window which we can just start treating or doing some maneuver where this yellow will not go into the right side top box where your damage has already been there, like in the form of function, or the red one where your biomarker is also positive and there is also no function. Now, the green part on the left top where there is no damage and no loss of function, so that is something which we want. If our patient is in the red box or in the yellow box, we want to take our patient to the green box, which would be a sign of recovery and restoration of the function. Now, if we go to the right, it would be loss of function from top to bottom. On the right side, damage. But if we are going in the form of left side, from the top to bottom to top, it would be recovery, and from the right to left, it would be restoration of function. Now, This is if you want to make it in one pictorial form in the examination, so it is very easy to draw also. I have tried to share with you something which is not again artistic. In the exam, theory exam, you are not there to create artistic view of glomerulus, tubular, tubule or PCT, DCT and capillaries or collecting duct. Rather, it should be just like making it some scribbles. You can see here glomerular filtration and proximal tubule function. We can actually albumin excretion. That habit, that is nephrocheck, and this is urine IGF BP7 that we will be discussing. Now, there would be again, if we go a little bit to the deeper, it would be distal tubule injury, and the biomarkers normally here are urine NGAL, urine TIMP2, TIMP2. That is again nephrocheck. So this is something, if in the examination, if you get a question related to biomarkers in kidney, so you can easily write one small box and a picture like this. Now, some of the things also, just for your understanding, if you remember this thing, that is very good. You can keep or create like functional marker, stress marker and damage marker, and you can see here the functional marker is green, stress marker is blue and damage marker is red. I'm not going into detail, but this is another form of where you can create different biomarkers as per the different localization. Now, the functional biomarkers. What are the functional biomarkers? I have already told the cystatin C earlier rise than the creatinine, less muscle dependent. Kinetic GFR, which is a dynamic monitoring, it can increase or decrease depending upon the fluid status and again maybe the augmented renal clearance, maybe depending upon the functional ability of the kidney or the glomerulus to the different changes in the clinical status. Now coming to the damage biomarker, NGAL, which is neutrophil gelatinase associated lipocalin, early rise within 2 to 6 hours after injury. Now the next one is the KIM1, kidney injury molecule 1, proximal tubular injury marker, and IL-18, inflammation and ischemic tubular damage. In the examination, nobody expects you to write in detail about these biomarkers. Just remember the names and the full form. If you can just write, and also where it actually generated or produced from. Then the fourth one is LFABP, which is liver fatty acid binding protein, that actually shows how much is the oxidative stress and ischemia. Now the stress biomarker, the third one is TIMP2 into IGFBP7, which is popularly named as nephrocheck, and that is actually showing us the cell cycle arrest, which predicts the AKI risk within first 12 hours. And this is mainly used for re-stratification in the ICU and post cardiac surgery. NGAL, that is neutrophil gelatinase associated lipocalin, that rises within 2 to 4 hours of injury, useful in the cardiac surgery, sepsis, contrast nephropathy. And also NGAL is predictive of the dialysis need and outcome. Now, some of the usual important biomarkers I have tried to summarize in 2 to 3 lines, so that you can at least write if a question comes as biomarkers in the kidney or the kidney failure or AKI. This is already we have discussed nephrocheck, FDA approved test, predict risk of AKI within first 12 hours, valuable in the critically ill patient. Now other biomarkers already I have shown you. You just need to know that these are proximal tubular injury, inflammatory marker, filtration marker the cystatin C, and that is less influenced by muscle mass. Maybe in the examination they can ask a short question on maybe cystatin C also. So you need to know maybe little bit about all these things. What are the clinical application and evidence of the biomarkers? They can predict the risk, stratify the risk, and also triage in critical ill or post-surgery. Early initiation of nephroprotective strategies, optimize the fluids, avoid the nephrotoxin so that we can immediately start it before the proper AKI settles in. Now, this can also help to differentiate AKI phenotypes, whether it is functional, whether it is structural. So it is not that all the the people would be wearing the same size of shirt or shoe. So it's not like any AKI you would be treating in the same line. So we need to the phenotype. Avoid nephrotoxins, optimize the hemodynamics, and also we can have some preventive bundles. And as per the KDICO, it is named as KDICO care bundles. And also, in case the patient needs dialysis, so we can in the larger trials, some trials have also been conducted based on or using some of the biomarkers. So these are something which you can write about the clinical application and evidence of the biomarkers in the kidney. Now, this again one picture I have tried to create. You can see there is always a lagging in creatinine, but NGAL and team 2 and into IGF BP7, which is an check, it can immediately allow your kidneys to be alerted if you can do it at the right time. Now, some of the limitations already cost and availability in our resource limited settings. Maybe we cannot get these biomarkers. Variability across the population, we cannot extrapolate it to different categories. Maybe if it is applicable to post-operative state, may not be applicable to the chronic disease conditions. Most are additive. We cannot have a single biomarker to know that whether this patient is having AKI or not. Rather, we normally recommend it as a battery of tests. So that means it is not a standalone thing, rather additive. So must be interpreted with the clinical context. We have to have a very much proper cutoff. Otherwise, you cannot be very sure whether 0.4 is actually the cutoff. If it is 0.41, you will be saying that yes, no, this patient is into AKI. Not yet universal in the KDICO guidelines. Also, the guidelines have only suggested, but it is not that very much confirmed in the guidelines. Strongest evidence of the biomarkers in AKI is in the perioperative state, sepsis, and ICU. So these are the situations where actually the biomarkers have been studied in detail. Now, what are the future directions? Maybe integration of this multi biomarker panel plus AI. AI every time any question, if somebody is asking you what to do in the future, you can always add AI or OX along with that. Move towards personalized AKI risk prediction. And in summary, biomarkers are adjuncts, not the replacement of our clinical decision. Concept of subclinical AKI, which I have shown you, that is the thing that we can get if we use biomarkers judiciously, timely. Multi-marker panels and AI is promising, and the whole idea is early detection enables timely intervention. And maybe these biomarkers overcome the limitation of our age-old creatinine and urine output, allow earlier intervention, but yes, challenges remain still in widespread adoption. Now, the second question, at this point of time, any questions? 5 seconds, or else I will go to the question number 2. Now, question number 2, again, KDIGO criteria for AKI. I hope everybody has known about what is KDIGO and some of the classification about KDIGO criteria. So straightforward, we go to the headings if we are getting a question on this. So these are some of the points. Again, I am not going into detail. Evolution, how come KDIGO came? Before the first one is rifle criteria, then Akin criteria, then KDIGO criteria. Definition, staging, what are the strength and clinical utility of KDICO, what are the criticism and limitation of KDICO, how it has been compared with rifle and Akin, and what is the role in the epidemiology and research, and some of the special population like pediatric pregnancy, and what are the future direction. So if you remember certain points in the examination also, you can actually write 2 lines about each one. So my suggestion for all the theory aspirants, that always don't be very much stressed when you are getting a question which we don't know. Rather, you try to divide into certain domains in that question. Maybe a 10-mark question, a 1 line or 2 line question, straightforward. It doesn't have any sections or subsection, but whenever you are writing, just don't straightforward start with this is something like no a and then like an introduction. No, you try to divide or make it into at least 5 to 6 structured domains, and then start writing 3 lines, 4 lines, 5 lines about that each domain. So in that way, what will happen, when you start writing, you will get some idea how to fill up these all these like structured domains. And at the end, when you reach at the last domain, you can see a very impressive template of the answer is already prepared by you. Okay, so don't be fearful and rather face your theory paper very confidently. Now, with this background, if we want to go into the evolution of KDIGO, rifle criteria came in 2004, Akin 2007, and KDIGO 2012, which was updated in 2023. Now, the aim is to standardize the different like the usage and also classification, and also it can be compared with the clinical situation of the disease across the world. Now, rifle, we all know 2004 risk, injury, failure, loss, end stage renal disease. That is the first consensus definition. Akin came in 2007. That was refined with smaller creatinine increments, and there was a 48-hour time frame. Now, KDICO unified both rifle and Akin, and now it is the global standard. Now, the global standard also in research and also in clinical practice. It is not only in the practice, also the research. Now, coming to the definition, as for the KDIGO, I'm not going into exact word numbers that you remember or you can go through when we will be finishing our crash course. AKI definition is very important. If they will be asking, you have to write in this format. I have also given you KDIGO as for the serum creatinine criteria and urine output criteria. You know AKI stage 1, 2, 3, and within 48 hours, then 6 consecutive hours, 12 hours, 24 hours, urine output criteria, and creatinine criteria 1.5 to 2, more than equal to 2 to 3, and more than threefold. And the 3, if patient is started on RRT, irrespective of the stage at the time of initiation, it comes to the AKI stage 3. Now, just for the sake of understanding, in any case, if the examiner also asks about, can you like explain about the different classification strategy for AKI? So in that case, you have to also write about rifle criteria and also Akin criteria. Not going into detail, you know, risk, injury, failure, loss, end stage renal disease. Here, stage 1, stage 2, stage 3. So go for it, remember it, put it on your like the table where you read, so that all the classification every day, maybe 2 days, you can just have a glance of look. Yes, this is something, because it would be all visualized. So in the examination also, you can just remember that on your table, on the wall, this has been actually pasted, and you can just try to simulate it on the theory paper. Now, strength of the KDIGO, harmonize the definition, global adoption, sensitive. This capture mild AKI also. It includes both functional, that is serum creatinine, and urine output criteria. It has a stage-based approach which has prognostic relevance, and it predicts mortality and RRT needs as well. The clinical utility, again, standardized diagnosis, so early recognition, it guides in our management and also escalating the treatment, like from stage 2 to if the patient goes into stage 3, definitely we need to consider RRT. Widely used in ICU, nephrology, surgery, epidemiology, and there is also a risk stratification in ICU and sepsis. So definitely we need to be very cautious when we are using the guideline in our patients, and this also guides fluid, nephrotoxin avoidance, and RRT. Now, there is a common language of KDIGO across clinicians and also various trials we conduct. So definitely this is also one of the biggest utility. Now, some of the criticism and limitation of KDIGO, creatinine, what we use or there is actually in our KDIGO, this is delayed and influenced by muscle mass, volume, and some of the drugs. It doesn't still have the recent biomarkers. Urine output, again, the limitation we know, it depends upon the hydration and diuretic. It cannot distinguish between the different phenotypes of AKI, whether it is functional versus structural. Baseline creatinine often unknown. No integration with the biomarker, the recent biomarker that I have already told. Comparison with rifle and akin, definitely it integrates best of both. Though rifle is the first conceptual framework that includes severity and outcome, while akin emphasized early changes, KDIGO has a broader time window, that is 7 days, and it retains sensitivity. Now, studies have shown that KDIGO outperforms rifle and akin in predicting outcomes, more sensitive for mild AKI, which I have already told, improves reproducibility, and still it has some complexity, which is its limitation. Now, it has a very important role in the epidemiology and research, as global uniformity is there, but reliable incident data is only 10 to 20% in the hospitalized and 30 to 50% in the ICU. They have used as endpoint in clinical trials, stratifies risk for the CKD and also mortality. And we need to also know that KDIGO has certain special population applications, but the KDIGO pediatric modification exists, but not in very robust idea. Cirrhosis, isosepsis, and pregnancy, creatinine is unreliable. So we all know in pregnancy, creatinine is actually fallaciously low. So biomarkers need to be integrated so that only we should not be depending upon the creatinine. Cardiac surgery and transplant, yes, it is validated but evolving. So future and take home, integrate again biomarkers, imaging, AI. Dynamic models should have real time the electronic health record alerts and AI prediction. And also the KDICO is currently this gold standard, but evolving and useful for bedside research, global comparison towards this would be helpful maybe in the future KDICO the revision and structural AK definition. It is critical required in the ICU practice. Now coming to the stage or the question number 3, principles of RRT. Any question at this point of time? Are you all with me or not? Or you have started living? I want again thumbs up from all of you. Yeah, at least 5 to 7 so that we can go ahead. Okay, perfect. Thank you. So these are something I would be very honest with you. Nephrocritical care, if you know something, the examiner will also be not very keen or knowing the details, because it is something a very I would say defined specialty in the critical care. So you need to know something, you will get definitely 7 to 8 marks out of the 10-mark question. It is easy to score, but yes, for that you need to remember or know something about nephrocritical care. Now, if we are getting a question on RRT, definitely you can again create some of the templates or the domains like indications, principles, then what the different the principles on the basis of solute clearance, fluid management, biocompatibility, dose of dialysis, vascular access, anticoagulation principles, monitoring and complications, and take home message. Now, these are the things I know you all have already revised. So I will be little bit quicker, just showing you the slides. What are the absolute indications of the dialysis A, E, I, O, U? I hope you all know it. And what are the relative indications like sepsis with AKI, toxin removal, fluid overload, unresponsive to the diuretics. Now, what are the principles of the dialysis? Diffusion, that is dialysis, convection, that is hemofiltration. Now, diffusion, where solute moves across a semi-permeable membrane along the concentration gradient, and that is good for small solutes like urea, potassium. So you can easily do with the diffusion or dialysis. Now convection is hemofiltration. That means solutes are actually dragged with the water in the form of brain drag, and that can clear middle molecules as well, little bit like no bigger molecules than the small solutes. The rate at which this dialysis or the hemofiltration happens is the ultrafiltration into the sieving coefficient. Sieving coefficient for each solute, it has a different, and each membrane they have a sieving coefficient different for the each of the solute. Now the third important point, the principle is the adsorption. Adsorption is like solutes adhere to the membrane surface, and these are important for the cytokines, endotoxins, and most example like important example is auxiliaries or cytosorb or like the charcoal hemaadsorption. Now, the solute clearance efficiency depends upon the blood and the dialysate flow rate. membrane surface area and the pore size. And also this, there are like two modes which we can do: ISD diffusion that I have told, and CRRT. In CRRT, convective plus adsorptive. And here we want to know the concentration in minus concentration out divided by concentration in into the constant factor. Efficiency of like different solute clearance, small versus middle molecule. The dialysis adequacy is in the form of KT by V. And then the next principle is the fluid management. Just remember, in the fluid management, controlled ultrafiltration for the precise fluid balance. This is especially crucial in our ICU patients who are suffering from sepsis, ARDS, cardiogenic shock, where little bit of like the other side of the fluid management will be landing up in the pulmonary edema. CRRT would be a better idea when we want gradual and when we want the fluid removal to be having hemodynamic stability. So this is very important. Now biocompatibility. Again, biocompatibility means the interaction between the dialysis membrane and the patient's blood. Because if we are like exposing the patient blood to an external membrane or extracorporeal membrane or circuit, that can trigger complement coagulation and inflammation. These are the membranes. Normally we have cellulose membrane, which is biocompatible and bioincompatible, that can activate the complement, cytokines, coagulation, and that can increase inflammation. Now the synthetic membranes are nowadays preferred, which are in the form of poly AN6 and there would be greater biocompatibility the synthetic membranes compared to the cellulose membranes, that can decrease the inflammatory activation, improved patient tolerance. Some have also adsorptive capacity for the cytokines or endotoxin like the auxiliaries. So it can serve the both the purpose. Clinical relevance: reduce systemic inflammation, better outcome in the critical ill and septic AKI patient. Important consideration in the CRRT and prolonged therapy. So the take home for the biocompatibility, that synthetic is better than the cellulose membrane, and that can lower the immune activation and improves tolerance. Now coming into the dose and vascular access in RRT. Dose for ISD 3 sessions per week, normally 3 to 5 hours each. CRRT, as per the KDIGO 2012, the effluent dose should be 20 to 25 ml per kilogram per hour. The standard, like the landmark trials like Renal and Etienne trial, they have found that higher dose is not equivalent to the survival benefit. So don't go for like more than 30-35. Adequate dose when we can say if there is optimal solute clearance, fluid control, and not just higher intensity. Rather, we can say less is better. I would not say more, rather it is better. But yes, we have to be judiciously decide the dose. Now coming to the vascular access, any RRT if you are planning, we should have a proper vascular access. Now that can be again divided into temporary and long term. Temporary, it would be double lumen catheters and IJ femoral. Try to avoid subclavian because we all know the limitations or the side effects or complications of putting the subclavian dialysis catheter. Long-term catheters are tunneled cuffed catheter, and in long term, like when the patient is on IST for long time, AV fistula graft for the CKD patient. Now the key principle is we have to have adequate blood flow in the form of more than equal to 200 ml per minute, and also we need to minimize infections and preserve the long-term access site. Now, anticoagulation principle, we will be discussing this anticoagulation multiple times today because there is a separate question also, antibiotic during CRRT. The purpose is to prevent circuit clotting, maintain the clearance, and prolong the filter life, which is very important. And the options we have is systemic heparin, most common, cheap, easy, but there is increase in the bleeding risk because it is systemic anticoagulation, and with heparin, sometimes our patient can develop heparin induced thrombocytopenia. Now, regional citrate anticoagulation in CRRT, and we all know the reason why we want citrate in our patient, it the calcium, and that would be having the local effect. So this is something regional. So remember the terminology. Regional means it would be only limited to the circuit. It will not have any effect on the patient's blood or in the systemic way. and this can have decrease in the bleeding. It needs calcium monitoring, and we need to be little bit cautious in the liver failure, severe lactic acidosis, patient on high vasopressor and acidosis. What are the alternative anticoagulation we have? Low molecular weight heparin. This is predictable, but yes, in AKI this can accumulate. Prostacyclin, which is antiplatelet used in the high bleeding risk. Hypotension risk is there. Nafamostat, which normally they have used in Japan and some of the Asian countries, but it has short half-life and we don't have in India. No anticoagulation is again one more modality when in a very high bleeding risk, because of if we want to finish the dialysis with shorter span, so we don't need anticoagulation when our bleeding risk is very high. Now, monitoring parameters in our CRRT, we can write on certain headings. Now, these are electrolytes. We need to be very cautious. Acid-base balance. We have to monitor the ABG, the lactate, the bicarbonate, the hemodynamics, like the BP, MAP, heart rate. We need to be very cautious if the patient develops hypotension or there is inlet and outlet pressure. TMP, TMP is transmembrane pressure. Whether it is the patient is having clotting or filter failure. Filter, again one more monitoring whether our filter is getting clotted easily. Membrane fouling is there because of this protein deposition. The pores are actually getting clogged, and we should be having at least target of more than equal to 24 to 48 hours of filter life in our CRRT. Anticoagulation monitoring, if you are using heparin, it should be activated clotting time, and in case of citrate, it should be ionized calcium. Now, the complications of any RRT, definitely you can always write hemodynamic instability, electrolytes for shift. Electrolyte, it would be all mainly related to the hypophosphatemia, hypokalemia, hypomagnesemia, hypocalcemia, especially with citrate. Most common electrolyte, maybe we can say during the CRT, is hypophosphatemia, and this is also labeled as dialy trauma. So in the exam, they may ask you, keeping all the complication related to dialysis, as a broad term or umbrella term, dialy trauma. So don't be very surprised. It is just like another trauma in our ICU practice, like volute trauma, barotrauma. In case our dialysis patients are also having some of the complication, you can always write a short note or a long note on the dialy trauma. Bleeding, so all these complications you can keep under the dialy trauma. Infection, vascular access related sepsis, disequilibrium syndrome, because of if you are going for acute ischemic heart, the heart disease, or you can develop cerebral edema because there is actually a rapid shift or disproportionate shift of urea from the central or the cerebral circulation to the systemic circulation. Air embolism, filter clotting, circuit related alarms. Now, the take home message, at least for the RRT, if you are getting a long case, long question, RRT in AKI is life-saving bridge, not the cure. You have to understand the principles, indications, dose, and the complication. We need to choose the modality of the RRT. Again, if you are getting a question straightforward CRRT, like as it was asked in the DNB anesthesia, so we have to also discuss about the different modes. I will be discussing in the upcoming session. So CRRT we can write, but yes, as always I advise you should be first framing your a subsection, so that each section can have at least 4 or 5 lines you can write. What do you mean by CRRT? Definition: it is continuous extracorporeal therapy for solute and removal over 24 hours. It is never done for 10 hours, 12 or 14 hours. This is designed for hemodynamically unstable ICU patients where ISD may cause hypotension. What are the types? I have told you that I will be discussing. So these are some of the types of the CRRT. Which is hemofiltration, section based, where based, so DG, CVP hemodilution, where convection fusion is filtration, that is only for the fluid removal in acute decompensated heart failure, which is diuretic resistance. We don't want anything except the fluid removal. What are the mechanisms? I have already explained. I am not going into detail. The indications I have already written, but yes, in case of you are getting a question, so you can always write at least the headings. So that's why I have kept these things, though I know that you already know it. Like indication for CRRT along with standard ICU indication, you need to remember or write in the examination traumatic brain injury with cerebral edema. This is one of the standard gold standard indication. Acute liver failure with cerebral edema and also post cardiac surgery, cardiogenic shock, transplant patients where you need to have better hemodynamic tolerance and fluid control. Now, what are the advantages of CRRT? Already we have discussed and we all know, but yes, this would be something which you can write in one of the section. What are the circuit components? Again, you need to remember that there are certain technical terms you have to write in the examination. One starts from the vascular access, blood pump, the tubing, hemofilter or dialyzer membrane, replacement fluids, dialysate pump, effluent collection bag, anticoagulation system in the form of heparin or citrate. The monitoring, when if you are getting the monitoring of CRRT, you just divide into two types, patient and circuit. In the patient, write about the vitals, hemodynamics, fluid balance, electrolytes, acid base. In the circuit, it would be pressure. All the pressures you can write, the access pressure, the filter pressure, the return line pressure, the filter life, anticoagulation parameter I have already told, APTT and calcium. So lot of time you will be just listening to these words repeatedly through this nephrocritical care, but in the examination when you are right, you have to summarize it well. Now dose, in case of CRRT, it's always KDGO 12, the effluent rate should be 20 to 25 ml per kilogram per hour, and that includes dialysate plus replacement fluid plus net ultrafiltration. The three things are combined together. Now, delivered dose, you normally prescribe 20 to 25, but the delivery normally happens less than the prescribed dose due to a lot of interruptions like filter clotting, procedures, downtime, and this must account for the downtime when calculating actual delivered dose. So in real life, normally we normally prescribe it to be around 25 to 30 to at least reach 20 to 25 at the end. If you are writing 20 to 25, because of this downtime, we get it less than 20, which is not at all optimum. So our patients are not getting the benefit of CRRT. And as for evidence, the renal and ATN trials, they have shown that higher intensity to the tune of 35 to 40 ml per kilogram per hour doesn't improve any survival. And the target or our focus should be on adequately delivered dose, not higher intensity and frequent monitoring. Limitation of resource, the CRRT resource intensive, all the ICUs have not got that expertise. Again, the cost is the biggest factor. The nursing has to be very optimum or smart enough. Machines have to be there in the hospital, in the ICU, so this cannot be always available in the resource limited settings. Frequent circuit clotting will be a big problem. Electrolyte or trace element depletion, like I have already told, hypophosphatemia, hypomagnesemia, the patient will have difficulty in weaning. There are ECG changes, all these things can happen. And again, no proven mortality benefit versus ISD or SLADE, renal and ATN trial. So again, you cannot always say that these are the situation where if you do CRRT, there would be a definite proven mortality benefit compared to the SLADE or sometimes also ISD. So definitely we have to be very sure in which patients we are actually prescribing. Now coming to the summary, it is a modality of choice in unstable ICU patients with AKI, mainly the traumatic brain injury with cerebral edema or acute liver failure with cerebral edema. Provides gentle continuous clearance and precise fluid control, but the limitation, definitely we need to be very precise in our decisions. Now coming to the fifth question, they sometimes the examiner would be expecting prescription of CRRT. I want to know how many people are there with me now. Thumbs up. Whenever you say that yes, we do not want now further, I would be stopping. Maybe later on we will be recording and sharing with you, because I don't want to just talk and there is nobody on the other side. So that feeling is something I am actually very fearful to. And Abneet, please let me know when the number reduces to less than 10. Okay. So prescription of CRRT, this is again a very important question. And as a, clinicians also, when you clear your DRNB in the real life also, the clinicians, the hospital, the relatives, they expect you to write one prescription of CRRT. So indication and goals, vascular access, modality, dose, replacement or dialysate, ultrafiltrate goal, anticoagulation, monitoring, documentation. These are something which you need to be very thorough when you are writing one prescription of CRRT. Now, the indications I have already told, the goals also, because for starting dialysis, at least as a treating clinician, you should be very thorough that yes, this patient needs dialysis or not. So that's why you have to be very clear with the indication and the goal what you want to get after the dialysis. Whether you want to maintain the hemodynamic stability, whether you want to just remove the fluid in the form of scuff, whether you want to clear the urea creatinine or phosphate or potassium, or the regulate the acid base balance. What is actually your target? You need to be sure before going ahead with any extracorporeal therapy. And indication again, whether it is hemodynamically unstable AKI, fluid overload, sepsis with cytokine storm, where you want to remove some cytokines. Cerebral edema part is actually very concerning for you, whether it is TBI or ALF or extracorporeal toxicology. You want to remove some toxins. So you need to be very thorough, and that's why your prescription will be also tailor-made. Now, vascular access would be the second thing. You need to very much clearly write on your prescription whether you want to have IJ or femoral catheter, whether it is double lumen, what would be the size of the catheter, and we need to remember that femoral side, the longer site catheter is actually needed. What should be the flow target? You should have at least more than equal to 200 ml per minute blood flow for effective clearance. The checklist also, the line should be ultrasound guided, aseptic insertion, and securely fixed. What will be the modality? I have already told about what are the advantage of different modality, but in the prescription you have to write what do you want, whether it is CBPSD, CBPSDF, SCUF or CBPH, and depends upon the indication. That's why I have told you that you need to know what is the indication from the very beginning so that you can write about the correct modality. And these are the primary process and the flow components and what is the mechanism. So this is one the very important table where you can see the different modality mechanism behind flow component. Those I have already explained because I have told you, you will repeatedly look at these lines or the words, but this would be very much essential to just have a buzzword in your mind at the back of your mind. Now, QB and QD. So this is very important. QB is the blood flow rate. QD is the dialysate or replacement fluid. Now, QB already I have told usually is 120 to 200 ml per minute. You have to keep it lower in unstable patients, but higher for efficient clearance. Too high QB with low effluent, your filter would be not very much efficiently used because you are making your blood flow too fast. Too low QB, risk of clotting because the blood will be clotted within the filter. Now, QD or replacement fluid directly contributes to the prescribed effluent dose. So, split between the pre and the post filter replacement depending upon the hemodynamics and filter life. You want to add something in the pre and also divide, distribute between the pre and post filter replacement so that you are not getting the filter clotted also, and also post filter also there will be at least you are getting it diluted. Usual should be 15 to 25 ml per kilogram per hour effluent dose where you are actually making it dialysate and replacement. And effluent dose I have already told it is actually dialysate plus replacement plus net UF, and this net UF is for fluid balance, not solute clearance. So we are not directly targeting net UF for the solute clearance, rather it is dialysate dose. Now coming to the replacement fluid or dialysate fluid, pre-dilution that would prolong the filter life I told you, and but the side effect is or negative or flip side is it would decrease the clearance. Now post dilution, it would be increasing the clearance, but there would be increase in the risk of clotting. So that's why we normally distribute your replacement fluid between the pre and the post, so that both of the best worlds would be happening. And now the dialysate, it would be bicarbonate based preferred, better acid base control, and special consideration when you need something like potassium free or phosphate supplementation, something like if you are to treat the hypophosphatemia. Now some of the clinical scenario: septic shock with high catabolism, what would be your target, what would be your QB, what is your QD, how you are splitting 50-50 between dialysate and post filter replacement, what would be the modality of choice, and what is your rationale behind prescribing in this way. Now hyperkalemia or toxin, where you are targeting or removing the small solute clearance is priority. So your target is this: QB is 180 to 200 and QD is higher dialysate flow in the form of CBP HD. In sepsis, you are preferring CBP HDF, where little bit of the cytokines are also getting cleared. But in case of hyperkalemia or toxin, CBP HD, because it is removing the small solute. So HD diffusion is actually which is favoring small solute removal. Replacement minimal or PEEP filter if litter cutting is risk. Now the another point C is hyperammonemia or where you are actually targeting the middle molecule clearance, and here your convection is actually optimum. Now the fourth is hemodynamically unstable and high clotting, where you want to have more replacement fluid in the form of pre-filter replacement, that would be prolonging the life. And the target is again 20 to 25 ml per kilogram per hour. Now the next prescription find the section would be ultrafiltration goal. What would be your target fluid balance? That would be individualized. Usually the net ultrafiltration should be 1.1 to 1.75, which sometimes you can write 1 to 2. And higher UF rate, if you are keeping higher ultrafiltrate rate, risk of hypotension and decrease organ perfusion would be there. And how you choose your ultrafiltration, that has to be guided by the mean arterial pressure, the vasopressor requirement, the in your patient focus. Now, next one very important is the anticoagulation. In the prescription about the anticoagulation, whether you are using heparin or RCA or any other alternative like low molecular heparin, prostacyclin, or nafamoprast, or sometimes you are not advising any dialysis technician who would be monitoring the patient to do, whether it is patient related, circuit related, or anticoagulation related. I have already told about the various things, and what is the delivered dose at the end. Whether you are whatever you are writing, prescribing, and what is acting at the bedside, documented well. Now the last part would be daily to be clearly mentioned in these forms, and always ensure good communication nursing or ICU team. Now, practical way to write the prescription: instead of just 25 ml per kilogram per hour effluent, you can write the 25 ml per kilogram per hour. Actual, it will be around 22 to 23. Downtime, your QB, your QD, and and adapted to the clinical scenario. And we already know that major trials, they have not shown any benefit if you are exceeding your 25 ml per kilogram per hour. So this is dynamic. You should be looking at the patient. Don't copy paste from the internet and write it on the your nursing chart or doctor's chart. And adequate delivered dose is more important than the prescribed dose. RCA, anticoagulation of choice unless contraindicated, and daily reassess for fluid goals, dose, and continuation. And remember, already I have told CRRT is a bridge, not curative. So it have to be supported until renal recovery or transition to IST is there. Now coming to the anticoagulation CRRT. or RRT, already you know. I'm just keeping the need of the anticoagulation option, systemic heparin, RCA, other strategy, contraindication, what are the monitoring complications as per the KDIGO, what is the recommendation related to anticoagulation and the take home. This is an important question. Sometimes they ask it, but if you know it, you can easily score 8 or 9 out of 10 mark. What is the need of anticoagulation? I think already we have discussed in our previous questions, and where it is very important in CRRT. Maybe IST we don't need anticoagulation. SLADE yes, but again SLADE can be done without anticoagulation also. But it is very important in CRRT where continuous flow predisposed to the clotting, and your goal should be to balance between the circuit patency and bleeding risk. What are the options? Again, I am not going into very much detail, already explained. Systemic, regional, no anticoagulation. Remember in these forms, systemic heparin, again, what would be the most common systemic heparin? This is unfractionated heparin, bolus plus infusion. Dose should be 5 to 10 unit per kilogram per hour. You can also give some bolus, don't also do or give infusion. Pros, it is cheap, widely available. People are more conversant with the use of systemic heparin. The con is bleeding risk because it is systemic anticoagulation, and sometimes it also causes heparin induced thrombocytopenia. How to monitor? Yes, APTT or SCT. RCA, as per the KDIGO guideline, this is the preferred in the CRRT. The mechanism is, we all know, it is a local anticoagulation. Systemic calcium, sometimes if it is low, it has to be replaced by IV, the calcium, or through the pump. Now, pros, prolonged filter life, less bleeding risk, and the monitoring, you have to monitor the systemic plus post filter ionized calcium and total by ionized calcium ratio. So this is the monitoring that you need to be very thorough if we are getting it in our CRRT. The contraindication I have already told. If it is severe liver failure on high vasopressor, shock with lactic acidosis. What are the monitoring in RCA? Again, systemic patients ionized calcium I have already told, 1 to 1.2 should be your target. You should check the ionized calcium every 4 to 6 hours, and that would be guiding you the calcium infusion rate. Post filter ionized calcium, that is free filter sample, target should be less than 0.3 millimole per liter to ensure that anticoagulation is there, and check every 6 to 8 hours once stable. Now total calcium by ionized calcium ratio is more than 2.5, that would be suggesting citrate and accumulation. Now this is something which we do not want because it is now going in favor of citrate toxicity. Now you have to check the citrate level or calcium level daily or earlier if clinical suspicion is there, whether your patient is now developing more of acidosis, rising lactate and refractory hypocalcemia. That means you are going in line of citrate toxicity. Now the systemic acid base status in the form of metabolic alkalosis. If a metabolic alkalosis is there, if your liver is perfect, then that means excessive citrate is actually converted into the alkalosis or bicarbonate. Now if it is like the metabolic acidosis is rising and you are getting rising total calcium by ionized calcium, that means citrate is accumulating, and you are like the monitoring should be every 6 to 12 hours. Electrolytes, yes, there is high chance of risk of depletion of sodium, potassium, magnesium and phosphate. So check daily or more often in unstable. Liver function test, yes, at baseline we need to have one baseline LFT and lactate, and you need to be very much vigilant if you are continuously getting that citrate accumulation is resulting in rising lactate, acidosis and high calcium by total calcium by ionized calcium. Other strategies, yes, these are the terminology that you need to remember, and thus pros and the cons of the different anticoagulation strategy. What are the contraindication to anticoagulation? Already again from the discussion that we had, systemic heparin has its own contraindications, RCA has its own contraindication, and as a general, using any anticoagulation in case your patient is having uncontrolled coagulopathy and high bleeding risk, definitely you should not use. What are the monitoring you should do? Already explained. These are some of the systemic heparin, RCA, circuit pressure, because if your filter is getting clotted because of inadequate anticoagulation, then definitely you will be getting rising TMP. Bleeding signs, if you are actually having systemic anticoagulation more, so your patient will be bleeding from different mucosal surfaces, hematuria, GI bleed, And what should be your monitoring parameter? Post filter ionized calcium less than 0.35, and systemic calcium is 1 to 1.1 to 1.2 millimole per liter. What are the complications? Again, all these things are we all know. Just remember heparin, RCA, low molecular heparin, and some of the anticoagulation like prostacyclin, they can cause hypotension, and there are certain limitation of using nafamostat, which is not there in most of the other countries apart from Japan. And also hypocalcemia. Remember citrate toxicity. The examiner maybe in the theory, in the practical or in the viva, they would be showing you one ECG where there is a long QT, and they will say that this patient was on plasma exchange or the CRRT. So they would be expecting some of the complication in the form of hypocalcemia that is resulting in arrhythmia. So this is and as per the KDIGO recommendation, so RCA is the preferred anticoagulation in CRRT, systemic anticoagulation with unfractionated heparin if your RCA is not feasible, and no anticoagulation if there is high bleeding risk. And anticoagulation strategy must be tailored to patient and ICU resources, because RCA is not feasible in most of the ICUs, at least in the resource limited setting. So take home message, something which you can summarize in your examination, start from the different like types of anticoagulation, end with the monitoring complication and how to manage. How many of you are with me? Any questions at this point of time? Are these presentations are at least no you feel you are able to understand, because I am trying to cover up, but yes, it should not be slowed also, because most of the things you know, I want to only sensitize you so that in the examination you can just quickly write, not like Mr. Bean but like Pele. Okay, so drug dosing in RRT, the next question, very important. Just heading, you need to know the PK principle, pharmacokinetic, the different drug properties, whether what are the antibiotics, what are the antifungals, that you need to be very clear whether you are actually adding like an extra dose or not. Filter factors that can affect your drug dosing, whether what are the adjustment that you need to do, the antibiotics, antifungals, antivirals, anticoagulants, analgesics. What is the role of TDM? TDM is therapeutic drug monitoring, and guidelines. What are the guidelines say and the key summary? PK principle in CRRT, ADME. What ADME? What is ADME? Can anybody just post in the chat box? I want to know that it's are like all of you are actually completely muted. In case of PK, ADME. What is ADME? Can anybody tell me the full form? It is already written here: absorption, distribution, metabolism, and elimination. So always whenever a question comes with the pharmacokinetic, you can write that. CRRT adds an extra renal clearance pathway. It is not only the kidney and the liver in our intra, like no, in our in vivo plus also in vitro. Hydrophilic drugs more affected, that is aminoglycoside and beta lactams, because these are hydrophilic and that would be like no, excreted through the extracorporeal therapy. Lipophilic drugs, less clearance, more tissue bindings. VD, which is volume of distribution, protein binding, clearance. That also like has some effect on the total drug doses and the efficacy of the drugs. Higher volume of distribution or protein binding, that has less removal, and that has also to be understood if you are actually thinking to do dialysis. Drug properties affecting clearance, standard from our like no pharmacology class. Molecular weight, small molecules easily cleared by diffusion, and whether it is like no, you need to know about hydrophilic, small drugs cleared easily. Protein binding, only free fraction removed, and like phenytoin bound, less clearance because high protein bound. Volume of distribution, if large volume of distribution, less removal, for example digoxin. Hydrophilicity, hydrophilic drugs are cleared more, that is aminoglycoside. Filter factors, membrane pore size and type. High flux adsorptive membranes, higher clearance, because you have like along with the usual principle, you have also adsorption method, so definitely it would be cleared like easily. Mode of CRRT, CBPH is convection, diffusion, CBPHD is CBPHDF, both. Effluent dose, you can also write about whether you are going for like high effluent dose, that would be definitely affecting the drug clearance. dose adjustment based on both renal function plus CRRT clearance, and also account for the downtime or interruption delivered versus prescribed dose. Adjustment it than expected maintenance due to CRRT drug loss, and adjustment whether you are going for under or overdosing, you need to avoid both the two things, underdosing also overdosing, and effluent dose to the clearance. Now what are the antibiotics that you need to be thorough about in CRRT? Beta lactams, because they are independent. What you will do in CRRT, you should be increasing the dose. Aminoglycoside, it is concentration dependent, so give the full loading. Don't be afraid of giving the full loading if your patient is on CRRT. Adjust maintenance, and always, if you think about, give post dialysis dosing. Repeat again one more dose. Vancomycin, significant CRRT clearance. So again, we all know the limitation of vancomycin. The trough level, the little bit different or difficult to know. So frequent, if your hospital has therapeutic drug monitoring, so go for and higher doses you should be giving. Daptomycin and linezolid remove 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 antifungal or antiviral. So you can see here fluconazole well cleared, low protein binding, so you need to increase the dose. Voriconazole, posaconazole, high protein binding, large volume of distribution, so less affected. So you don't need to increase the dose. Acyclovir or ganciclovir, they are cleared extensively. So dose reduction needed, plus monitor the toxicity, because you need to be very clear about what you are actually giving. But
This meeting is being
glycoside,
recorded.
you don't want to err on the difficult side. Guides the dose adjustment in variable CRRT settings, helps balance toxicity, and in the final, key summary, CRRT profoundly alters the drug clearance, and we need to be very clear on the drug filter and also CRRT settings. Now, hydrophilic low protein bound drugs are most effective. Effluent rate, key determinant of the clearance. So we need to be very clear, and always use loading doses. Don't be compromising on the loading dose. Maintenance guided by CRRT plus TDM, whether it is volume the lipophilic or hydrophilic or volume of distribution, and individualize the prescription daily based on the patient CRRT delivery and drug monitoring. Now, challenges in the CRRT, that was also another question. Again, you all know the CRRT challenges. Again, I will be just showing you the slides, because this should be again repetition of many things. So you can always write in certain headings technical challenge, filter or circuit challenge, vascular access challenge, anticoagulation challenge, hemodynamics, electrolyte, nutrition or drugs, cost or resources, prevention of different the challenges, and take home message. Technical challenge, again, this we all know: complexity of the machine setup and operation, frequent alarms, require trained nursing staff, downtime, because if we write something, but what is actually happening at the bedside, how much is actually getting translated to the patient's recovery, that is a little bit difficult to know. It needs continuous power and monitoring, which is sometimes in resource limited setting difficult. Filter or circuit challenges: filter clotting, protein fouling, air or blood leak, circuit kinking, pressure alarms, frequent interruptions that would lead to the underdialysis. Now, coming to the vascular access issue, vascular access is malposition, or it is like having thrombosis, or there is infection, insertion complication. If we are starting with one bleeding inadvertently, puncturing the artery, pneumothorax, definitely these are some of the challenges or complications of CRRT. Site infections, catheter related bloodstream infection, CLAPSI, inadequate flow leading to decreased clearance and increased circuit clotting, central venous stenosis with prolonged use. Anticoagulation challenges, I hope we have already discussed in detail. Hemodynamic challenge also, along with hypotension, there is also happening cardiac stunning in patients who starting like SLADE or CRRT immediately, intracranial pressure instability in traumatic brain injury or ALF, and how you want to closely titrate the ultrafiltrate and vasopressors. Electrolyte challenges already I have explained. Just remember the basic fundamental and how you are going to treat them. Nutritional and drug challenges, yes, loss of water soluble vitamins, amino acids, hypoalbuminemia worsened by protein loss, altered pharmacokinetics of many drugs, and we need to have careful drug dosing plus TDM. Otherwise, we can continue with the CRRT, but the patient will not recover because of the inadequate or inefficient treatment of the sepsis or septic shock. Now, some of the nutritional or drug related problems, nutritional, I have already told, amino acids, peptide, they lost in the effluent. Water soluble vitamins are easily cleared, so you need to supplement water soluble vitamins in your ICU, IV, externally. Trace elements, again, we need to supplement albumin, larger protein, though it is having minimal loss, but yes, if you are using high flux or adsorptive membranes, that would be also excreted. Now, drug related issues, I have already told in detail. Clinical implication, you need to give higher protein, like if your patient is on CRRT, vitamins, trace elements, daily drug dosing review, and TDM if you are like having narrow therapeutic index agents. Cost and resource challenges, already told, there are a lot of things which we need to be very clear in our mind before starting the CRRT program. What are the prevention and mitigation strategy? Definitely, we need to have a protocolized machine setup, anticoagulation, ultrasound guided vascular access, treat asepsis, individualized ultrafiltrate and dose prescription, regularly monitoring electrolytes and supplementing it, and multidisciplinary approach where intensivist will be at the center and nephrologist and ICU nurse as well as dialysis technician would be the periphery. Take home message, CRRT is life saving but resource intensive. There are a lot of technical, vascular related, anticoagulation related, hemodynamic related, metabolic and nutritional challenges. Most complications are actually predictable and preventable if you are clear in your CRRT prescription and also with confidence of your team. You can clearly have CRRT outcomes properly. How it going to prevent, vigilant monitoring and protocols. Success depends upon team training, standardized protocols, and vigilant monitoring. Do you need all any break for 2 minutes, 3 minutes, or it's okay? If you want me to continue without any interruption, it's okay, or we can have 2 minutes break. We want to continue. Okay, perfect. So question number 9 is early versus late RRT. Now, this is again another question that was asked. So we can have, what do you mean by early? What do you mean by late RRT? What is the rationale behind early RRT? What is the rationale behind late RRT? The evidence, the comparison of between the early versus late as per like the recent landmark trials, the current consensus, and the conclusion. Now, what do you mean by for the life-threatening complications happen and the late when absolute indications present? Now, if you want to know what is the rationale, early means to prevent the further complications related to azotemia or hyperkalemia or some or other like the fluid overload. Now, late avoid unnecessary RRT related risks. If you are subjecting our patient to early RRT, maybe most of the time we could have actually avoided with our conservative management with treating the disease as such, rather than subjecting to one extracorporeal therapy. Now, this is the RRT initiation landmark trials in critical ill patient. You see from 2002, 2013, then came the Elaine trial. I would be discussing that also. Then Kiki trial, Ideal ICU trial, and Start AKI trial, then AKI 2 trial in 2023. Now you can see I am not going into detail, but yes, in case if you want to just have a short note on different landmark trials of early versus late, so these are some of the standard trials you can always write about: Akiki, Elaine, Ideal ICU, Start AKI. And this is in one slide about the different things about the Elaine, Akiki, Ideal ICU, Start AKI, and the recent one Lancet published Akiki 2. So this is something which you can always remember. Now, this is only one trial which has suggested that if you start early, so the mortality is actually significantly lower. Alien trial, but this is more confined to the surgical ICU patients and early within the 8 hours of critical stage 2. And they found the decrease in the 90-day mortality to 39% if you start early, and late it was 55%. Then the Akiki trial 2016, the first one, medical ICU, early versus delayed, like no absolute indications, no survival benefit. Rather, 49% of the late group, they never required RRT. Okay. Now, ideal ICU, septic shock with AKI, again, no mortality benefit with early initiation. Start AKI 2020, more than 3,000 patients, multi-center, and no mortality benefit, increased dialysis dependence in the early group. So all these are negative trials related to the early the AKI if you are going for dialysis early. Now some of the meta-analysis also, they have also suggested like 2021 to 23, no consistent survival advantage, and delayed actually avoids unnecessary RRT in 30 to 50%. So at least early you should not be going. Now early versus delayed. Early RRT means before conventional indications like life-threatening hyperkalemia, pulmonary edema, severe acidosis. Potential benefit, you are instituting early RRT, so that would be helping in early removing the toxin and the solute, prevent the complications, some of the trials that I have already told. Delayed RRT starts only when the standard indications are present or patient deteriorates. Advantages, it avoids unnecessary RRT seen in 30 to 40% of delayed arms patient, lower risk of RRT complications, and there are a lot of trials that showed no mortality benefit in early initiation. Now, current consensus is watchful waiting plus close, and early initiation may or refractory metabolic the derangements where you can start your the early dialysis. But yes, most of the cases it is not like right now you will be subjecting your patient to the early dialysis, because it would be unnecessarily bringing some of the complications of the early dialysis. Now, guidelines also you need to see as per KDIGO 2012, initiate when life-threatening complications develop, no universal benefit to early RRT, not creatine versus urea threshold, and individualized decision. So conclusion, early RRT selected benefit in high-risk patients, delayed safe avoids unnecessary therapy, and adopt watchful monitoring and waiting. Now, next question, it would be again related to nephrocritical care, that is plasmapheresis and plasma exchange, regime, process, indication, complications, evidence. What is it? It is like extra corporeal blood purification technique. Yes, I need some of the thumbs up of these questions to keep me motivating. Like maybe I would be a little bit demotivated, but it's not like that. I want to give justice to our class, and this is the one class, last class before we will be live with you, because neuro part would not be possible for us to like give you live. We don't want to also. You can give two thumbs up also. That will look like you are having like 30 or 40 people. Though I know only 18 or 20 people are there. So if you do multiple thumbs up, that would look like there are more people. So we will be definitely recording the neuro part and sharing with you, so that the whole comprehensive critical care will be with you for next 25 days or so for your theory exam. Now, coming to the plasmapheresis or plasma exchange, again, it is one form of like extracorporeal blood purification technique designed for removal of large molecular weight substances. So, plasmapheresis is not for small molecules. So, more or less, it would be for large molecular substances. And what do we actually do? We separate the like plasma from the blood cells by centrifugation or membrane filtration, and sometimes we will be again reinfuse of cells with cleaned autologous plasma or donor plasma or another replacement colored solution like albumin, FFP or cryoprecipitate. So this is termed as plasma exchange. Exchange means we are taking something and we are giving something. But plasmapheresis is when we are taking the plasma only from the patient, right, and then purifying it. Now, in common usage, the term therapeutic plasma exchange and plasmapheresis are actually used interchangeably. So people normally use it, plasma exchange, plasmapheresis, but you need to be little bit clear that they are not actually so much similar. Now, therapeutic plasma exchange, I have already told, where large volume of plasma is taken, and if you are not actually replacing, then significant hypovolemia resulting in vasomotor collapse would occur. So it must be replaced with some form of replacement fluid. Now, plasmapheresis, where we are actually taking smaller amount of plasma, typically less than 15% of the patient's blood volume, and many treatments involve a process of cleaning of the patient's own plasma, and then that has to be returned to the patient. So here we do not actually always require replacement of the removed plasma, like sometimes. And many treatments involve a process of cleaning and its return, but this doesn't require always like we need to be replacing. Now, this is the circuit of the therapeutic plasma exchange, what we are normally doing. So just like your dialysis, but yes, here blood pump is there and you are separating the plasma here. There is plasma filter here, plasma separator, and you are getting the plasma pump here. Substitution fluid is adding here something if you want to have some replacement fluid, and then the waste is coming outside here, and then plasma separation, what is happening, that is now again going back to the patient. So you can just draw one diagram. The examiner would be at least clear that yes, you know what are the main pumps and the filters. What are the pathologic substances removed by therapeutic plasma exchange? Again, you can see here immunoglobulins, autoantibodies, lipoproteins, leukocytes, platelets, abnormal red cells, circulating immune complex, protein bound substances and toxins, and hyperparasitemia. Can you see? In malaria patient also they have tried to remove the hyperparasite, like parasite level in therapeutic plasma exchange. Now coming to the applications, yes, just remember some of the indication in the examination. If you do not have time, you can just create one diagram like this and write about the most important. Don't forget to write about rheumatology, hematology, neurology, and nephrology. These are some of the, I think, most important indications that you should not be forgetting to write. Now, the indications can be divided into again absolute indication, where therapeutic plasma exchange is a recognized first line treatment, and relative indication, where it is recognized as a second line treatment. Now, what are the most important absolute indication? AIDP, we all know, Guillain-Barré syndrome, Goodpasture syndrome, hyperviscosity syndrome in the form of hypergammaglobulinemia like Waldenström microglobulinemia, catastrophic antiphospholipid syndrome, myasthenia gravis, NMD antibody encephalitis, TTP, acute liver failure. Acute liver failure, again, you need to remove the albumin bound and water soluble toxins. So these are absolute indications. Relative indications are autoimmune hemolytic anemia, chronic acquired demyelinating polyneuropathy, Lambert-Eaton myasthenic syndrome, and steroid responsive encephalopathy. There are also another indication which is rescue indication. Rescue indication means disorder for which therapeutic plasma exchange may be used in the ICU as a rescue therapy, despite we do not know there is having any strong evidence about its efficacy, like heat with progressive thrombosis, cryoglobulinemic vasculitis, pancreatitis with severe hypertriglyceridemia. We normally prescribe therapeutic plasma exchange, but yes, or plasmapheresis, but it is a rescue indication. It is not having absolute or relative indication. Specific type of poisoning, paraneoplastic neurologic syndrome, SLE with severe vasculitis complications. Now, some of the formulas you need to remember during plasma exchange. What should be the plasma volume? 0.07 into weight into 1 minus hematocrit. Normally, we should be doing at least 1 to 1.5 plasma volume exchange per procedure. And the techniques, again, what you normally do is with the centrifugation devices used in the blood banking procedure, but in ICU we can do with our normal dialysis machine. Venous access, again, as usual, like we put the central line, and as per the American Association of Blood Bank, general recommendation is one exchange be performed every second or third day, each exchange consisting of 1 to 1.5 plasma volume, and we should be going for at least 3 to 5 procedures. Exceptions: in acute GBS, it may be necessary after initial exchange to perform TP 1 to 2 times a week until improvement happens. In TTP, it should be performed daily until the platelet count is normal for 2 to 3 consecutive days. Goodpasture syndrome, this should be again on daily basis for at least 2 weeks. And what are the replacement fluid? As I have told, maybe albumin saline or combination, or FFP. So that would be something which we can be giving through the replacement fluid. What is the evidence? TTP, GBS, ALF, sepsis, and ARDS. You can always write about 2 to 3 strong indications. What are the complications? Again, I told you, whenever any procedure you are writing or you are being asked about the complications, start with the things that is involved in that procedure. Starting from the vascular access, then during the procedure, hemodynamics, metabolic or electrolytes, then hematologic, immunologic or infectious. Because of hypogammaglobulinemia, what happens? There is increased chance of infection. Then you are using so much of FFP and albumin, maybe the patient will be having some allergy or anaphylactic reaction. During the procedure itself, air embolism, line disconnection accidents, and trally, if you are using so much of fluid replacement, they can land up in trally, hemolysis, infection with FFP. In conclusion, this is a life-saving extracorporeal therapy in immune-mediated or hematologic disorders mainly. Role in sepsis or MODS is investigational. Always follow American Society of like the apheresis. That would be something which can guide us. How many of you are with me? Okay, very nice. Okay, you all are with me. So next question, again very important. We all like expect this type of question in our recent exam, because recent advances, extracorporeal therapies in sepsis is one of the red hot chili question which can be asked in your exam. So again, the sepsis guide us for like using extracorporeal therapy. In sepsis, what happens? There is in cytokine storm, endothelial injury, microcirculatory dysfunction. So both macro and microcirculatory dysfunction happens, and there is imbalance of the pro-inflammatory. Pro-inflammatory means IL-6, TNF alpha, and anti-inflammatory. A lot of anti-inflammatory mediators will be there. Now there would be also pathogen toxins along with these cytokines. There would be some of the endotoxins are they also amplify the organ injury, and that would be leading to the multi-organ dysfunction. So this is we need to remember. Now, what is the rationale for extracorporeal therapy? The extracorporeal therapy can remove the harmful mediators in the form of cytokines or endotoxins. They can restore the immune homeostasis. They can balance between the pro versus anti-inflammatory state, and they can also maintain the organ support in the form of solute or fluid balance and acid-base stability. Now, what are the modalities we have? Just remember, there are certain modalities that is helpful in our day-to-day practice. One is hemoperfusion, polymyxin B, cytosurf, auxiliaries, then high cutoff or medium cutoff membrane, coupled plasma filtration adsorption CPFA, plasma exchange in the form of TPE, and hybrid therapies with CRRT. So this is something which we need to know, so that at least in the examination, if we are writing, we can like at least write about 3-4 lines about each one. Now polymyxin hemoperfusion, UFAS 2009, the mortality reduction was there in abdominal sepsis, but then there is another study came, Abdomix 2015, there is no mortality benefit. And Euphrates 2018, again you can see no overall benefit, possible effect in high endotoxin activity subgroup. So in the examination, at least you should remember about these three landmark studies and the different meta-analyses that have been conducted. They have shown inconsistent survival benefit. Now, second one is the cytokine adsorption in the form of cytosurf. Principle is what happens in the cytosurf, the hemoadsorption device with porous polymer beads, they remove the hydrophobic molecules like cytokines, myoglobin, bilirubin, and toxins. And the goal is to like attenuate the cytokine storm and restore the immune homeostasis. What are the indications? Indications are not always like the confirmed. So it is proposed or investigational. One is septic shock with high vasopressor requirement, hyperinflammatory states we all have used during the severe COVID-19 time when we are not getting the adequate response. So we did it with like anti-inflammatory drugs like steroid. We have used tocilizumab and also sometimes we have used in cytosurf therapy. Pancreatitis, trauma, post-cardiac surgery, SARS. So here the problem is with pro-inflammatory cytokines. Sometimes we can also add with ECMO or CRRT. The evidence is rapid cytokine removal is documented in the form of IL-6 reduction to TNF alpha reduction. Small RCTs and registries, they have shown improved hemodynamics and decrease in the vasopressor requirement, but large RCTs, they have not given green signal for having a proven mortality benefit. KDIGO or surviving sepsis campaign guideline, they have not recommended it as a routine practice, but yes, used in clinical trials and rescue therapy or the wherein when you are in desperate situation. Coming to the complications or limitations, non-selective removal, because it is not only removing the problem or culprit antibodies or cytokines, rather it can also remove some of the good cytokines and also antibiotics, nutrients and drugs. Cost, availability, and again we have to start it in early hyperinflammatory phase. If you are starting it in the anti-inflammatory phase when the patient is already entering into CARS. CARS is the compensatory anti-inflammatory response syndrome. Then we are removing some of the good cytokine at that time. Patient will not be able to actually recover from the second hit or third hit. So the verdict here is cytosur provides cytokine clearance and hemodynamic stabilization in septic shock. But yes, survival benefit is unproven and best used in selected patients only and or in trial patients. CPFA is actually what happens. You are actually plasma is separated. It is undergoing through adsorption and hemofiltration. So both the two things are happening, and it is passed through resin cartridge that can remove the cytokines, endotoxin, inflammatory mediators. They can again be recombined with blood, then conventional CRRT for solute and fluid. So both the two things are happening here. Rational broad spectrum removal of both pro and anti-inflammatory mediators, and the aim is to restore immune homeostasis, support organ recovery. Evidence, some of the pilot studies have shown that it improves hemodynamics and decrease the vasopressor requirement, but compact 1 and compact 2 trials, they fail to show any mortality benefit, and these trials have actually been stopped early. So it is used mainly experimental wise, not guideline recommendation. Limitation, complex, costly, requires dedicated equipment, large plasma volume needed. So logistic challenge, we cannot get so much of plasma volume. It is non-selective. So risk of removing the protective molecule. That is the biggest side effects or complication of going with all these extracorporeal therapies for sepsis. And CPFA that offers a broad spectrum extracorporeal immune modulation approach in sepsis, but RCTs are silent or they have not shown any survival benefit. Currently, it is limited to the research or rescue therapy. This is one of the picture of CPFA. You can see here how the plasma filter is first happening and then it is passing through the dialysis filter. Now, plasma exchange, that is also one of the other modality for the extracorporeal therapy. The one article published in NEJM 2016 that improves transplant-free survival. There are small RCTs and meta-analysis. They show that decrease in the SOFA or mortality, but evidence is low certainty and investigational. As per the guidelines, if we will be just going through
This meeting is being recorded.
how long we have to subject our patient for extracorporeal therapy is unclear. It is having high cost, resource intensive, benefit till date. Routine use not recommended. Maybe it can help in research settings or selected subgroups. Future, we may have to integrate our the therapy with the biomarkers and personalized strategies. We need to have certain cutoffs of the cytokines that we are targeting to remove. Otherwise, there is no point of subjecting the patient to multiple times any extracorporeal therapy. So this is again something which is very important. Remember the headlines. If you remember, you can write at least about 4 to 5 lines, and any question you can answer. That is whole idea of conducting, organizing this type of crash course. From the nephrocritical care, maybe now the transplant cases are happening more, so the examiner may expect that how you are confident in the renal transplant management. So I am just trying to give a summary of renal transplant because it is not possible to give in detail. So it is a definitive therapy for end stage renal disease, the transplant. It improves survival, quality of life versus the dialysis. Dialysis is never much preferred because every time it has its own complication. The goal of renal transplant is to first survive with the graft, and then there should not be any infection and any complication related or during or after the procedure. Now, before going into the transplant related complication, first we need to optimize the pre-transplant patients with the immunological. Again, every time you write about a question, every subsection, again what you write, you need to again give or make it a subsection, so that it would be very structured and you don't need to write in complete. You cannot write a full sentence. There would be grammatical mistake. There would be something like how you would be writing so much. If I am talking now, if I will be asked to write all these things, then it would be like no, your exam would be there and we all be not able to finish your this comprehensive critical care crash course. As I am talking, I am able to talk. But if you wish me to write again what I am talking, it would be endless. So that's why you need to have a small sentences like this. So the examiners would be just looking at this slide or maybe your paper, and they would be knowing at least that yes, this candidate knows about most of the things. Maybe he has not or she has not written in full sentences, because sometimes you can save time by just writing immunological, HLA, cross match, panel reactive antibody. So it is self-explanatory. Infectious screen, HBV, SCB, HIV, TB, CMV, EBV. What you will write in if you write as a sentence, it is self-obvious if you are writing infectious screen itself. Comorbidities, diabetes, because renal transplant, diabetes, cardiac problem, obesity, malignancy. Now, immunosuppressive regime, yes, you need to know about what are the immunosuppressive. There are certain no, the standard classification. So for renal transplant, you have to know about the induction chemotherapy, maintenance chemotherapy, that is tacrolimus, cyclosporin, MMF, azathioprine, steroid. These are the some of the buzzwords that you need to remember. Any exam, this would be coming. Balance between the rejection versus infection. So if you are overusing, it would be going into the complications, toxicity. If you are actually giving it in high dose, maybe patient will be immunocompromised, and that would result in the infection part. And the patient, if you are not using in proper dose, then patient may go into rejection. Now, during all these renal transplant, like whether the patient is going into surgery or in your ICU, you should be trying not to have any infection. So preventive measures and monitoring. Prophylaxis, you can try with cotrimoxazole, valganciclovir, antifungals. Vaccination pre-transplant, vigilant post-transplant monitoring like CMV, PCR, BK virus, cardiovascular metabolic issues. You need to optimize all these things because that would be depending upon your long term patient care. Hypertension, diabetes, dyslipidemia, then CNI, nephrotoxicity. Monitor the labels. Your hospital, your lab should be equipped with getting all these lab reports on time. Now then, if you do it long term metabolic syndrome, definitely your patient will be better managed. Now, if you just go with other complications, yes, malignancy is one of the things that you need to be very cautious. Bone disease, steroid if you are using, then bone diseases can happen. Chronic allograft dysfunction can happen. As per the guidelines, you can remember with KDIGO and American Society of Transplant, if you are going with a proper direction, 1 year graft survival is more than 90%. 10 year survival is also improving with better immunosuppression. You have to carefully select your patient free of optimization during surgery, also in ICU, also take care of the immunosuppression part and infection prevention. Lifelong follow-up has to be mandatory. So key summary: careful selection, immunosuppression, infection prevention, and lifelong follow-up is mandatory. Now the 13th number question is graft rejection. If graft has been rejected, then how will you identify and how will you are going to manage? So this is the last question in the nephrocritical care part. So definition and type, here we need to remember hyperacute, acute cellular, antibody mediated, and chronic rejection. Now, clinical presentation, in case the patient is going into graft rejection, rise in the serum creatinine, decrease urine output, proteinuria, there would be some graft tenderness sometimes. What are the risk factor? If you are not going into proper HLA, means like matching during the renal transplant, poor adherence with the chemotherapy, inadequate immunosuppression, some of the infection have happened like CMV or BK. How you are going to diagnose? You will be getting the creatinine to be rising. You can do the Doppler to rule out obstruction, or is there any vascular anomaly or abnormalities. In case of confusion, go for the biopsy as per the Banff classification. You need to remember this. This is the gold standard. If it is acute cellular rejection, so pulse dose steroid. Resistant cases, anti-thymocyte globulin, switch to the cyclosporins. Then antibody mediated rejection, plasmapheresis or IVIG, because here we want to remove the culprit antibodies. Go for rituximab, bortezomib or eculizumab in refractory cases. Chronic rejection or like the different like the CNI related complications. So no effective treatment, supportive care and optimize the blood pressure and diabetes. Differential could be again cyclosporin induced toxicity, recurrent disease itself. The primary disease has again like started like fluorating, obstruction, maybe tubular obstruction or some other infections. Now prognosis and prevention: rejection episodes worsen, long-term graft survival and adherence, therapeutic drug monitoring and protocol biopsy. You need to have at least a structured transplant program in your hospital ICU to have a good outcome. Guideline: KDIGO 2020 transplant guidelines. You should be going with the updates of Banff classification. Now take home message for the graft rejection: identify early. Rising creatinine is there, go for biopsy, try to identify the problem properly. Different types, tailor the therapy, prevention via adherence, adequate immunosuppression. Now this is all related to nephrocritical care. So now we need to discuss about some of the miscellaneous questions which have been like at the end of the curriculum that we have shared with you. How many of you are with me? Do you want to continue with the miscellaneous questions, which are like maybe 5 to 6 questions? You can post whether you want it now or not. I can finish it maybe next 40-45 minutes. All okay? Should we go ahead? Okay, perfect. Yes, perfect. Uh, this would be quick because this is very practical and miscellaneous questions which you can write easily. Nephro part was slightly, if somebody has not worked in this type of settings, that would be difficult. Then the first question in the miscellaneous is scoring systems in ICU, role in outcome prediction. Very important. Any ICU, any NABH coming to your ICU, if you have witnessed, then they would be always keen on knowing what are the scoring system that is used in ICU. So for a like not final year trainee which about to be consultant, so definitely this is expected by the examiner. So what are the purpose of ICU scoring system? Why we want ICU scoring system? This is very easy miscellaneous question, so I will not be expecting like to be at least giving a pause. I would be just showing you the slides so that you can guess what should be my headlines if I'm getting any question for like this type of things. So the purpose of ICU scoring system that it should be quantify the severity of illness and predict the outcome, and it should be helpful to like prognosticate the family, the patient. Decision making should be easier, and it should be helpful in our research and also benchmarking our care, our hospital, our ICU at the national level. What is our standpoint? Now, what are the classification of ICU scores? So if you want to give again a structured classification, it would be as per the CBS. And some of the examples are Apache, SAPS, MPM, mortality prediction model. That can be also based on the organ dysfunction scores like SOFA, MODS, and LOTS. Condition specific, whether it is liver, whether it is like related to the sepsis, and then specialty. Specialties, it is trauma or it is related to emergency department. Now, what are the principle of scoring? Wow, these scoring systems have actually come. This is derived from large ICU database, and they use the physiological lab and the demographic variables, and there is regression or logistic model. It's not like that any more like the vitals they can add and they can create the scoring system that have been already subjected to rigorous like the regression and logistic models, and as a result what has happened, that can predict pretty well the mortality, morbidity, and length of stay. Now, some of the important ICU scoring system you should know can come as a separate question, a short note, 5 marks also. Again, you need to remember in detail. Here, I am just giving you a snapshot. What is Apache score? Acute physiology and chronic health evaluation. It uses initial 24-hour ICU data. There are certain versions like Apache 2, Apache 3, and Apache 4. Most probably, your hospital must be having some Apache scoring in your day-to-day clinical practice. Apache scoring predicts hospital mortality, and this is widely used for benchmarking in research in registry maintenance. Now the next important scoring system is SAP score. Now what is SAP score? This is simplified acute physiology score. There is SAPS 2 and SAPS 3. The parameters that is used here: age, comorbidities, and physiology. This is one of the score that has actually predicted the mortality in multi-center studies. Now the third one is the MPM score. MPM is mortality probability models. The data at admission, 24-hour and 48-hour. This is simpler and fewer variables are there. Normally, this is used for quality improvement and comparisons. The next one is the SOFA score. I know everybody knows about the SOFA score. SOFA score is sequential organ failure assessment score. So, 6 organ systems: respiratory, CVS, CNS, renal, liver, coagulation. It tracks dysfunction over time. Every day you need to do it so that you can get one trained rather than only on the first day or second day. Sepsis 3 definition, they have mentioned that SOFA score rise of more than equal to 2 can result in like or guide you or at least predict that yes, the organ dysfunction has started. Now other organ dysfunction source: MODS, LOTS, prognostication in multi-organ failure. There are certain condition specific scores also like MELD score, liver failure outcomes, transplant listing. It is useful mainly in the transplant. Child flu classification, cirrhosis prognosis, QSOFA, that is bedside sepsis screening, GCS is neurologic outcome. There are certain pediatric ICU scores also, though we are mainly dealing with the adult, but yes, sometimes the examiner slightly little bit oriented towards pediatrics. So just remember mortality. This is used in the PICU outcome prediction. Now, what are the application of this scoring system in ICU? Risk stratification for treatment intensity, resource allocation and triage, clinical research and trials where you want to mix the patient population, benchmarking ICU performance. The limitation, yes, population versus individual prediction. You cannot always predict that if your patient is having Apache 30, that every any patient with Apache 30 will finally die. You cannot say. May be outdated with new therapies. It's like whatever has started in 2000 with some of the scoring system that would be standing true in today's practice also, when we have so many newer innovations every day coming. But yes, sometimes the examiners slightly and the performance varies across ICUs. It's not like only based on the scoring system you can label that every ICU would be having the same result, and it is not substitute for the clinical judgment. Always add machine learning and AI based model in any type of this type of question. Dynamic real-time risk prediction is important. It's not that you do the scoring system in first 24 to 48 hours or 15 days ICU stay, biomarkers and genomics should be playing a bigger role in future when we want to add on or like have these things also incorporated into the scoring system. And personalized ICU outcome prediction is something which is need of the hour. Now, take home message: yes, the severity, organ dysfunction, everything would be better analyzed or like guided by this clinical judgment. Now, the next question is scoring system in liver disease. That was also asked, and the question was describe any one of these scoring system that is used in the liver disease. They were not HTP score, that is child torque puke score, but yes, MELD score is also one of the important thing because that is better in terms of CTP when it comes to the transplant, liver transplant listing. Now, multiple scoring systems assess severity of or like the prognosis, like child torque puke, mild or mild sodium, clip SOFA, that is in ACLF, Apache 2 in ICU patients. We will describe CTP score in detail. Now, developed in 1964 by Child and Turcott and modified by the Pugh in 1973. Originally, they were trying to assess the operative risk in portal hypertension in surgery, but in liver transplantation. The parameters, we all know 5 parameters: bilirubin, albumin, PT or INR, ascites, and encephalopathy, and these are the scoring tables: 1 point, 2 point, 3 point. You can know, you can just go through, remember the lab values at which you will be labeling this as 1 point, 2 point, and 3 point: ascites, encephalopathy. The classification again: class A 5 to 6 point, class B 7 to 9 point, and class C 10 to 15 point. That is decompensated form. Prognostic value: 1 year survival, class A is 100%, class B 80%, class C 45%. Transplant consideration: usually CTP if it is more than equal to 7. Now, clinical application: risk stratification in cirrhosis, prognostic tool for survival, guide for liver transplant listing. Surgical risk assessment: you must have seen any patient who are going for any surgery with cirrhosis of liver, they normally put this CTP score like as one of the guide of like explaining prognostication. Coming to the limitation, this is a very subjective parameter having ascites and encephalopathy. Encephalopathy. For me, maybe encephalopathy 3, for you, maybe it is 4. Maybe for ascites, I would label it as like no severe ascites, you will label it as like no mild ascites, because the clinical judgment is very important. The ultrasound has to be, again, it is a subjective matter. Ceiling effect, you cannot like label 10 to 15 is in the grade C. So 10 to 15 is a long, like you can say 10 to 15. But if it is like no, it is not a continuous like the MELD score. MELD score, the lab values have to be like no, like calculated, and it would give you a real number. But here A, B, C. So we cannot like know whether my B patient will be like no, for every patient who will be in the B category in my ICU in CLD patient, that will be having the same outcome. It will not be having a very clear, robust idea, and it is less accurate for short-term mortality prediction. Now, comparison with MELD, CTP is simple, bedside, it is an older system, but MELD is objective, continuous, superior for transplant allocation. Often they are used together in our practice. So, take home message: CTP is simple and practical for bedside use, still relevant in clinical practice, but MELD is largely preferred for transplant allocation, but you can use both for the patient comprehensive assessment. Now, one more case, the question was asked here: mortality prediction score, rational and role of ICU, same as the ICU scoring system that I have explained, but the question was framed in a little bit different way. Mortality prediction score. Every score that is used in nowadays is having some or other mortality prediction. So we all know that ICU patients are heterogeneous, high mortality risk. Objective tools help guide the prognosis, benchmarking, and research. So mortality prediction is actually estimating probability of death in our ICU patient. The rationality behind this mortality prediction model is standardized assessment of disease severity that would be helping in clinical decision making. Benchmark ICU performance, I have already told, this is one of the quality indicator nowadays being used in our ICUs. Risk stratification in trials and research, and sometimes it is helpful in family communication. If you know that my patient is having this mortality prediction model coming in the last stage, so you can pretty well document it in your clinical notes also, and that would be helpful if there is some medical legal issues coming. Now, what are the characteristic of ideal score? I have already told you. Easy to calculate. It has to be reproducible. High discrimination has to be there. A good calibration has to be there. Universally applicable and updatable. Broad categories already I have told, but yes, you can always write about physiology based, organ dysfunction wise, diagnosis or condition specific, and composite models. Now, just one more thing I can give you as a classification. There we have told about disease specific, organ specific, something like physiologic basis. Now here what you can write, one is first day scoring system, repetitive scoring system. That is again one other way of dividing or classifying the scoring system. First day is Apache, SAPS, and MPM. Repetitive SOFA, MODS, and LOTS. These are some of the timelines of different scoring system from 1980 till 2006 and above. Already explained Apache, SAPS, SOFA, MPM. I'm just skipping because just for the sake of completion, because these questions have come. So you should not be feeling nervous when you are getting little bit slight different question than what is actually you have read. Some ongoing scores that have now in process. Apache 4 is right now in modified stage. There is a SAPS L. There are certain condition specific scoring system now. SOFA for heart failure patients, and UK ICU database also they are having one score like ICNARC. Now strength of mortality scores already explained. These are benchmark, guides, triage, and prognosis discussions. Limitations do not replace the clinical judgment, need recalibration. Role in ICU practice, again, the examiner would definitely expect you should talk about research and clinical trials, administrative tools, so that you can use your resource, limited resource in some of the ICUs wisely, and quality has to be assured. And the daily practice should be prognosis estimation, family communication, and some of the high mortality diseases. You can use this as your helpful guide. Future direction, already told, machine learning, AI model, incorporation of biomarker, real-time EHR linked prediction system, and finally we should be reaching to the level of precision ICU care. Now 18th number question, ICU admission criteria. That was again one of the miscellaneous questions that was asked. Why we need admission criteria in ICU? Because ICU is a specialist unit for critically ill patients needing continuous monitoring and organ support. The purpose is early detection of deterioration, life-saving intervention have to be done, and multidisciplinary critical care. So the general principles of admission should be, when ward care is insufficient, you need to consider based on the severity of illness, reversibility of condition, need for invasive monitoring or advanced organ support. Ethical balance has to be there. Benefit versus burden. You cannot always keep a patient who is 90 plus with moribund, with some of the end stage malignancy and the frailty and some of the the things which cannot be reversed. So in that case, at least you should have a 25-year-old trauma patient who is in need of a bed, and you can allocate that resource to a patient where we can salvage some of the patients who are dying. Now, these are this is from the 2023 December as per the Government of Ministry and Family Welfare. This is intensive care unit admission and discharge criteria. I have taken the screenshot from that exact guideline that was published. You must have seen it also. So there are certain ICU admission criteria I want to know, because this is from the Ministry of Family Health Welfare. So NB also in the examination or your NMC, they they would be expecting that at least you should know about these 3, 3, 6, and 7 criteria. Should be ICU expenses trend published 2023 December. Now you can always differ ICU admission criteria based on certain the localization or the organ of the emergency. So let's start with the airway indication. I'm not going into detail, just giving you a brief structure you all know, but you can always in this way. Impending airway compromise, need for elective or prophylactic intubation, failed non-invasive airway protection, the patient is in the ward where you are unable to provide NIV. So these patients are definitely shifted to the ICU. Respiratory indication, mechanical ventilation cannot be provided in the ward. Severe hypoxemia, PaO2, FiO2 less than 200, hypercapnic failure despite oxygen therapy or NIV, severe asthma, COPD exacerbation, not responding to ward measures, circulatory again, hemodynamic instability requiring vasopressors or inotropes, persistent hypotension despite close monitoring. Some of the patients from the cardiac side, neurologic indication GCS less than equal to 8, where you need to protect the airway, status epilepticus requiring sedation, ventilation, raised ICP, head injury, stroke, meningitis, encephalitis, acute neuromuscular weakness, where you are suspecting that this patient will be aspirating or this patient will be retaining carbon dioxide or this patient can stop breathing in case of GBS, where there is ascending paralysis. Renal indication, acute kidney injury when the patient needs dialysis in unstable patient, severe acidosis, severe electrolyte derangement, potassium is very high with ECG changes, severe hypernatremia. You cannot monitor the sodium in the ward. Acute poisoning when the indication of RRT is there. Metabolic or endocrine indication, definitely decay patient with shock, altered sensorium, thyroid storm, myxedema, coma, severe lactic acidosis, tumor lysis syndrome. These are some of the very interesting and need of the hour indication where you need to shift the patient to the ICU. Sepsis and multi-organ dysfunction, again severe sepsis, septic shock, like no 2 or 3 vasopressors, MOD score more than equal to 2, organ support system, involvement is there, though maybe the burn is not that severe, but airway involvement is there, inhalational injury is there. So you need to shift the patient for the ICU. Massive transfusion protocol I have already told. As per the triage categories by Society of Critical Care Medicine, American Society, priority 1, priority 2, priority 3, priority 4. Priority 1 is a life-threatening condition needing active intervention, immediately shift to ICU. Priority 2 stable now, but yes, there is high chance of high risk of deterioration is there. Priority 3 critically ill with low chance of recovery like advanced malignancy, poor prognosis. And priority 4 moribund patient unlikely to benefit from ICU. So 3 and 4 you have to be a little bit like judicious in shifting this patient to the ICU. Discuss with the family, the goals of care have to be documented properly and there should be a shared decision making. Contraindications of this like ICU admission criteria, that you should be shifting any patient to the ICU. Terminal illness with no reversibility. Why to shift the patient to the ICU when you can provide palliative care and family should be at the bedside. Patients with advanced directive or DNR orders. Futile cases where you are expecting that the patient is dying in 24 to 48 hours and everything has been documented well, the family understands. End stage dementia, advanced metastatic cancer. So it should not be shifting shifted to the ICU where the risk benefit is actually tilting towards the risk more. Coming to the summary part, ICU admission guided by severity, reversibility, prognosis, and ethical principle. Balance the resources versus benefit in one of the paramount importance. You cannot like subject any patient to ICU and where the needy patient is not getting a bed. Now, the 19th number question, again, very important from infection control practice purpose, care bundles in ICU. So that was asked in the examination. So I would be discussing under certain headings. Critically ill patients are at high risk of complications due to invasive devices, organ dysfunction, and prolonged ICU stay. So variability in practice often leads to the worse outcome. So we don't know that Mr. X will be doing the same thing like Mr. Y, and maybe X ICU would be maintaining the same type of dedication like the Y ICU. So that's why we need to have some care bundles. That is a systematic approach to unify evidence-based care across the teams. So if it is at the middle of the night also or middle of the day also, weekend also, weekdays also, it would be provided important. It cannot be 10, 12. It cannot be also like not too much or like too less or too much. So that when performed together and reliably, so everything has to be done together and reliably, that would be leading to the better outcome than when implemented individually. So you cannot like justify that my therapy or my intervention is working or not when you are doing only one or two. If you are doing all the like bundle components together reliably, then only you can say whether your like intervention is working or not. Emphasis would be to have a collective impact than the individual effect. Example, VAP prevention bundle versus single intervention. Like if you are only going for head of bed elevation, then you will not get a good result than if you are going with all the VAP prevention bundles. Now the rationale behind these bundles are it improves safety, reduces complications, enhances patient outcomes, it standardizes the care delivery in complex ICU settings, reinforces teamwork and accountability, that you need to again and again reinforcing the bundle components, and it translates guidelines into daily bedside actions. So it's not only which is written in the guidelines, rather which is like workable principle in your ICU. Now the key features: limited number of intervention, 3 to 5. It cannot be too high, too much, or too less. Each intervention is supported by high quality evidence. Like everything has been studied well. You cannot add anything into the VAP or the CLAPSI bundle and say that yes, this is also a bundle component. No, it has to be supported by very good research. Literature is supporting that yes, if you are going with head of bed elevation, then definitely it has certain physiologic and pathophysiologic principles. It is easy to monitor and audit for quality improvement, something we can do regular auditing. So this has to be very simple one. It cannot be complicated. And all are non-compliance principle, like partial implementation is not equal to bundle compliance. Very clear. Now types of bundles in ICU, I hope everybody knows about it, but it can be divided again into prevention bundles, management bundles, procedural bundles, daily care bundles. Prevention bundle is aimed to reduce device related infections like VAP, CLAPSI, COUTI. Now, management bundles when you are trying to optimize some of the acute illness like sepsis, ARDS, AKI. Procedural bundle when you are doing some procedure but you want to have it foolproof, no complication like central line tracheostomy or bronchoscopy. Now, daily care bundle routine checklist based measure for ICU patient like fast talk BIDS, something like that. Now, I am just showing you some of the slides. Again, I am not expected to discuss VAP bundles also at this time. But yes, these are some of the things you should be having at the tip of your tongue, at least before going to the exam. I'm just showing you the slides. I'm not expected to explain the sepsis resuscitation bundle hour one. But in the examination, if you are getting a question, you are expected to write short notes or long notes exactly what is right now you are being seen, like no showing or shown, something like that. Within 6 to 12 hour, that is also again another bundle. ARDS ventilation bundle, daily ICU care bundle, first BIDS. Then what are the impact of bundles? Evidence shows that significant reduction in the VAP, CLAPSI or COUTI rate is there. Mortality in sepsis and ARDS has also reduced. and improves compliances with the best practices, strengthen multidisciplinary teamwork, culture of safety, and forms the backbone of ICU quality improvement programs. Now, the take home message: care bundles are small, evidence based, practical steps applied consistently. It requires full compliance for maximum benefit, widely applied in ICU for infection prevention, sepsis, ARDS, and daily care. Bundles transform guidelines into bedside actions, saving lives daily. Now, I think the last question we are finishing, and you are here today. So you want all of them, this or not? The last question: biomarkers in critical care. How many of you are with me? Yes. I know everybody will be saying, because this is the last question. Why to take the blame that yes, sir, we have not given one thumbs up and you have stopped the class because of our little bit laziness. Okay. I know you will be giving 3, 4 thumbs up together. Okay. So the question related to biomarkers in critical care can be asked in a different way. It will not be straightforward biomarkers in critical care. Rather, it can be asked in a clinical wise also, like a 55-year male with septic shock, rising lactate, and procalcitonin. How would biomarkers guide your management? This can be also a clinical question, which would be just you can say the replacing the straightforward question. Now the headings: introduction, what is a biomarker, ideal characteristic of ICU biomarker, different biomarkers, how to apply smartly clinically, limitations, take home. Now, if you will be just going with the introduction, what is a biomarker? I have already told in the question before when I was explaining about AKI. Biomarker is a measurable indicator of a normal biologic process, pathogenic process, or response to therapy. Remember what I am actually trying to highlight here. It is actually something indicating the biologic process, pathogenic process, and also if you are giving some therapy, how your body or your patient is actually responding. That also you need to see through a biomarker. In critical care, laboratory or imaging based measurable parameter that guides diagnosis, prognosis, monitoring, and therapeutic decision. So a lot of things you need to know, or that would be helpful: diagnosis, prognosis, monitoring, or therapeutic decision. Why important in ICU? ICU patients are complex, unstable, and time sensitive. Biomarkers provide objective, rapid, reproducible data beyond clinical science, and that help in early diagnosis, risk stratification, therapeutic guidance, monitoring response, and outcome prediction. So this is something which will be definitely helpful to you. Now, if we'll be just going with characteristic of ideal biomarker, you can see here high intensity, high sensitivity, increased microbial concentration after heart attack. There should be rapid release to allow the early diagnosis, long half-life to allow the late diagnosis as well. Then high specificity. Its absence in tissues other than microdel 1. Its absence in healthy patient, because agent is how it exclude MI or something like that. Assay related characteristic: good cost effective ratio, easy to assay, short processing time. It is not like it will be taking 9 days, 7 days, 5 days to just get the report. And high precision, and this should be also helpful in guiding the therapy and predicting the prognosis. Already discussed, rapid turnaround correlates with disease severity and outcome, guides therapy decision, cost effective, reproducible, and validated. Now, some of the biomarkers as per the disease itself: infection and sepsis biomarker, CRP, procalcitonin, IL-6, everything you need. What is the utility? Both in CRP, procalcitonin, strength, clinical use. Is there any landmark trial that have used this biomarker, and how you are actually utilizing or using this in the bedside care? IL-6 and TNF alpha, like elevated in cytokine storm, severe sepsis, COVID-19, CAR T therapy also, IL-6 and TNF alpha is used as a biomarker. And this is useful as a adjunctive marker for the prognosis, severity stratification, and to identify patients for the extracorporeal cytokine removal therapy. Now, IL-6 and TNF alpha the again infection sepsis biomarker 2, pre-sepsin, pro-adrenomedulin, and you can see here this is soluble CD14 subtype released by monocytes in response to bacterial infection. It rises early in sepsis before the other the parameters and the biomarkers start rising. It correlates with ICU severity score and mortality. It is used as a prognostic marker. Proadrenomedulin is a stable fragment of adrenomedulin, a vasodilatory peptide involved in endothelial function. It is elevated in septic shock and severe infection. It is a strong predictor of organ dysfunction, vasopressor need, and mortality. Clinical utility that will be helpful in early recognition of sepsis, help in risk stratification and prognostication. And again, if you complement it with CRP and procalcitonin, maybe a better antibiotic stewardship program and mortality prediction can be there in our ICU care. Now coming to the cardiac biomarkers, again, troponin, high sensitive troponin T, troponin I, BNP, NT-proBNP, these are some of the biomarkers along with ST2, galectin 3, these are novel heart failure risk markers which are emerging. Now kidney marker, I have already told, not going into detail. Liver injury, conventional is bilirubin, ALT, AST, INR, but they are late indicator. Now they are going into having some newer biomarkers like microRNA 122, keratin 18 fragments, ammonia. Now neurologic, neuron-specific enolase, S100B protein, GFAP, which is glial fibrillary acidic protein, and the role also we can prognosticate in hypoxic ischemic encephalopathy. So this is the upcoming biomarker that can help in the prognostication and also the therapeutic decisions. Now, so respiratory ARDS biomarker, this can be asked as a short note also because this is helpful in having the phenotypes and endotypes also. SPD, which is surfactant protein D, these are marker of alveolar epithelial injury elevated in ARDS and correlated with severity. They may help to distinguish ARDS from cardiogenic pulmonary edema. The next one is a soluble receptor for the advanced glycation end products. They are released from the damaged alveolar epithelial cells, reflects epithelial barrier dysfunction in ARDS. Higher levels, if you are getting, that would be linked with the worse outcomes and ventilator induced lung injury. Proadrenomedulin, I have already told, this is again one just like sepsis, systemic marker of endothelial dysfunction, elevated in sepsis related lung injury, strong prognostic value in for the mortality and progression of ARDS, clinical relevance, currently research use but not routine, and useful in phenotypic ARDS, like hyperinflammatory versus hypoinflammatory subgroups. And they may guide precision medicine, which is in upcoming in our future trials. Hematology and coagulation biomarkers, D dimer, thrombin, antithrombin coagulation, thromboelastography, like TEG and ROTEM, where you can get the global coagulation assessment, whether you want to give FFP, cryo, platelet, or do nothing. So that also you can give through the take. Metabolic or stress biomarker, serum lactate, cortisol, ACTH stimulation test, mid-regional proadrenomedulin. These are something which are upcoming. On emerging omics based biomarker like circulating cell-free DNA, exosomes, microRNA. These are early detection of organ failure, proteomics, metabolomics, transcriptomics. All these omics towards the personalized ICU care. And then everything, all these biomarkers can be combined with AI-based biomarker panel for the precision medicine. Now, what are the limitation of the biomarkers? They are costly. We do not have this in every center. Assay variability between labs to labs. We don't know that this lab has this cutoff, that lab has different cutoff. Influence of different comorbidities, it is not straightforward. The heart failure patient may be having some kidney problem, liver problem. So the biomarkers can talk between these organs also, and it should not it should complement, not replace the clinical assessment. Now the take home message that no single biomarker is perfect. Panels plus serial trends are the best strategy, and the biomarkers are useful for early diagnosis, prognostication, and therapy antibiotics. So I know we have tried and we want to have the time on the result day when we will be glad to inform you if we get the result before you are getting the result that you passed all, and congratulations to all of you. And I hope that day all of our efforts for last 2 weeks, Friday, Saturday, Sunday, Friday, Saturday, Sunday, that will be fruitful. And maybe you will be running after finishing your final exam. If you go through all these videos in the next upcoming 25 days, you will be running after writing the 3R, 3R, 3R paper for continuously 3 days, and you will be throwing, don't throw the papers, otherwise your answers will not be calculated. Thank you very much for your patient listening. I've just crossed 3 hours non-stop, and I hope you have been benefited to a great extent after 6 days of extensive discussion. Neuro part is pending, so Dr. Sanant would be recording this and sharing with you maybe in couple of days. Thank you very much. If you have anything you want to share with us, please post in this group, post in the WhatsApp group also. We will be helping you out. It's not the end. Maybe our faculties would be with us in the group also. They would be guiding you. If you have any problem, you have anything you want to get from us as a note or like some like an articles, short notes, somebody would be definitely helping you. Our whole effort will be complete if you successfully complete your exam, at least the first part, like that you will be appearing the exam. And definitely in the practical also, I would be assuring you we are coming up with on-site practical course also, and also again similar to this real type simulated table vivas and clinical cases. Keep like stay tuned with all of us, and wish you all the best. Thank you very much. Anything
The recording
anybody
has
wants to
stopped.
post, they can like in between like if we have 1 minute time,